Hello, I'm Dr. Oksana Baltarowicz from the Jefferson Ultrasound Research and Education Institute at Thomas Jefferson University in Philadelphia, and I'll be speaking about liver sonography. We're going to discuss the normal liver. We'll talk about Doppler of the hepatic vessels. We'll talk a little bit about diffuse liver disease patterns, then move into portal hypertension and focal liver masses. Now, the normal liver, when we look at it sonographically, we pay attention to the size of the liver, the shape of the liver, the echogenicity, and the echotexture. The echogenicity and echotexture are two different things that we talk about. Echogenicity has to do with the level of brightness of the liver parenchyma, and we use portal vein walls to compare that. And texture has more to do with the homogeneity of the liver. The liver is very susceptible to technique. We have to make sure that we have a nice smooth TGC curve. We want to make sure that the penetration goes all the way back to the diaphragm. Here is this curvilinear bright structure. We would like to have the vessel wall, vessel lumens clear of extraneous echoes. And when we scan the liver, we want to make sure that we clear all of the margins of the liver. In this case here, we have very good technique coming through this side of the image. We have nice echogenicity, clear vessels. We get through to the diaphragm. But here we seem to have some kind of division, some kind of dropout of sound. So we would have to correct that, either apply better pressure on the abdominal wall and try to even out the echogenicity here of the liver. One thing that's very important, and this is important for all structures that we image in ultrasound, we always want to be able to see at least 2 to 3 centimeters beyond the margin of any organ so that we can exclude possibility of any exophytic masses or any kind of adjacent masses that can affect the organ. In this case here, this is the liver. The inferior edge of the liver would be here, but because we were trying to clear 2 to 3 centimeters beyond the margin, we noticed that there was a mass hanging off the inferior edge of the liver. We would have never seen it if we would have stopped our picture at the inferior margin of the liver. And if you, by the way, this was a hepatocellular carcinoma, a hepatoma, 5 centimeter hepatoma hanging off the margin of the liver. And if you think that this is an anecdotal or unusual case, here's another case that we had fairly recently. Hanging from the inferior margin of the liver was this large mass, another hepatocellular carcinoma hepatoma, and that's the right kidney here. Now, as you scan the abdomen, you should always have in mind the different parenchymal organ echogenicities and have a kind of a relative scale in your mind of the different echogenicities. The renal medulla is the least echogenic of all the parts of upper abdominal organs. It is much less echogenic than the cortex of the kidney, which in turn is less than or can be equal to echogenicity of the liver. We used to think that equal to the liver was abnormal, but now we know that especially in young people, cortical echogenicity could be equal to liver echogenicity. Now, we also know that the liver is less echogenic than the spleen, but that's something difficult to ascertain because usually the liver and the spleen are not on the same picture, and you would really need them to be side by side to tell which one is more or less echogenic. That can happen sometimes. Now, this is a scan of the left upper quadrant, and we're looking at the spleen here, and we notice that the spleen has sort of a double shade, has a darker area and a brighter area, almost like a double shaded spleen. However, we also note that there are some little vessels in this part of the spleen, not so much seen here. And then we realize that this is liver. This is the left lobe of the liver going all the way across to the left, hugging the spleen, and so that it looks like it's a part of the spleen, and it isn't. So this is liver, which is indeed less echogenic than spleen. And this is not to be mistaken for a subcapsular hematoma. Sometimes this is mistaken in the spleen. So there's our proof. Now, the liver is also less echogenic or equal in echogenicity to the pancreas. Pancreas usually more echogenic, but they can be equal, especially in younger people. So here is pancreas, and here's the left lobe of the liver, and they're fairly equal. When we compare echogenicities, we should be comparing at a similar depth of the beam. Oh, and one more thing here, that the pancreas itself is less echogenic than retroperitoneal fat, which is hyperechoic, and also less echogenic than the renal sinus echoes. So renal sinus echoes and the retroperitoneal fat are hyperechoic and the most echogenic of all of these parenchymal organs. When we look at the liver parenchyma itself, we realize that there are little holes throughout the liver. Sometimes we see little cylindrical shapes, and some of them have bright walls and some of them do not. So then we have to figure out what we're looking at. When we do ultrasound sonographically, the vessels that are visible within the parenchyma of the liver are the portal vein walls and the hepatic veins. The hepatic arteries and the bile ducts typically are not visible within the parenchyma of the liver unless they are abnormally dilated. We can see them in the porta hepatis, which is just outside the liver, but as far as being inside the liver, we only see these two vessels. If you think about the liver, you realize that there are 4 tubular systems that go throughout the liver. We have the portal venous system, the hepatic arterial system, and the bile ducts. These are intimately related at the porta hepatis. They join together as partners in the portal triads, and they stay together throughout their entire branching throughout the liver. The 4th tubular system is the hepatic veins. Now, the hepatic veins drain the liver superiorly towards the IVC, inferior vena cava, and they stand alone. They do not have anything associated with them, and that becomes important to us. We'll see in a minute. So the portal triads then are maintained throughout the liver, and that's partially, that is what is causing this reflectivity of the walls. Portal veins have bright echogenic walls, and we use this for comparison of parenchymal echogenicity. What happens is the main portal vein, it enters the liver through the porta hepatis and almost immediately splits into a right and left portal vein. The largest portal veins divide horizontally approximately in the middle of the liver, and they supply lobes and segments, and they carry blood flow into the liver. Now, the reason that portal veins have bright walls is, number one, because of the portal triads, which is the portal vein, the little hepatic artery, and the bile duct. So all we're seeing here is the portal vein. The little artery and duct are small, so they just provide reflectivity. We also have some reflectivity from Glisson's capsule, from the little lymphatics and nerves and connective tissue around the portal triads. So that's why portal veins have bright walls. Hepatic veins do not. And why is that? Well, it's a matter of contrast. The hepatic veins have imperceptible margins. They actually have walls, but we just don't see them. If we look at what they look like by configuration, they're more vertically oriented. They enlarge towards the inferior vena cava, and they actually have sort of an umbrella configuration where the spokes of the umbrella come together superiorly, and the the rest of the spokes drop down throughout the liver. Now these veins are found between lobes and segments, so we use them as anatomic dividers, and they carry blood flow out of the liver. They do not have any other adjacent little structures, therefore we do not perceive their walls. Here's an umbrella, just for your imagination. You can see that the spokes of the umbrella come together at the top, which is here. So if we take a slice through the very superior portions of the liver, we can see longitudinal orientation of the hepatic veins. Now, as the veins drop down and we take a transverse section lower, these veins will be cut and look as like circles. So here is the middle hepatic vein, and here is the right hepatic vein, showing us lower in the liver as a cross-sectional configuration, cross-section, which we would be doing through the spokes of the umbrella. Now, having said that, we always find exceptions to the rule. Now, I just told you that portal veins have bright walls, and now all of a sudden I'm showing you a picture of a portal vein that does not have bright walls. Some portal veins may not show echogenic walls because they become parallel with the beam. Parallel is the worst angle for B-scan. So we're losing resolution, and we simply lose resolution of this portal vein wall. Here, on the other hand, are hepatic veins. Now, I just told you that hepatic veins do not have bright walls, and all of a sudden I'm showing you a big hepatic vein with bright walls. Well, it is true that some hepatic veins may show echogenic walls. That's because they're large veins and they have thick walls, so they do have reflectivity, but also in this case, this vein is completely perpendicular to the sound beam, and that's the best angle for B scanning, therefore we see the hepatic vein wall. So two exceptions to the rule explained by angles. So we have some now a little bit of insight into the anatomic landmarks on transverse scans of the liver, and let's look at these. In high portions in the upper parts of the liver, we see large hepatic veins coming together into the inferior vena cava. In the mid portions of the liver, we see the portal veins kind of horizontally situated, the left being a little higher than the right, but nonetheless with the bright walls. That we know now that we're in the middle of the liver. If we look at transverse lower sections of the liver, we don't see any big veins. We see an echogenic line here. This would be where the falciform ligament comes in, and the umbilical fissure, the fissure for ligamentum teres, and that will mark the lower parts of the liver for us. So we'll know if we're high, mid, or low in the liver. Now, since I mentioned ligamentum teres, let's talk about that. Ligamentum teres means round ligament. We have different round ligaments in our body, but this is the round ligament in the liver, which is the obliterated fetal remnant of the umbilical vein. So the fetal umbilical vein, once the fetus is born, there's no need for that vein, so the vein clamps down and becomes almost like a thick fibrous kind of cord located within a fissure, within the fissure for ligamentum teres. So the fissure has a little fat in it. That's what gives us bright reflectivity. So somewhere in here is the collapsed, obliterated ligamentum teres, surrounded by echogenic fat. This is a transverse section of the left lobe, and that becomes a divider of the left lobe into medial and lateral segments on a transverse scan. Also notice that there's some shadowing behind this, and the reason that it shadows is not because it's calcified, and this should not be mistaken for a calcified mass, but it's because the ultrasound beam strikes this at 90 degrees, which is directly striking this fibrous cord, and that shadows behind it. As soon as you change the angle a little bit, that shadowing will disappear. If it was truly calcified, there would be shadowing no matter what angle you come from. The fetal umbilical vein came into the umbilical segment of the left portal vein. We can see this when we cut the liver sagittally. At this precise level, we are now taking a sagittal image, and we can see the brightness of the fat surrounding the ligamentum teres within this umbilical fissure, and notice that it goes directly into the umbilical segment of the left portal vein. So that's where the fetal umbilical vein enters the portal system. This vein may recanalize in portal hypertension, and once again, it is a divider of the left lobe. So while I mention fetal remnants, I'll mention the ligamentum venosum. Ligamentum venosum is the obliterated fetal remnant of the ductus venosus. The ductus venosus carried blood out of the liver. In the fetal circulation, blood entered the liver, but there was no reason to stay in the liver, so there's a ductus venosus that right away carries the blood out towards the inferior vena cava and towards the fetal heart. That ductus collapses once the fetus is born, and it lies within the fissure for ligamentum venosum. Now, here on a sagittal section, that fissure appears to be a bright line, which is located between the caudate lobe and the left lobe of the liver. Behind the caudate lobe is the inferior vena cava. Okay? When we turn 90 degrees and do a transverse section, the fissure appears here again as a bright echogenic line. Somewhere in here, we don't know where, is the collapsed ductus venosus, probably closer here to the umbilical segment of the portal vein. So it would have come out, and on higher sections it will enter the inferior vena cava. Notice that that fissure is a broad plane. It's a line on transverse, it's a line on sagittal, so it is not a linear kind of fissure, but it's rather fairly broad. And that is our divider for caudate lobe from left lobe of the liver. This vein does not recanalize in adults. You don't see this vein ever again, except perhaps in the very small neonate that has umbilical vein catheters. You might see it, but once the child grows, this vein is obliterated and does not recanalize in portal hypertension. I mentioned the caudate lobe. When you think of caudate, you think of something caudal, but yet that's not really what this means. Caudate in Latin means tail. So the caudate lobe is like the stubby tail of a dog. Here's a little puppy here. And it's actually one of the more cranial parts of the liver. Now we pay attention to the caudate lobe because the caudate lobe is functionally an autonomous segment, and it has often been said that it is spared in liver disease. It has its own blood supply. It takes blood supply from the right and the left portal veins, and you can prove this to yourself if you carefully scan. If you have a good patient, a thin patient, and you look around the portal veins, you can see small branches entering the caudate lobe, and you can also see venous drainage, separate venous drainage directly into the inferior vena cava. And supposedly that drainage here is what helps to protect the caudate from other diseases. Now, another thing you should know about the caudate is that it itself can look like a mass sometimes. We call that a pseudomass. Here's a section of the liver, and it looks like there's a mass in the caudate. So I would caution you, this is an artifact. If you ever think you see a mass in the caudate, ask yourself first, are you sure that that's not a pseudomass? What happens with the pseudomass, the ultrasound beam comes through the portal structures and becomes attenuated. So it partially drops out, giving it the appearance of a hypoechoic mass. if you move off of this porta and come in with the beam from different angles, you will see that this is not truly a mass. That's why it's a pseudomass. Also, the caudate lobe can become enlarged, especially with cirrhosis. We can actually measure that. This is described in the literature. And the caudate is enlarged when a certain ratio of the caudate to the right lobe is enlarged. So what we would do, we would take a transverse section of the liver. We would take the medial margin of the caudate and the lateral margin as the lateral margin of the portal vein. That we would measure as the width of the caudate lobe, and the rest of it is the width of the right lobe. Then we would take a ratio of C over R, or caudate over right lobe, and if the ratio is over 0.65, that becomes an enlarged caudate. If the ratio is over 0.73 or so, that's very specific for cirrhosis of the liver. But you have to have the whole transverse scan on one picture. It's easier to do on CT. So now that we've talked about the hepatic and the portal veins, this leads us into the basis of modern lobar and segmental anatomy. This is the basis of surgical procedures nowadays. This is the reason why surgeons can go in and remove a subsegment of the liver, let's say a metastasis in a subsegment, and not harm other parts of the liver. This is possible because of now our understanding of this lobar and segmental anatomy. Now, we've already told you that hepatic veins drain peripherally, so they are interlobar and intersegmental, therefore we use them as dividers. Portal veins feed the segments centrally, so they are intralobar, intrasegmental, and we use them to name the segments. So here we'll start with the hepatic veins as dividers. Here's a transverse section high in the liver, and we see the three hepatic veins coming together at the inferior vena cava. The middle hepatic vein divides the liver into right lobe and left lobe. The left hepatic vein divides the left lobe into medial and lateral segments. But this only occurs in the high parts, cranial parts of the liver. That's where the hepatic vein is. The right hepatic vein divides the right lobe into anterior and posterior sections. Okay, so now we have right and left lobes divided. Now the portal veins, they feed the segments, we name the segments, and they define the segments. Okay, so here we have a portal vein with bright walls. The main portal vein just came into the liver and immediately divided into a right portal vein, which is rather short because it suddenly splits into the anterior segment and the posterior segment. Okay, so this is the division of the right portal vein. So here is the right anterior segment, and here is the right posterior segment of the liver. And notice, here's our right hepatic vein, and here's our middle hepatic vein. This plane of separation, middle hepatic vein in line with the inferior vena cava, is our divider of the liver into right lobe and left lobe. And the right lobe is further subdivided into anterior and posterior segments. The left lobe has its own divisions. Now here, after the vein split, the main portal vein, the left portal vein has a longer course. It travels towards the left lobe and suddenly takes an abrupt anterior turn. This is the only part of the portal system that suddenly aims anteriorly. Okay, that's the umbilical segment of the left portal vein. And it sends off lateral branches and medial branches. So this would be the medial segment of the left lobe, and these are lateral segments of the left lobe. This is used as a divider. This is the only part of the portal venous system that is used as a divider. I told you hepatic veins are dividers, but this is the only part of the portal system that's used as a divider in the midsection of the liver. Okay? That's our division of middle hepatic vein dividing right and left lobes. So here we have our subdivisions on subdivisions in this case of the left lobe. I've already mentioned 3. I'd like to put them all together for you. So we have dividers of the left lobe into medial and lateral segments. High up on high sections, it's the left hepatic vein that divides the left lobe into medial and lateral segments. In the middle of the liver, it's the umbilical segment of the left portal vein, which divides the liver into medial and lateral segments. And lower down, where there are no big veins, we have the echogenic falciform ligament coming in and the umbilical fissure dividing the liver into dividing the left lobe into medial and lateral segments. So superior, mid, and inferior parts. Another point that I'd like to bring up here is about the division of the main portal vein. Precisely where the main portal vein comes in and splits, right in that line here, we can use that as another anatomic divider of the liver. If we look at the liver frontally or en face, we'll see that part of the portal vein divides the liver into superior and inferior segments. However, so that's on coronal sections. If we look transversely, we slice up the liver, and we find that division in the middle of the liver, that will divide further into anterior and posterior segments. So the same vein, it's a tubular structure, can divide things into superior and inferior as well as anterior and posterior. So it becomes useful. All of that put together helps us subdivide the liver into subsegments, which is useful, very useful for the surgeon, because if we can place a lesion in a specific segment, the surgeon can then go after that lesion and remove it without harming other vascular supplied segments of the liver. This is the basis of the Quinault system, a French system that divides the liver into 8 segments. If we look at the liver from the front, this would be the left anterior lateral segment. Behind it would be the left posterior lateral segment. Way in the back is the caudate lobe. That's always segment 1 in any system of classification because it kind of stands alone, so we get it out of the way. Then we see the medial segments. We have a superior and inferior medial subsegment. And when we get to the right lobe, here we have anterior superior in blue, and we have anterior inferior in purple. For you to see the back, I've rotated this liver slightly. So here's anterior superior, anterior inferior. In the back is posterior inferior and posterior superior. These segments are labeled 5, 6, 7, and 8. It's kind of an unusual system. It kind of twists around like a figure 8. Nonetheless, each segment has a number. Now, I don't think that you should learn all of these segments with numbers because you have to know what your surgeon uses. Your surgeon may not use this classification. But if you divide and explain that it's left posterolateral or right posterior superior, they will know then which part of the liver the lesion is in. So here's a little quiz. Name the subsegment with the cyst. Okay, this is a transverse scan of the liver. So where would you place this cyst? What subsegment? This is transverse, and here's a sagittal scan. Okay, well, I hope that you were able to see that this is the middle hepatic vein, so this is in the right lobe. And this is the right hepatic vein, so that's in the anterior segment of the right lobe. And it's up high by the large hepatic veins, so it's in the anterior superior part of the right lobe, which is segment 8. And that is confirmed here on the sagittal where this cyst is high up. sagittally rather than in the lower parts of the liver. So then you can tell, you can precisely locate this lesion. Let's look a little bit at the portal veins. For this we have to talk about the Doppler a little bit, because nowadays we do more and more Doppler. In a normal main portal vein we have continuous forward flow. The liver is always available for detoxification of substances, anything that you eat, anything, any breakdown products from the spleen, the gut, etc. So it's constant forward flow with a low velocity. If you did velocities, usually they're 15 to 28 or 30 centimeters per second. The flow is into the liver, shown here on this color Doppler. Red means flow towards, so we have flow towards the liver. It's an undulating pattern which reflects respiratory variation and may reflect cardiac variation. It's a slightly turbulent, rough, low rumble kind of flow. That's because it's located between two capillary beds, between the mesenteric venous system and the hepatic venous system. What's abnormal? Well, abnormal is when that flow becomes too pulsatile. It may then start resembling hepatic vein pulsatility, and that would mean that there's elevated right heart pressures and that there's transmission of pressure through the sinusoids into the veins. We can see this with tricuspid regurgitation. We can see it with moderate to severe right heart failure or pericarditis. The exception would be in the young child, where the liver is so soft and pliable that it can actually transmit cardiac pulsations and central venous pulsations from the heart. Here is an abnormal pattern of a main portal vein. Suddenly it becomes too flat, very flat and continuous flow with loss of that undulating pattern, and that's what we'd see with cirrhosis and hepatic fibrosis, where the liver becomes stiff and we lose that undulation. The hepatic artery, now let's look at the hepatic artery. The hepatic artery typically has a very rapid systolic acceleration. It's a nice arterial pattern. It has continuous forward flow of blood into the liver throughout the cardiac cycle. So it has a low resistance pattern. In other words, fairly high diastolic flow, because blood freely enters the liver. It is always in the same direction as the main portal vein flow. So on color Doppler, these two vessels, the artery and the main portal vein, are always the same color. So if you set your color map with red, meaning towards the transducer, both will be red. If you turned it blue, as meaning towards the transducer, both should be blue. But you should not have one red and one blue, because of course this has nothing to do with oxygenation. It's direction. It's also interesting that the portal vein and the hepatic artery sort of have a mutual understanding between themselves. The portal vein carries 70 to 80% of the blood into the liver, whereas the hepatic artery only brings in 20 to 30% of the blood flow. But the artery brings in the fresh oxygenated flow, but the portal vein brings in deoxygenated flow from the splenomesenteric system. However, it's carrying a lot of flow. And there is a certain homeostatic mechanism between the portal vein and the artery. So if the portal vein flow decreases, there's a signal given to the artery to increase blood flow. So as a liver becomes sicker and develops more cirrhosis and blood flow cannot come in through the portal system, the arteries tend to enlarge to bring in more flow. Okay, so you saw the normal waveform. Now here's an abnormal waveform. The waveform becomes abnormal when the resistance becomes increased and diastolic flow drops. So we see such a pattern after eating, postprandial. We also see this with portal hypertension, more resistance in the liver, and more importantly these days, transplant rejection. We will pay attention to the arterial waveform. Now, another way that the artery has abnormal Doppler is post-liver transplant. That's when it becomes important to us. If we see a tardus parvus waveform after liver transplant, this is an abnormal finding. We would see low upstroke and fairly low velocity, which means that proportionately the diastolic flow is elevated. So we have a prolonged systolic acceleration time and then this tardus parvus waveform. What it means is that there is a hepatic artery stenosis, anastomosis. There's an anastomotic stenosis post-operatively. So we are not seeing the flow through the stenosis itself, but we are seeing the flow downstream from the stenosis when the flow has lost energy and is trying to relaminarize and is weak. And that's why we get the tardus parvus syndrome. So we don't actually see the stenosis, we just see the effect of the stenosis downstream in a transplant. Now let's look at the hepatic veins. Normally, the hepatic veins drain towards the heart. That's why they're registered here in blue, away from the transducer. And on the spectral, they are also registered away, usually below the baseline, towards the transducer where we have systole, diastole, but we have above the baseline when we have the atrial kick. So we have systole, diastole, kick, systole, diastole, kick. The normal Doppler here, the reason for this pulsatility is because it reflects respiratory phases and variations in central venous pressure that is transmitted from the right atrium. It also reflects the compliance of the liver parenchyma, giving us this triphasic waveform, systole, diastole, kick. Be careful though, because deep inspiration or Valsalva may reduce this pulsatility and dampen it, causing you to think there's a problem. So the waveform becomes abnormal when we lose that triphasic flow. When we lose that, we know that there's elevated right heart pressure. We lose the oscillations or the amplitudes. We can actually lose the atrial kick. We lose that first, and then the whole waveform starts to be more dampened, eventually turning into a monophasic abnormal waveform that is flattened and actually almost resembles a portal vein flow. We call this portalization of hepatic venous flow. So it should be a nice pulsatile pattern, and all of a sudden now it's flow. It's because the liver is stiff, the liver is non-compliant, and does not allow this wave to be reflected in the vessels. So now let's talk about sonographic liver patterns. There are basically three patterns in the liver: the normal pattern, the centrilobular pattern, and the fatty fibrotic pattern. We already discussed the normal pattern. Now there's the centrilobular and the fatty fibrotic. If you look at it closely, this one has too many portal vein walls. This one doesn't have any, and let's talk about the reason for that. In the centrilobular pattern, what happens is the liver is edematous, so that the parenchymal cells, the sinusoids, the hepatic cells become edematous, increase in water, drop their echogenicity. Okay? And that makes the portal vein wall stand out, giving it a starry night appearance. So you have these bright walls standing out in a dark background of the night sky. So what we see increased brightness and of the portal vein walls, and we seem to have more portal vein walls. Now the liver does not make more portal veins, it's just that we see them because now we have more contrast. This pattern is seen with acute hepatitis, also seen with acute right heart failure. You may see it with infiltrative diseases of leukemia and lymphoma. We used to see it with toxic shock syndrome, but we don't see that much anymore. And we can see it with 2% of normal cases. And the 2% of normals are usually the young, thin adolescents, maybe 15 to 20 years old. They're so easy to scan and see so well that they look abnormal, and that's easy to tell. The patient is healthy. There's no liver function test abnormalities, so those would be normals. Beyond that, we have to be cautious and rule out liver disease. I would like to bring up fulminant hepatic failure, because this is something that's very serious but could easily be dismissed or misdiagnosed. You will not see this often, but when you see this, you should think of fulminant acute hepatic failure and liver necrosis. What you'll see is areas, patchy areas of decreased echogenicity with prominent portal vein walls, and areas that look normal. They look echogenic, but they're actually normal areas of liver. You look back at these, this is the starry night pattern reflecting acute edema or necrosis, and these are areas of normal or regenerated liver. So they come in patchy areas. This is a case that we recently had of a 22-year-old man who came in with jaundice, and we saw areas of the liver that had increased portal vein brightness, and we thought that that looked like acute hepatitis, yet other areas of his liver seemed to be normal. He did have jaundice, and he was not that sick. However, his bilirubin was close to 30. He eventually got up to 30 in the hospital. And he became so sick that he ended up with a liver transplant. So what happened in this case? It turned out that he was using herbs, certain herbs for bodybuilding, and apparently developed some kind of toxic effect from these herbs, and developed liver failure and ended up with a liver transplant. I have seen such situations happen. One case was a sulfa drug reaction, a woman who was on sulfa drugs for bladder infection, who came in as an outpatient and had this appearance. So we thought that something was very unusual and wrong. We sent her to the emergency room, and after I followed her up in 3 weeks, I found out that she too went into liver failure and had a liver transplant from sulfa drug reaction. Another patient that I had, that I recall with this pattern, was a 34-year-old woman who was weak, a little bit jaundiced, and I thought also outpatient setting, and I thought, gee, this liver, something's very wrong. I sent her to the emergency room, and on follow-up I found out that within 24 hours she was dead. Autopsy revealed that she went into heart failure. She had lupus myocarditis and lupus hepatitis and developed this acute fulminant failure. So these are unusual cases, nonetheless serious, and we should not dismiss such an appearance. If you're not sure, if it doesn't look like it matches the clinical picture, we should send the patient right away for evaluation. The fatty fibrotic pattern is opposite. We have increased echogenicity of parenchyma. There's some kind of infiltration with fat or fibrosis going on in the liver, which increases the echogenicity high enough that it matches the portal vein walls, and the contrast is lost. Therefore, we do not see the echogenic portal vein walls. In this pattern, we look at the echogenicity, that's increased, but then we have to look now at the echo texture. It could be a smooth, homogeneous echo texture of the parenchyma, or could be heterogeneous or coarse. Sometimes we see sound attenuation, and this type of pattern is usually seen with fatty infiltration, but also seen with chronic hepatitis and cirrhosis. So here's the fatty fibrotic pattern with the homogeneous echo texture. Here's the fatty fibrotic pattern, loss of portal vein walls, with the heterogeneous pattern. Notice we almost see little tiny rounded masses throughout, a little bit nodular. That's what gives it this heterogeneous appearance. Let's look at the fatty liver. Fatty livers are of this pattern, echogenic, loss of portal vein walls. When it's a very pronounced case, there's so much attenuation that we can't even image the hemidiaphragm, as we have in this case. We've tried to increase the TGC curve posteriorly, and we cannot fill in with echoes. Notice how nice and homogeneous this pattern is. Now, fat can do two things focally. We can have focal fatty infiltration, and we can have focal fatty sparing. Okay, here's focal fatty infiltration, where we have areas of fat. Now, the fat part is echogenic. Fat areas of fatty infiltration interdigitating between areas of normal liver parenchyma. And we also can have focal fatty sparing. Here are areas of normal liver not affected by the fatty infiltration. You look carefully, you see little vessels inside. There's no distortion. This is a completely normal little liver pattern. That's areas of normal liver spared. These can possibly be confused with liver masses. However, they occur in a very typical location around large portal veins, around fissures, and subcapsular. So we tend to look in those regions, and we look for internal architecture and see that it's not distorted. Cirrhosis has this fatty fibrotic pattern. Now, when we make a diagnosis of cirrhosis, we look for heterogeneous echo texture, so coarse sometimes that it looks moth-eaten, and it's from these little islands of regenerated tissue mixed with diseased tissue that causes this heterogeneous pattern. The livers tend to be small and shrunken. They have a nodular surface. Often there's ascites to help us delineate the surface. And these are the livers where we can see the enlarged caudate. So if you see an enlarged caudate to right lobe ratio, and if it's over 0.73, that's a 99% specificity for cirrhosis. It's not sensitive, but it is specific. Here's a cirrhotic liver. Try to imagine what you would see on ultrasound. You see these nodular areas of regeneration all throughout. In between are these fibrotic bands, and that gives this nodular appearance, sometimes micronodular, sometimes the nodules are bigger, and sometimes macronodular appearance. Look at these tiny little islands of regeneration inside the liver, which cause vascular channel disruption, etc. So when we see a cirrhotic liver on ultrasound, we then have to right away look for clues of portal hypertension. So with portal hypertension, the liver is diseased. The liver parenchyma develops resistance to blood flow. This increases the portal venous pressure. Eventually, the portal flow will slow down, and it will reverse, and flow will actually be going away from the liver, hepatofugal, and there's then increased risk of bleeding because collateral vessels open up. The ultrasound findings of portal hypertension include ascites, a dilated main portal vein, splenic vein, or spiromesenteric vein. What is a dilated portal vein? Well, a portal vein bigger than 13 millimeters in diameter we consider dilated. A splenic vein or superior mesenteric vein centrally, when it measures more than 10 millimeters, we consider that dilated. So just a simple measurement. We look for collaterals. Splenomegaly is part of it, and various Doppler findings. Where would we look for collaterals? Well, right away, the first place to go is the gastroesophageal junction, GE junction. We then can look for a coronary vein, which would be a little branch off the main portal vein or off of the splenic vein. We would look for a recanalized umbilical vein heading towards the umbilicus. We can have gastrosplenic vessels. We can have a splenorenal collateral. We can have a gastrorenal collateral. We can have perisplenic, all kinds of retroperitoneal collaterals, vessels that we don't usually see suddenly appear. So we try to look for them. On ultrasound, here is the aorta, the gastroesophageal junction, GE junction, and tortuous serpiginous vessels in the region. These would be the gastroesophageal collaterals. Here is a sagittal section through the recanalized umbilical segment, recanalized umbilical vein, and it has flow heading out of the liver towards the umbilicus, hepatofugal flow out of the liver. In this image, we see the splenic vein, which is posterior to the body of the pancreas, and it seems to have a branch. We usually never see a branch there, but when we see such a branch, that's a perfect place for a coronary vein. Here's a spleen with large vessels around it, up in the left upper quadrant. Perhaps these are gastrosplenic collaterals. Here's perigastric or perisplenic kind of collaterals. Here's a large spleen with the left kidney, and there's a large tortuous vessel in between, a splenorenal shunt. What are the Doppler findings in portal hypertension? Well, let's look at the portal veins. First of all, we're going to lose the respiratory variation. The waveform becomes very flattened. We have a drop in the velocity of the main portal vein, and eventually it may reverse and be on the reverse side hepatofugal flow. Hepatic veins start to lose their normal pulsatility. We had systole, diastole, kick, and now all of a sudden it's becoming a very flattened waveform. Hepatic arteries, the only thing we'll see is that they can become quite large. And also notice here on this color image, the hepatic artery is red, the main portal vein is blue. They're opposite colors. The artery and portal vein should be the same color. This means that the artery is going towards the liver and the vein now has hepatofugal flow. So we can see that as two different colors. You can also see enlarged hepatic arteries in the parenchyma of the liver. And what happens in that situation is in the portal triad, where you have the little portal vein, on top of it is dilated a little hepatic artery. Now also sits there the bile duct. Usually when we see a dilated duct on top of the portal vein, we see this parallel channel arrangement. But it can also be seen with a dilated hepatic artery. We turn on Doppler, one has venous flow, one has arterial flow. Now the last segment that I'd like to talk about the liver is regarding liver masses. Ultrasound is excellent in detecting focal liver lesions. We're very specific. We're specific for liver cysts, but liver cysts that are about 1 centimeter or more, because very tiny ones we may not be so sure about. But ultrasound is not good in differentiating among the different pathologic entities. There are very few ultrasound features outside of cysts that are characteristic of the mass itself, the pathology. We are not good in distinguishing between benign and malignant masses. Triple face liver CT and MRI are excellent modalities for this, but we are good for picking up a focal mass, and we are also very helpful in the diagnosis in the proper clinical setting. We're good for follow-up and as a guidance for biopsy. We can see simple cysts. Now this is a classical cyst like anywhere else in the body. Anechoic mass, smooth margins, excellent sound transmission. So this is a simple cyst in the liver. What else can be simple cyst? Well, an old hematoma, a hydatid or echinococcal abscess, which this is. This is a patient from Egypt who had a solitary cyst, and eventually this was diagnosed to be echinococcal. A biloma or a seroma can look like a simple cyst. And if we ever have a vascular or if we ever have a cystic structure that looks unusual, not perfectly round, we should always think of the possibility of this being some type of vascular structure like an aneurysm or some unusual fistula like arterial portal venous fistula or portal to hepatic vein type of a fistula. We can have multiple cystic lesions throughout the liver. Very often these are associated with adult polycystic kidney disease or the dominant polycystic kidney disease. We could see multiple cysts with echinococcosis or hydatid disease, as was in this case. We can have multiple cystic lesions throughout the liver that are actually choledochal cysts, the type 4 and the type 5. Type 4 has the dilated bile duct. Type 5 has a normal bile duct. But we can see these cystic structures throughout the liver. If we look at them closely, we will realize that they actually connect, and these are tortuous tubular structures. But many times they just look like collections of cysts. This is a reminder for you of the choledochal cyst. The type 1 has a dilatation of the bile duct. The type 2 has a little diverticulum, a little cyst, off the bile duct. Type 3 has a little choledococele protruding into the duodenum. Type 4 has dilated biliary ducts throughout the liver looking like small cysts, and it also has an associated fusiform dilatation of the common bile duct. And type 5, or Caroli's disease, has the dilated intrahepatic ducts but no dilatation of the common bile duct. So these types you can see, and it's these two that would have dilated cystic type structures in the liver. Complex cystic masses. What about cystic masses with echoes inside of them? Well, that could be from a hemorrhage within a cyst. It could be from infection in a cyst. It could be a hematoma in the liver. It could be an abscess in the liver. Notice that there's sound through transmission, so we know that this is of a cystic nature. In this case, this was an abscess. It could be a biloma or seroma. Could even be a large biliary cystadenoma. Or could be cystic or necrotic degeneration within a metastasis or a malignant tumor. Liver abscesses sometimes cause trouble in diagnosis. A liver abscess, when it has fluid and debris, is fairly easy to spot, but when it has bubbles of gas or pockets of gas, that sometimes may shadow out the back wall of the abscess itself and may cause confusion in its appearance. Here's another way that an abscess can confuse us. An abscess completely filled with pus can be echogenic and sometimes look isoechoic with the liver, and it may actually mimic liver and you may not recognize it. But your eye then would catch some effect on a vessel. Perhaps you may catch an edge effect from the curved surface, and you would eventually realize that there is an abscess here within the liver. This is a fairly characteristic appearance. If you saw a cystic mass in the liver and you saw this kind of folding membrane referred to as the lily pad sign, this is the sloughed internal membrane folding in upon itself, very characteristic of an echinococcal cyst. If you see this, you may be the first one to suggest this diagnosis. Patients travel these days to various parts of the world and may bring back a souvenir, an echinococcal cyst, and nobody may think of it until the characteristic sonographic picture is presented. Other complex cystic masses can occur. We can have benign, we can have malignant. This happens to be metastases that are complex cystic lesions. This one is an echinococcal cyst with internal debris. This one, metastases. So we can't really tell. There's nothing specific. So that's why I'd like to make just a list of hypoechoic masses in the liver. Nothing very specific about these. We can have an abscess, we can have an adenoma, focal nodular hyperplasia, a hemangioma, an unusual atypical hemangioma, focal fatty sparing, microabscesses. They can be hypoechoic. It could be a malignant metastasis, hepatocellular carcinoma, or lymphoma. We can't tell. This happened to be a case of focal nodular hyperplasia, this should be hyperplasia, and this was proven by MRI. We see in the literature that focal nodular hyperplasia has a central scar. However, this is not diagnostic. It's fairly characteristic, but it is not diagnostic. And here's why I'd like to show you. Here's a lesion with a central scar, and this was a hepatocellular carcinoma. This was a lesion that seemed to have a central scar, and this ended up to be a giant hemangioma. So you see, even that central scar is not characteristic enough to be 100% diagnostic. We also have lesions in the liver that are homogeneous and hyperechoic, and most of the time they are hemangiomas. Both of these are, but we have to be very careful. There are other lesions that can look exactly like this that are not hemangiomas. Hemangiomas, when they are found incidentally in asymptomatic patients and in a young patient, a patient under 40, well, such a lesion we can call hemangioma if it's under 3 centimeters. But if the patient is older, beyond 40, or if the patient has any other medical illness, we have to then prove this to be a hemangioma. Let me show you some atypical hemangiomas. This is hemangioma atypical, heterogeneous. This one has some cystic spaces. This one is not totally hyperechoic. This one is hypoechoic and has some sound transmission. All of these are hemangiomas, but they're not typical. Now let's look at something hyperechoic. What's the differential of a hyperechoic lesion in the liver? Well, we all know about hemangioma, but it could possibly be an abscess. It could be an adenoma, could be focal nodular should be hyperplasia. It could be focal fat, could be a hemorrhagic cyst. And it could also be something malignant. Could be a metastasis, could be a hepatocellular carcinoma, could be lymphoma. Not very specific. All of these are unusual, but this one happens to be a thyroid cancer metastasis. So you see, nothing is 100% in the liver. Now, when we talk about multiple solid masses in the liver, the differential diagnosis is metastasis, metastasis, metastasis. But there are other pathologies that can mimic this, that can be just the same. Usually we would say metastasis and we would want to have a history to see what's going on. But it's still, even in this case, not 100%. We can have regenerating nodules in a liver in cirrhosis like this patient had, and this patient has lymphoma, masses within the liver. So even solid metastases are not 100%. Here's another patient with multiple focal hypoechoic masses, and this was multiple atypical hemangiomas. And this one with small hypoechoic masses was microabscesses in an immunocompromised patient. So multiple hypoechoic solid masses is not always metastatic disease. Some metastases are calcified, and we usually think of them as coming from colon cancer, but there is a whole laundry list of other cancers. We can see calcified metastases with ovarian cancer, breast cancer, stomach cancer, pancreas, osteosarcoma, leiomyosarcoma, chondrosarcoma, teratocarcinoma, so certainly not a specific appearance. What's very useful with sonography is that when we're not sure we need a tissue diagnosis, we can just guide a needle straight into the mass and get a biopsy or provide drainage if it's an abscess, and that's extremely useful. Before I close, I just would like to remind you that when you have a case of liver metastases, you should always think a little further to see, are those metastases causing any complications, such as segmental biliary obstruction. You should double check the vessels. Are the metastases invading vessels? Is there invasion of the portal vein? Is there invasion of hepatic veins? This is a patient who has hepatocellular carcinoma in the left lobe, and tumor has grown into the main portal vein, tumor thrombus. You should look for necrosis, maybe hemorrhage or some kind of superinfection. These are all possible complications of liver metastases. So in conclusion, we have discussed the appearance of the normal liver. We've talked about normal and abnormal Doppler patterns of hepatic vessels. We've covered diffuse liver disease patterns. We've talked about portal hypertension and discussed focal liver metastases. Thank you for your attention.
Hello, my name is Fay Lang. I'm a radiologist at the Brigham and Women's Hospital in Boston, Massachusetts, where I'm professor of radiology at Harvard Medical School. And the purpose of this lecture is to discuss using ultrasound to evaluate the gallbladder. So we're going to be talking about ultrasound of the gallbladder, a common anatomic area to evaluate. So let's have a look at it. Gallstones are usually not an issue when they're large and classic and show, as we see here, a clean acoustic shadow, a dependent position, and important, the fact that they're mobile. But sometimes when we're looking at a patient, we don't always get the classic appearance, or you might be fooled. For example, in this case, this looks like it could be a gallstone, but it's not. That's just some bowel gas. So seeing that a stone is mobile has important implications to be sure about the diagnosis. These are gallstones, but you can see how close one image mimics the other. Also, fluid in the right upper quadrant doesn't equal a gallbladder in all cases. In this patient, the history reveals there was a cholecystectomy, and this is a post-op fluid collection. What you really want to look for is make sure there's a wall and the configuration of the gallbladder. Every gallbladder has this fold in it called a junctional fold. It's an embryologic result of the development of the gallbladder, and you should look for it in cases where there's any question if you're dealing with the gallbladder. What I really want to focus on is not the obvious stones, but the more subtle stones, patients who may have acute cholecystitis. If you're not sure you're seeing the gallbladder, the significance of intraluminal echoes that are not due to calculi, and the question of polyps, when do you worry, and are you dealing with adenomyomatosis or possibly cancer. Now, we've already mentioned that when you have a gallstone, you want to see shadowing, and in this case, we see no shadowing here, or no significant shadowing, but shadowing here. And these are gallstones, but it's the same patient. So the question is, why did I not see shadowing over here? Here's a case with sludge balls, and I already mentioned these are gallstones. Two different patients, identical scans. So sludge balls, you wouldn't expect shadowing. Gallstones, you work to see that they do shadow. And what is the difference then between these two scans? Why do I see acoustic shadowing in the scan on the right? Well, it has to do with where the gallstone is relative to the ultrasound beam. And if I am not occluding the beam, or if I'm at the very edge of the beam, you will not see an acoustic shadow. So having the stone there at the edge and not occluding the beam is not a good way to go. What you really want to do is have a narrow beam with the gallstone at the level where the beam is narrow, and that implies you're using a high frequency, the highest frequency possible transducer that you can use will result in a narrow beam, and try to place that stone as you're going through it in the center of the beam to occlude it and create an acoustic shadow. Here again, we do not see acoustic shadowing, and that's because this patient was just turned immediately before this scan was done. But having a patient hold a position for a few minutes lets the stones settle and aggregate and present as a larger geometric volume to the ultrasound beam, and then create an acoustic shadow, as we see here, with some sludge in addition. Here's another example where in the classic LPO sagittal position, a shadow is not evident. Yet this same patient, in the opposite right side down position, we see a relative mild but definite acoustic shadow over the liver. So why didn't we see the acoustic shadow in the LPO position? That's because as we come through the gallbladder, the patient is turned with the right side up. There will be bowel, as there often is, in the duodenum or the antrum, and that effectively precludes you from seeing a shadow because you're seeing lack of echoes over lack of echoes where there's the gas. If you have the patient in the opposite direction, however, as we see here, the small subtle stones, as present in this case, will create an acoustic shadow that is visible over the echogenicity of the hepatic parenchyma. So with small stones, these are the problems. Big stones are easy to see, but small stones are very difficult sometimes, and looking for the acoustic shadow is very important. So again, to reiterate, use the highest frequency transducer you can. Have stones, small stones, aggregate. Think about scanning with the right side down if there's a question to see if you can get shadowing projected over the liver. Here, for example, is a case, this patient actually had two, quote, normal ultrasound exams, but had classic biliary colic when you questioned him. And, I might see a little bit of sludge in this gallbladder on this clip, but no definite stones. It was the history that made me look harder at this patient. And when you're thinking about subtle stones, one of the things you might want to do is to turn the patient rather rapidly, as we see here. And you can see literally at least 100 stones here, small individual stones that are very, very difficult to see, and that's why he had two prior normal studies. These are the kind of stones that will cause problems as they pass into the biliary tree. So look for the rolling stones, and it depends on what you mean by that, but I'm not talking about this type of rolling stones. Look for the rolling stones in the gallbladder when you have a... So to emphasize clues, important ones to see small stones, is to look for the acoustic shadow, scan appropriately to see it with the appropriate transducer, look for mobility, turn patients if necessary, and also if a patient is lying LPO or if there's a question of acute cholecystitis, look very carefully in the neck, because that's a difficult area to examine due to the twists and the turns that are anatomically present at the level of the neck. Now let's turn our attention to making the specific diagnosis of acute cholecystitis. If you took 100 patients who have gallstones, about a third or so will be asymptomatic throughout their lifetime. Many patients will, however, go on to develop chronic symptoms, but nothing too acute, dyspepsia and so forth, when they eat perhaps a fatty meal. The largest way patients go on to develop acute cholecystitis is going from those chronic symptoms to suddenly becoming acutely ill with severe right upper quadrant pain. Relatively few patients go from being asymptomatic to suddenly having acute cholecystitis. So what happens when people have acute cholecystitis? Typically, a stone is moved from the region of the body of the gallbladder, and look carefully, because if it's impacted in the neck, it may be difficult to identify, and your eye may just pick these stones up. But make an effort to look around the curves and the twist in the neck to see if you can see a stone impacted in the neck. Often people have more than one stone, and the question in this case is this an impacted stone and that's a free stone, or is it two free stones? So it's important to show relative motion between this stone, if it's impacted, and that stone. And one of the things people often will do is turn the patient a little bit LPO or RPO. As done in this case, you can see there's no real change in the position of the stone in the body to the neck in either image. So that is not sufficient in this case to prove whether or not there's impaction, because neither stone has moved very well. You haven't turned the patient sufficiently. What I suggest you do is take the patient from the supine position, either turn them prone or sit them up into an erect position, and now clearly there's no question that that stone that's in the neck has not moved, but the one that was in the body has now moved to the fundus, clearly showing one is mobile and the other is fixed. Very important to make that determination. So what criteria do I use to make the specific diagnosis of acute cholecystitis? The two that I consider the most important or major criteria consist of the presence of stones in association with focal gallbladder tenderness. Other criteria that have been described and used include looking at the gallbladder size and shape, wall changes, pericholecystic fluid collections, and intraluminal changes. But I consider these minor findings because they are not as specific as the major criteria of stones with focal gallbladder tenderness or a positive Murphy sign. Now, the problem here is that I can take a picture of all of these criteria, except I cannot take a picture of focal gallbladder tenderness, a major criterion. So I have to know how to elicit a Murphy sign. And various things have been described in the literature, but what I like to do is to look at this in two ways. One, first, I ask the patient to take one finger and show me with one finger where they hurt in their right upper quadrant. And if they rub over their entire right upper quadrant, that is definitely not a Murphy sign. If they take their finger, on the other hand, and point to one spot, and then I take my transducer and I see that spot corresponds to the gallbladder, that is very suspicious for a Murphy sign. Then in a more objective manner, I take the transducer and I tell the patient I'm going to push in 3 spots, and they should denote to me which is the most tender. And let's say the second place I push is over the gallbladder, and then they say that is the area that was most tender. That will, in my mind, confirm a Murphy sign. So I do 2 things. One is the patient shows me where they hurt, and the second is I try to use the transducer to blot in various areas, one of which corresponds to the gallbladder, and the patient says, yes, that is where the pain is. Wall changes are interesting. Most patients who have acute cholecystitis will have wall changes, and some with chronic cholecystitis will have some thickening of their wall. Now, what I would like to do is not just look at wall changes specifically, but to determine if the wall is diffuse or focally thickened. Now, when it's diffusely thickened, yes, it could be due to acute or chronic cholecystitis, but there are a large number of other entities that can cause diffuse wall thickening, including a patient who's not fasting, a patient who has chronic low albumin, hepatitis, heart failure, and even HIV with association due to AIDS, cholangitis. So if you look at this list, often, except for the top of that list, acute cholecystitis or chronic cholecystitis, often diffuse gallbladder wall thickening is not associated with primary gallbladder disease. Let's look at a few examples. Very, very thickened gallbladder with sludge in the lumen, the CT showing the same thing. Notice how complex fluid on ultrasound is so much more dramatic than it is on the CT scan. This is the same patient. That is acute hepatitis with dramatic diffuse wall thickening. On the other hand, here's a patient with acute cholecystitis, very, very similar findings. This patient, as we can see, with a shrunken liver, nodular contour. Ascites has a diffuse wall thickening, and that is due to hypoalbuminemia associated with the chronic liver disease. Now, sometimes people say ascites causes wall thickening, and as you can see in this case, a normal thickness to the gallbladder wall in association with ascites. It's really the hypoalbuminemia that commonly occurs with ascites that causes the wall thickening. It's not ascites per se. Now here is a case where some people might look at this and think the gallbladder wall is diffusely thickened. But if you look at it carefully, it's only the portion of the gallbladder that is in contact with the undersurface of the liver that looks thick. And as a matter of fact, this isn't wall thickening at all. This is a patient who has edema of the gallbladder fossa. And this is a person who has acute pancreatitis causing this. How does this happen? Well, if you think of either pancreatitis or possibly peptic disease occurring down in this area of the duodenum or head of the pancreas, inflammation can develop and spreads in a retrograde fashion along the hepato-duodenal ligament or the course of the bile duct, and then rests by the area of the gallbladder neck and subsequently dissects into the gallbladder fossa, hence giving you this appearance. So just be aware that when you have this asymmetric type of thickening just in the undersurface of the liver, that it probably is not gallbladder wall thickening, but maybe due to pancreatitis. Here's just another example of two patients. Notice the patient with acute hepatitis has diffuse wall thickening all the way around. The acute pancreatitis is a nice example with the fatty liver showing the edematous change in the area of the gallbladder fossa and no thickening on the opposite wall. Focal gallbladder wall thickening has a long list of differential diagnoses, and these different entities often look different one from another. But if you consider polyps, metastases, adenomyomatosis, carcinoma, etc., the rest of the list, these are gallbladder conditions, even though they look different from one another. So focal gallbladder wall thickening almost always is due to primary gallbladder disease. When it's in the context, of course, of pain and so forth, we might be thinking of severe gallbladder, severe cholecystitis, such as a gangrenous gallbladder. So let's take this case. Is this a good scan? Well, there is diffuse wall thickening on both sides of the gallbladder. I'm sure you've already appreciated a stone in the neck, but there's a problem here because the images of the fundus are not good. And it's very, very important when you're looking at the gallbladder not to forget the fundus. The fundus really does deserve our respect. And we can see that when somebody has severe acute cholecystitis, the problem is that the fundus often suffers first. And that's because there's a poor blood supply to the fundus of the gallbladder. We can see the hepatic artery taking off, then the cystic artery coming into the neck of the gallbladder, and then it peters out by the time we reach the fundus. So the fundus of the gallbladder suffers the ravages of acute cholecystitis initially, and we can see there's some irregular thickening here at the fundus. When somebody has a gangrenous or perforated gallbladder, severe cholecystitis, the wall changes then particularly involve the fundus with irregular thickening. You may see intraluminal changes. Sludge is not specific, but if you can see stranding, it will suggest that the mucosa of the gallbladder is sloughing in association with necrosis and gangrene of the gallbladder. Pericholecystic changes are also often at the fundus if the gallbladder has perforated and has contained abscess or contained air collection. Here's a nice example where at the fundus, compare it to the CT. See the irregular thickening at the fundus in both examples. Dr. Netter agrees in his diagram of a gangrenous gallbladder. Now, sometimes it's not just the fundus per se, but changes around the fundus that are important. This was a woman who actually had a CT scan, and I'm going to just show you the CT scan. And the CT clearly showed edema of the fat around the fundus of the gallbladder, but no stones. So ultrasound was done and did show clearly stones, because ultrasound is better at showing stones than CT. So the question was, did the patient have stones? And the answer was yes. But I'm showing you this case to show the pericholecystic inflammation, or the dirty fat that is seen on the CT scan and the corresponding appearance on the ultrasound. Notice it appears white and echogenic, and that is what fat looks like when it's inflamed anywhere in the abdomen. We can see it around the appendix, around diverticulitis. And when you're worried about somebody who has inflammation of the gallbladder, look for these changes. Look for echogenic material that does not look like bowel, no wall, no compression, that signifies dirty fat. Here is another example of a patient who has a perforated fundus of the gallbladder, and on the clip, in addition, there's a contained fluid collection. Nice example, but can be difficult if you're not looking at the fundus carefully. Here's another example, and I have two clips here. We can see a contained with fluid debris level abscess at the fundus on the sagittal, and also on the transverse scan. There's sludge in the lumen, and now there's a contained fluid debris level at the fundus. Here's another example where we can see changes, and the clip, I think, will help you. We can see sludge, and there's some stones in the gallbladder. But notice the dirty shadowing at the level of the fundus due to emphysematous cholecystitis. See the perforation on the corresponding CT at the level of the fundus, and the contained abscess that is seen both on ultrasound over here and on CT over here. Acalculous cholecystitis is a very difficult diagnosis to make clinically, because there are often intercurrent illnesses. The ultrasound findings are nonspecific because by definition there are no stones. The patients often are too sick to localize whether or not they have pain over their gallbladder, and once gangrene and perforation occur, you lose that sonographic Murphy sign. So it's very challenging to make the diagnosis, and often when it's clinically a worrisome finding, we will do biliary aspiration and even place a cholecystostomy tube. But one of the things you can look for is evidence of inflammation around the gallbladder, pericholecystic inflammation. And here's an example: no stones, a very sick patient, and all that white echogenic material around the neck and in the porta hepatis here corresponds to what we see on the CT scan with that dirty fat. So that is what we have to hang our hat on. And here coming down the porta hepatis as well, along the hepatoduodenal ligament. If you have an old scan to compare, you will see that this is now increased in comparison to that old scan. And also here in the region of Morrison's pouch, again, to compare with the CT, we can see the fluid on CT, the fluid on ultrasound, the dirty fat on CT is the white echogenic material on ultrasound. And I can't emphasize how important it is to look for inflamed fat on ultrasound. It doesn't jump out and grab you. You have to seek it out and look carefully for that pericholecystic inflammation. And here's just an example at the bedside where we're placing a cholecystostomy tube in a gallbladder with acalculous cholecystitis. Now, what if you're having trouble seeing the gallbladder? It's not visible. Well, it may be very contracted. It may be filled with stones or sludge. These are much less likely. So here's a case where we really don't see the gallbladder, but we see the telltale so-called WES, or wall echo shadow sign. The wall is the first line. The stones that are filling the gallbladder is the second concentric line. Notice they're rounded, and we can clearly see those are stones. And then there's a little bit of bile between the wall and the stones, and then the shadowing. Most often it's due to a gallbladder filled with stones, as we see in this case. Now, sometimes, again, history is very important because this looks like a WES sign, but this is not. It could be due to a patient whose gallbladder is totally contracted and maybe has some air in the stomach, but this is actually somebody who has no gallbladder, and this is just air in the stomach mimicking a WES sign. So history is very, very important. And if you're not sure, you can give the patient some water to see if this indeed is in the stomach, as it was in this case. Now, it's very important when we're looking for the WES sign to contrast it to a single line that we're seeing here with a porcelain gallbladder. Remember, the Wes is two concentric white lines, a porcelain gallbladder, a single line, and this becomes very important because of the association of a porcelain gallbladder with gallbladder cancer. So if somebody has a porcelain gallbladder, it certainly should be removed. If somebody has a Wes finding, even though there may be many stones, if the patient's asymptomatic, often nothing is done. So is this one or two lines? Well, here I think it clearly looks like a single line, so you might consider a porcelain gallbladder. But now look at the same patient, and we can see that there are two lines, not a single line, making this actually a Wes finding or a gallbladder filled with stones as opposed to a porcelain gallbladder. So what's the difference between here and here? The difference is 2 megahertz. 5 megahertz transducer used here, only a 3 megahertz used over here. You must use the highest frequency transducer possible to get adequate resolution to show this, because in this case this patient did not need a cholecystectomy, whereas if you thought it was a Wes, where if you thought it was a porcelain gallbladder, it should be surgically removed. So that's a very important distinction. Here's a patient with a 5 megahertz. We still couldn't tell, and therefore a CT scan was appropriately done, proving a porcelain gallbladder. Whenever you see a porcelain gallbladder, of course, look carefully, because most of these are associated with stones, and we already mentioned the possibility of cancer. And when we look carefully in this patient, you can see there is a mass adjacent to the gallbladder in the liver, and this is what the CT looked like. And this person was already being treated for their inoperable gallbladder cancer. Now, intraluminal echoes can be due to an awful lot of different conditions in addition to stones. It could have sludge, you might have artifacts, milk of calcium, they may look like membranes, blood or pus, or neoplasm. So let's briefly touch on these. Typical sludge is homogeneous low-level echoes that are due to stasis of bile crystals, calcium bilirubinate, cholesterol crystals. We've already said they're homogeneous, they move slowly, and very importantly, sludge does not shadow. Is this sludge in this case then? Not really if you look carefully, because as soon as you put a higher frequency transducer on, we can see this is a contracted gallbladder. Notice the central luminal line of a completely contracted gallbladder with diffusely thickened wall. So technique is always important, and I emphasize over and over, use the highest frequency possible to make an appropriate diagnosis. Not a 4, but in this case, harmonics with a 5 made a better diagnosis. Typical sludge has a fluid debris level, as we see here. If you see what does not look like a fluid debris level, but a rounded grouping of echoes in the lumen, be wary that that may not be sludge. And in this case, that is a blood clot with hemophilia. Here's another example. Notice it's not a fluid debris level, it is rounded. And here is the hemophilia seen on the CT scan. This could certainly be a sludge ball, but if you put color on and you show the stalk of a polyp, then it's not a sludge ball. Sludge balls often are multiple, as we see in this example. Now, sometimes you'll see what looks like sludge. Clearly, no argument about that. But then, when you scan the patient from a different position, it's gone. And this actually is an artifact. And what is it due to? This is due to a so-called side lobe artifact. What happens here is if you take the transducer, as we often do, scanning the patient in an LPO position, pointing it toward the duodenum, the sound will come in to the patient's through the patient's gallbladder, but there will be these problematic side lobes, and they are not in the main beam. And if they hit something that's very reflective, like bowel gas in the duodenum, they will be returned to the transducer, and the transducer only knows it was hit by an echo that took a certain time path to return to the transducer. It will always put that echo in the main beam. And depending upon the time it took, that will be the position where it will be. And as you can see here, that side lobe will then be projected in the lumen of the gallbladder, as we see here, as that troublesome looking sludge. So really what you want to do is not point toward bowel when you're looking, if you're questioning if it's real or artifactual. And if you point it away from the duodenum, as we see here, there will no longer be the side lobe artifact. Another reason that you can get echoes that are pseudo-sludge, if you will, if you're not occluding the beam, if you have partial voluming of duodenum in the beam, that too can be projected in the lumen of the gallbladder as pseudo-sludge. So important reasons. Patients who have sludge in the gallbladder are typically those we said who have stasis due to not eating, or anybody with an obstruction who can't empty their gallbladder because of an obstruction anywhere in the biliary tree, from the gallbladder neck down to the distal duct. Now, if you see what looks like sludge, but it is shadowing, well, that is possibly an entity called milk of calcium, where a patient has prolonged stasis of crystals in their gallbladder and precipitates out this very high level of calcium in the sludge, and that can cause shadowing. But small stones can appear similar. However, see on CT the fluid debris level here, similar to the ultrasound, in this case due to milk of calcium. Now, what happens if you see membranes in the gallbladder lumen? Well, in this case, it's due to sloughing of the mucosa in a patient who has a gangrenous gallbladder because it has infarcted the wall. Another entity with membranes can be hemophilia, where the clot organizes, and as it matures, just like in an ovarian cyst, you can see membranes. Other reasons that you can have echoes in the gallbladder, as we see here, or another example, a lot of people would look at this and say this is a large polyp or it's a tumor, but notice, importantly, there's no vascular flow. Notice also the wall is intact. Gallbladder cancer is very aggressive and typically does not respect the wall of the gallbladder. So when we see this mass without echoes in it, we again should think of a blood clot. And this is another example of hemophilia. CT number greater than 30 confirms hemophilia on the CT scan. Another example of echoes in the lumen and stones, but this looks more like a heterogeneous mass. And look always very carefully, is there a liver mass here? Because as I say, gallbladder cancer typically is very aggressive, and when we look carefully here, you can see it broke right through the wall, and that is an important clue that we're dealing then with a gallbladder cancer here. And we can see the same thing on the CT scan, and Dr. Netter also shows that aggressiveness of this tumor with gallbladder cancer. Now let's just turn our attention for the few last minutes to polypoid masses and then adenomyomatosis. We see patients here who have small polypoid masses in the gallbladder. Is a cholecystectomy indicated? Well, not when they look like this. And what do we mean by these benign multiple polyps? They are multiple, and they're each less than 5 millimeters. They have a narrow neck. The wall is respected. If you, on the other hand, have a single or maybe a cluster of small, non-mobile, non-shadowing masses, then we get more worried, especially if they're broad-based, as we see here. This is metastatic melanoma, and this is a patient who actually at surgery had carcinoma in situ. Obviously an important time to diagnose, as opposed to when it is spread outside the gallbladder. Notice broad-based attachments in both cases. They are relatively solitary or just paired, as in this case. They will be in general greater than 10 millimeters. 5 to 10 millimeters, if they're multiple, we tend to want to watch those, and typically they don't really grow with time, as far as my experience. Here's a very interesting case. Clearly this is not hemophilia because we see the blood flowing within this mass, but notice that the wall is intact, and that is a clue that probably it's benign, but the large size greater than 10 suggests it should come out. This was a benign polyp, and this case was lent to me thanks to Bill Middleton. So polyps can become quite large. What about this case? Be careful. Here everybody, I think, would focus on the stone, but look beyond the stone. Most people with gallbladder cancer have stones. Don't just see stones and then forget about the rest of the gallbladder wall. In this case, blood flow is seen in this, and that becomes worrisome. Not surprising, a case of gallbladder cancer. Another example, here are stones. And is this study then just complete based on what we see? No. Notice we're using a sector scan here. Sometimes we need more than a single scan transducer to evaluate the entire gallbladder, especially the near field. Where is the fundus? gallbladder fundus deserves our respect. That sector scan didn't see it well. Change your transducer. Now we're using a curve 6, and clearly the fundus is not looking healthy. So the curved transducer, the higher frequency, the broader near field, all came to our rescue. The next thing obviously is to put color on. Seeing flow there is very worrisome for a neoplasm. Looking further in the porta hepatis, we can see that abnormal lymph node there. Unfortunately, it was a small cancer, but it had already spread and was therefore not a curable entity here. Now, 3 different patients, all with the same condition, and the condition is adenomyomatosis. How do we make this diagnosis? Because if we can make the diagnosis, we do not want to do a cholecystectomy. The clues are often intramural cysts, typically at the fundus of the gallbladder, as we see there, and we can see some here. Again, focal changes at the fundus with multiple intramural cysts there. Also, looking for comet tail artifacts, as we see in the patients 1 and 2, due to crystals that become deposited, crystals of bile that become deposited within these intraluminal cysts or Rokitansky-Aschoff sinuses, known as RAS. And when we see that combination of focal thickening, particularly at the fundus with cysts and comet tails, we can confidently make the diagnosis of adenomyomatosis. And here's Dr. Netter's rendition. Yes, other areas can be involved, but the fundus is quite typical with these little cavities or cysts that trap cholesterol and calcium bilirubinate crystals, get reverberation between these crystals, causing those comet tails. So look carefully at the fundus. Here's an example where somebody asked me, was that an abnormality? And I, when a quick perusal, said it's probably just a reverberation artifact, again, with a 4 megahertz sector transducer. But you can't stop there. When we looked further at this patient, changing again to the 6-curve, higher frequency transducer, clearly there was something wrong with this gallbladder. I suspected it was probably adenomyomatosis, but it was rather difficult for me to really get an ideal picture. That patient did go to surgery, was proven to have adenomyomatosis. So can we do any better even than I've done here? Because if possible, I'd like to not send the patient to surgery. Here's an example again, 6 megahertz curved transducer. I can't really say for sure if that's adenomyomatosis. Can I do better? Well, the answer is yes. Now I can see the Rokitansky sinuses and a contained mass in the fundus. How did I do this transducer? Believe it or not, I used a vaginal probe. This is the endovaginal probe. This is 8 megahertz, a higher frequency. I know it sounds funny putting it over the right upper quadrant, but use whatever it takes to get a better picture, if possible, to avoid doing an unnecessary cholecystectomy. And this is, I believe, my last case where we can see CT was done first. The question was, is this a porcelain gallbladder? If it is, then the gallbladder should be removed because of the worrisome development of cancer. The ultrasound here, we can see the cysts in the focal area of change in the fundus. We can see the comet tails, and those can often be even more dramatically revealed with this so-called twinkle artifact that we get from the irregularity of the crystals that we see in the Rokitansky Aschoff sinuses, the so-called twinkle artifact, and confidently make the diagnosis of adenomyomatosis and avoid surgery. And this truly is my last case. Again, is cholecystectomy indicated? Notice here comet tails, but not coming from a thickened gallbladder wall. Well, I suppose this could be air in the lumen of the gallbladder, but the patient was not symptomatic and therefore air, and did not have any reason to have air in the gallbladder based on a prior interventional procedure, ERCP, for example. So in this case, these are comet tails coming from the surface of a non-thickened gallbladder wall, so-called strawberry gallbladder, and it would be, these are just crystals of cholesterol deposition on the surface of the gallbladder, analogous to these little deposits on the strawberry of the seeds that we see on the strawberry wall, on the strawberry wall, and that's why this has been called a strawberry gallbladder. And this too does not need to be removed. This is cholesterolosis as opposed to the adenomyomatosis that we've already talked about. So I hope you've ended up becoming a little bit wiser the wise old owl, as you've looked hard at the gallbladder here, and I hope this discussion has been helpful to you when evaluating the gallbladder with ultrasound. Thank you for your attention.
So the following is just a brief overview that will go through renal transplants, focusing on their sonographic evaluation, and will hopefully give you a framework from which you can then apply these concepts to real-life cases that you'll be seeing during your service. So let's start off by talking about the indications for renal transplants. And as it turns out, renal transplants are really the gold standard for anybody with end-stage renal disease for any reason. Right? You want to try to get to the point where they can get a renal transplant. And you can end up getting these renal transplants really of one of two ways. They can either be from a donor who is living or a donor who is deceased. And in terms of the living donors, they can be related to, they can be non-related to, and the increase in life expectancy from living donors is about 20 years, and from deceased donors about 10 years. So ideally you'd get a living donor, but even a deceased donor really gives you a significant amount of increased life expectancy for patients with end-stage renal disease. We typically like to place these renal transplants in the right lower quadrant whenever possible. Turns out in the left lower quadrant, you have the sigmoid colon that gets in the way, so it's maybe a little bit easier to place them in the right lower quadrant. And this is what it kind of looks like, at least a schematic of it. You can see the kidney placed over here, and we make 3 anastomoses. We make an anastomosis between the donor's renal artery over here and the recipient's external iliac artery. We make another anastomosis between the donor's renal vein and the recipient's external iliac vein. We'll make a third anastomosis between the donor's ureter and the recipient's bladder over here. And some of the parameters to at least think about when it comes to measuring some of these velocities is that the peak systolic velocity within the right renal artery of a transplanted kidney will be a little bit higher than in a native kidney, and it's in the range of 200 centimeters per second in general. Also, when we do the waveforms within this vessel, we end up seeing a low resistance waveform, so this continuous flow, as you can see here, throughout systole and throughout diastole. And if you were to measure the resistive index, which is defined as the end systolic velocity subtracted by the end diastolic velocity over the end systolic velocity, we end up getting a resistive index of about 0.6 to 0.7, which is what we like for these renal transplants. Now, in terms of complications that we may anticipate post-renal transplants, ultrasound is a great modality, and in fact almost always the first line imaging modality to evaluate these complications. When we think about these complications, I really split them up into 2 broad categories. And the first broad category are non-vascular complications, while the second one, as you can imagine, are vascular complications. So we'll go through these briefly and talk about a little bit what you'd expect to see. First thing I look for non-vascular complications is hydronephrosis. Okay, now, as it turns out, these transplanted kidneys, for a variety of reasons, may have collecting systems that are a little bit more distended than you'd expect in a normal kidney. But when you really start to see the calyces look a whole lot bigger, for example, tracing over this, really start to get big like this, then you can anticipate that there's some degree of hydronephrosis. And understand that is somewhat of a subjective call. So if you're ever really worried about the presence of hydronephrosis, one quick trick is to measure the resistive index. So get a spectral tracing of a waveform out in the renal parenchyma over here. And if that resistive index is high, it suggests that there's some degree of pressure in this kidney, and that is likely or could be attributed to the hydronephrosis. If we get an RI in that instance of greater than 0.8, that may suggest that the hydronephrosis that we're seeing is quite significant. The second complication that I look for is things like renal infarcts. And one of the images that the sonographer should show you when they present their cases is one image where there is color flow throughout the kidney, so the upper pole, the interpolar region, and the lower pole. And with renal infarcts, as you'd expect, you'll see a pretty nice, well-defined region, such as something like this, where there's absolutely no flow. So if you see that, you want to suspect that there's a renal infarct. There's a whole bunch of causes for it, including segmental thrombi of a vessel, dissection of a vessel, but you certainly want to be able to look for an image where you don't see any focal flow, and that would suggest that there's an infarct over there. The next thing I look for are the presence of masses in the kidney. And these renal transplant patients are at actually an increased risk for things like RCC and a whole bunch of other tumors, including something called post-transplant lymphoproliferative disorder. And for the most part, as you can imagine, what I'd be looking for on my ultrasound are masses. So I want to see if there's any mass within the kidney, a solid mass or a complex cystic mass. With PTLD, it can look a little bit more infiltrative kind of appearance throughout the kidney. So again, it takes only about a few seconds to scan the kidney on grayscale imaging and realize that it's free of masses. But certainly if you see one, it's something that should be commented on and something that should be biopsied. The third thing I look for is around the kidney. So I look for collections. And for the most part, we can't really tell apart any collection around the kidney. Okay, you can see a collection surrounding the kidney over here and over here. And ultrasound's very good for either detecting the collection and following it over a period of time to see if it's getting bigger or smaller. It's also very good to guide imaging-guided biopsy if you want to aspirate it. And some of the collections that we anticipate in these patients include things like hematomas, which typically have fluid hematocrit levels. You can also see urinomas at times, which are typically seen near the bladder and ureteral anastomosis. You can get things like lymphoceles, which are collections seen about 4 to 8 weeks after surgery. And you can also see, of course, abscesses. So if you see any focus of air within these collections, it's either an abscess or superimposed collection, hematoma, urinoma, or lymphocele. One of the other non-vascular complications that is relatively common is this idea of acute tubular necrosis. Where this happens is when the recipient gets a kidney that is already damaged to begin with. So we end up seeing a little bit more with deceased donors whose kidneys have been damaged for whatever reason. Perhaps they were in a code situation and the kidney did not get appropriate perfusion for a period of time and then was then donated to somebody else. And so it takes a little bit of time for them to perk up. And the imaging finding of acute tubular necrosis is essentially decreased diastolic flow with elevated resistive indices. And we're talking about the realm of 0.8 and above that. And it's typically seen in the first 3 days of transplant. So if you see that finding in the first 3 days, it's likely going to be acute tubular necrosis. And in terms of the spectral waveform, if this is what the normal one looks like over here, the spectral tracing for something like acute tubular necrosis will have good systolic flow and no diastolic flow. So if you see the resistive index, which is defined as the end systolic velocity minus the end diastolic velocity divided by the end systolic velocity, this value will be close to 0. So you essentially get the end systolic velocity divided by itself and a number that'll be anywhere from 0.8 to 1.0 itself. And finally, in terms of a non-vascular complication is rejection. And rejection happens in a couple of stages. And from an imaging perspective, the two stages that we can detect are acute rejection and chronic rejection. And acute rejection typically occurs within the first 3 weeks that the patient has the transplant, while chronic rejection is something that occurs in the first 3 months. And so one way I like to remember it is that ATN is in the first 3 days, rejection acutely is in the first 3 weeks, while chronic is in the first 3 months. And the imaging findings of a rejection will be somewhat identical to ATN, where you get elevated resistive indices as well as low diastolic flow. So now let's shift gears a little bit and talk about the vascular complications of renal transplants. And one way to think about it is just to think about the anatomy, right? So we have a renal artery, we have a renal vein, and either of those can get completely obliterated or thrombose, or can narrow or get stenosis. So if we first start talking about the renal artery, the first complication we can think about is renal artery thrombosis. And as you can imagine, in renal artery thrombosis, when you evaluate the renal artery, you see absolutely no flow. So when you look at it over here, it'll be completely obliterated. The patients may present with anuria and pain over the kidney, and that really needs to be urgently treated in order to salvage that transplanted kidney. The next complication is renal artery stenosis. Now, renal artery stenosis has a bunch of imaging findings that we need to be aware of. And the idea is that for whatever reason, the renal artery gets narrowed. So for example, we see over here, it's not completely obliterated, but it certainly gets narrowed. And what ends up happening is that right in that location, the peak systolic velocities get really, really elevated. So they get really high over here, suggesting that this is the area of narrowing. When we evaluate the vessels more distal to it, so in this location and this location, and especially within the renal parenchyma more distally, what we end up seeing is something called a tardus parvis waveform. So again, if we go back to what our normal waveform looks over here, the tardus parvis waveform will be a little bit different. In that, we'll get peak systolic velocities that are lower than what we'd expect, and the time to reach those peak systolic velocities is also quite delayed. So instead of getting a nice sharp systolic upstroke with good flow throughout diastole, you get more of a delayed upstroke with decreased peak systolic velocities. So you can compare that, which is a tardus parvis waveform, with a normal waveform, which should be much like this. All right, so these findings suggest that there's a renal artery stenosis, and this tardus parvis waveform is always seen distal to the region of stenosis. Let's move on to the renal vein. So again, the renal vein can thrombose or stenose. Well, let's talk about renal vein thrombosis. And as you can imagine, with renal vein thrombosis, you'll see no flow in that renal vein. And what's also interesting is what you end up seeing if you evaluate the renal artery in this instance is reverse diastolic flow. So again, if we go back to what our end systolic and end diastolic velocities look like, in renal vein thrombosis, if it's quite severe and complete, you'll end up seeing forward flow in systole, and in diastole, you'll end up seeing reverse flow, much like this. So when you see waveforms like that with an obliterated renal vein, it suggests that there is renal vein thrombosis. And again, as with the renal artery, you can get renal vein renal vein stenosis, and it turns out there's not much good criteria for this, and you end up seeing a narrowing of the renal vein, and if you use a ratio of about 3 to 1 in terms of the elevation in velocities across this narrowing, it is predictive of potential renal vein stenosis. But again, this is an extremely uncommon thing to see. So finally, let's end with two other complications that I lump into the vascular complication, but strictly speaking, they are really seen in the context of post-biopsy, and those complications are pseudoaneurysm and arteriovenous fistulas. And the idea of pseudoaneurysm is that the people biopsy and it's done quite close to the renal hilum, where you have a bunch of vessels over there, and you end up getting a collection like this that is communicating with the vessels, and a portion of it has arterial flow flowing into it, and a portion of it has flow going out of it. So what it ends up looking like is something called a yin-yang. So it's the yin-yang sign of a renal artery pseudoaneurysm, and there's a variety of treatments that can be associated with it depending on the sign. So finally, let's end with arteriovenous fistulas. And these are little tiny communications you can see between the renal arteries and veins, again seen typically post-biopsy, and these can be difficult to detect sometimes because of their small size, but you end up really seeing a triad of findings that make you suspicious for it. Within the renal artery feeding this fistula, you'll see increased diastolic flow. That's because the renal artery is communicating with the veins, which is a low resistive bed. Within the actual fistula itself, you'll see a lot of aleasing or turbulent flow with very high velocities. And within the renal vein that is draining this fistula, you're going to see pulsatile flow. So if you see these triad of findings in the context of a recent biopsy, it's highly suspicious for a arteriovenous fistula. So there you go. That's a little bit of a summary for renal transplants and their evaluation. At least it gives you a framework for which to approach any potential case that you may end up seeing.
Good afternoon. My name is Wee Chung. I am from the University of North Carolina, and I'm going to be talking about Doppler ultrasound of the liver and portal hypertension. Doppler ultrasound of the liver and portal hypertension. Technical factors. In portal hypertension, the portal vein may have slow or reverse flow or may be thrombosed. Detection of slow flow requires optimizing Doppler parameters. This involves setting the focal zone at the level of the portal vein, minimizing the wall filter, On the right, we have images of the wall filter set at a high setting and a low setting. The wall filter basically eliminates all the low frequency signals. So when you have a high wall filter, this black band here represents the low frequency signals that have been suppressed. Since we want to detect slow flow, we do not want a high wall filter, and by changing to a low wall filter, we can see that that black band is removed. There are other factors that can increase the sensitivity that you can do. These include establishing a slow velocity range, creating a small Doppler angle, making the portal vein as superficial as possible by putting the patient in a different position, such as decubitus or scanning intercostally, and finally, making the color box as small as possible. All these factors will increase your sensitivity to slow flow. Finally, remember that spectral Doppler is more sensitive than color for slow flow. Aliasing. Aliasing is the artifact that you see in the image on the left here. This is the portal vein, and you see blue and yellow color within the portal vein. Does this represent reversal of flow? It does not. The reason you're seeing blue and yellow color is that the velocity range is above the peak set by the color scale on the left here. So since velocities within the portal vein are greater than 0.3 meters per second, you get a wraparound artifact, and the velocity that are higher than 0.30 meters per second appear as blue or yellow. So this artifact can be eliminated by increasing the velocity range, and we can see that this is the exact same portal vein, and by increasing the velocity to 0.4 meters per second, the false color, blue and yellow color within the portal vein has been eliminated. It's important to recognize aliasing because it will create a false impression of reversed flow. On the right is a grayscale image of a cirrhotic liver. The liver here shows a very nodular contour and a heterogeneous echo pattern. The nodularity is better seen in cirrhosis. The nodularity of cirrhosis is better seen when there is ascites. So this patient has ascites, and the nodular appearance of the liver is clearly seen here. One should look for liver lesions, the presence of collateral vessels, vascular anatomy, and the presence of ascites. If there is no ascites present, one can increase sensitivity for detection of nodularity and abnormal liver parenchyma by evaluating the liver surface with a high-frequency probe. Here, a linear 5 to 10 megahertz probe has been optimized for the near field, and it demonstrates nodularity on the liver surface as well as a heterogeneous echo pattern consistent with cirrhosis. The normal Doppler of the portal vein increases postprandially, increases when supine, and has a velocity of between 20 to 30 centimeters per second. Flow is hepatopetal with mild phasicity. So in this Doppler image, the cursor has been placed over the main portal vein, and you have a velocity of 0.27 meters per second or 27 centimeters per second. Flow in the portal vein is laminar in the mid-portal vein. That is to say, it is faster in the center of the vessel than along the periphery. But as the portal vein approaches the porta hepatis, it tends to flow in a somewhat helical manner, like a spiral staircase. And this will create an appearance like you see on the right side. You'll see red and blue here in a kind of braided appearance as the blood spirals its way up into the liver. This helical flow pattern is normal, but it becomes accentuated in the presence of portal hypertension, following liver transplant, and post-TIPS. So here's an example of the helical flow pattern within the intrahepatic portal vein past the porta hepatis. You see red and blue. The blue in this case does not represent reversal of flow. It just represents the blood spiraling upwards into the liver. The normal hepatic vein waveform is triphasic. It is composed of a S wave and D wave in the antigrade direction, and the hepatic vein antigrade flow is away from the transducer and therefore below the baseline. Then when the right atrium contracts, it sends a spike of reversed flow known as the A wave. So the normal hepatic vein waveform is said to be triphasic. 2 forward spikes of flow and 1 reversed spike here. So that means that during ventricular systole, flow in the hepatic vein will be antigrade and will appear blue as it flows away from the transducer towards the IVC posteriorly. But when the right atrium contracts, you will get a spike of reverse flow. So reversal of flow during the cardiac cycle is normal in the hepatic vein. Loss of the phasic pattern in the hepatic vein is abnormal. On the right here, we see an image of a hepatic vein waveform which is monophasic. The normal S and D waveforms and reverse spike of flow in the or A wave are not present. This is a sign of reduced liver compliance and is seen in cirrhosis, where it is considered a poor prognostic sign, and is also seen in infiltrative liver disease. The other cause of loss of phasicity in the hepatic vein is Budd-Chiari syndrome. On the other hand, exaggerated phasicity in the hepatic vein is a sign of congestive cardiac failure or tricuspid incompetence. The forward flow or S to D flow should always be larger than the A or reversed component. In this case, we see forward flow and reverse flow of equal dimension on the Doppler spectrum. This is abnormal and is a sign of heart failure or tricuspid incompetence. This is a color Doppler image on the left and a grayscale image on the right of heart failure. Note that the hepatic veins and IVC are dilated, and that on the color Doppler, the color shifts from red to blue in equal measure. This is a color analog of the waveform that we saw here, where you have forward and reverse flow in equal measure. In cardiac failure, the portal vein waveform can also be abnormal. This patient has congestive cardiac failure, and the exaggerated pulsatility in the hepatic vein has been transmitted into the portal vein. Remember that the normal portal vein flow is always antigrade with mild phasicity. It should never go into reverse, as in this case, where there is a pulsatile portal vein waveform with reverse flow during part of the cardiac cycle. The color Doppler image shows the portal vein flipping from red to blue to red with each cardiac pulsation, and this is a sign of congestive cardiac failure and tricuspid regurgitation. It can also be seen in abnormal flow states such as hereditary hemorrhagic telangiectasia due to high volume, or in arterial portal shunting in cirrhosis. Portal hypertension. This is a video clip of a patient with portal hypertension due to cirrhosis. We see a nodular cirrhotic liver, ascites, and on the color Doppler portion of the image, we see a pulsatile vessel in the liver hilum, as well as a hypoechoic tubular structure posterior to this pulsatile vessel that does not have any flow. So what is this tubular hypoechoic structure, and what is this pulsatile vessel? Well, the pulsatile vessel is actually a hypertrophied hepatic artery. The tubular structure without flow is a thrombosed portal vein. And this patient has a number of features seen in portal hypertension, which we will go over in a little bit more detail. The sonographic signs of portal hypertension are splenomegaly, spleen larger than greater than 12 centimeters, or area greater than 45 square centimeters. Loss of respiratory variation in the SMV and splenic vein caliber. Increased resistance in the hepatic artery, pulsatility index of greater than 1.0. Splenic artery and renal artery resistance also rises. The splenic artery RI rises to greater than 0.6, and the renal artery resistive index is greater than 0.7. The latter can be a sign of hepatorenal syndrome. Hepatorenal syndrome is renal failure developing secondary to renal artery vasoconstriction as a result of portal hypertension. The vasoconstriction in the renal artery leads to activation of the renin-angiotensin syndrome, and this causes renal failure, and is known as the hepatorenal syndrome. The hepatic artery hypertrophies in portal hypertension because the body responds by the increased pressure in the portal venous system by sending more blood into the liver through the hepatic artery. So this is a color Doppler clip and a spectral Doppler of a patient with a cirrhotic liver with a large hypertrophied hepatic artery that shows up as this pulsating multicolored vessel, and the portal vein is patent but is almost the same size as the bulked up hepatic artery, and it shows up as this area in red here. It's almost hidden by the strongly pulsatile hepatic artery. Other sonographic signs of portal hypertension are increased in size of the portal vein. The portal vein is measured in grayscale from the inner anterior wall to the inner posterior wall at the crossing point with the hepatic artery, or greater than 2 centimeters from the bifurcation. A portal vein is considered enlarged if it is greater than 1.2 centimeters in diameter. As the portal hypertension worsens, portal vein velocity drops lower and lower, and eventually you reach a stagnant state. Normal portal vein velocity is greater than 0.2 meters per second or 20 centimeters per second. This patient has very slow antegrade flow in the portal vein down to 0.05 meters per second or 5 centimeters per second. And as the velocity drops lower and lower, you reach the stagnant state where you have slow to and fro flow with a little bit of blood going forward and a little bit of blood going retrograde. So this is known as the stagnant or to and fro flow in advanced portal hypertension. As portal hypertension worsens even further, flow starts going into reverse. So this patient has complete reversal of flow. We see that the portal vein is entirely in blue, while the hepatic artery is this multicolored vessel running anterior to it. This is an image of the intrahepatic portal vein in this patient. We see the hepatic artery, which is hypertrophied and in red, while the portal vein running next to it is in blue, indicating complete reversal of flow. So reversed flow in the portal vein is a sign of severe portal hypertension. Portal vein thrombus. Portal vein thrombus occurs in the setting of portal hypertension due to the slow flow in the portal vein and stagnancy. You can also see portal vein thrombus in acute pancreatitis, in abdominal sepsis, and in tumor invasion from hepatoma, metastases, or pancreatic cancer. Acute thrombus is usually hypoechoic and may be indistinguishable from flowing blood. The portal vein is dilated, and here is a case of acute thrombus of the portal vein, which appears, the vein itself does not, has very few internal echoes, but the vein is shown to be thrombosed by the absence of color flow. The hepatic artery is the vessel running anterior to the thrombosed portal vein. Eventually, as the thrombus evolves, it becomes chronic, and the portal vein, the thrombosed portal vein, becomes more echogenic. Multiple collateral vessels then develop and run in the bed of the thrombosed portal vein. And this appearance is known as chronic thrombus or cavernous transformation of the portal vein. On the grayscale image here, we see instead of a single hypoechoic vessel running into the liver, we see an echogenic portal vein in which is embedded multiple tubular structures consistent with collateral vessels. And this is the color Doppler image of this patient, showing that the multiple tubular structures are actually small collateral vessels. Varices form at sites of natural portosystemic venous communication. These sites are closed in normal patients, but when portal pressure rises, blood is shunted from the portal circulation into the systemic circulation at these sites of natural portosystemic venous communication. The sites that are visible on sonography are the splenorenal varices, gastroesophageal, gallbladder, recanalization of the umbilical vein, and the coronary vein. The coronary vein is actually the left gastric vein, and it comes off the splenic vein and runs posteriorly. This is a recanalized paraumbilical vein. The recanalized paraumbilical vein arises from the left portal vein. It runs inferiorly in the falciform ligament towards the umbilicus. Eventually, it joins the systemic epigastric veins at the umbilicus, creating a cluster of veins known as a caput medusae. So this grayscale image shows the paraumbilical vein coming off the portal vein, then running anteriorly on this sagittal image towards the umbilicus. Here we are following the recanalized umbilical vein towards the umbilicus. Gastroesophageal varices connect the coronary vein and the azygous vein. On this sagittal clip here, through the left lobe of the liver, we see a cluster of vessels running anterior to the aorta and posterior to the left lobe of the liver. The esophageal hiatus is roughly at this point, and these vessels are large gastroesophageal varices as shown on this color Doppler image. Splenorenal varices are found at the splenic hilum. They appear as a bunch of tortuous veins in the splenic hilum that eventually empty into the renal vein, creating a spontaneous splenorenal shunt. This color Doppler clip demonstrates a bunch of splenic varices emptying into the splenic vein. Portal hypertension can be pre-sinusoidal, that is to say the obstruction to the portal flow occurs proximal to the liver, within the liver from cirrhosis or parenchymal liver disease, or distal to the liver at the level of the hepatic veins. We're now going to talk about pre-sinusoidal portal hypertension, and one of the causes of pre-sinusoidal portal hypertension is liver schistosomiasis, which is one of the most important causes worldwide. Schistosomiasis is caused by a parasite known as a trematode, which lodges in the venules of the mesentery. It lays eggs, and these eggs eventually get trapped in the liver and create a granulomatous reaction. This granulomatous reaction causes fibrosis, and the result is a dense fibrotic reaction forming around the portal vein. This grayscale image shows the portal vein here embedded within an echogenic cuff that surrounds the portal vein and its branches. And the portal vein eventually becomes narrowed by this fibrous reaction, and the obstruction to the portal vein leads to portal hypertension. This appearance of the liver is known as the tortoiseshell liver, as shown on this T2 weighted MRI, where the fibrous bands appear as high signal structures within the liver, somewhat resembling the shell of a tortoise. On this color Doppler image, we see that the portal vein here is occluded, and there's echogenic material surrounding the portal vein on either side, and this is the fibrous reaction. This is the hepatic artery here. Post-sinusoidal portal hypertension is caused by obstruction at the level of the hepatic veins. This is otherwise known as the Budd-Chiari syndrome. The causes of the Budd-Chiari syndrome are, it can be idiopathic, tumor invasion from hepatoma, coagulopathy, pregnancy, and oral contraceptives predispose to hepatic vein obstruction, and rarely from obstructing membranes caused by certain toxins. The sonographic features of Budd-Chiari syndrome are obliteration of the hepatic veins, loss or attenuation of the normal pulsatile pattern, and intrahepatic collateral vessels. Acute hepatic vein thrombosis will appear as in the form of a filling defect. So this is an example of an acute hepatic vein thrombosis. This is the hepatic vein draining into the IVC, and within the hepatic vein we see an echogenic filling defect, which is a clot. However, Budd-Chiari usually presents in the setting of chronic hepatic vein obstruction, and this slide illustrates the appearance of chronic hepatic vein obstruction. On the middle and right-hand side, we have chronically obstructed hepatic vein. On the left is normal hepatic vein for comparison. So a normal hepatic vein has a hypoechoic lumen, and the wall of the hepatic vein is very thin or imperceptible. The waveform within the hepatic vein is triphasic with a forward S to D waveform and a small reverse A waveform. This is chronic hepatic vein obstruction, and the vein is markedly narrowed in its luminal diameter, while the wall, which is this echogenic structure next to the lumen, is markedly thickened. This is color Doppler image showing a markedly narrowed hepatic vein with a thick echogenic wall, and the waveform from this vein is monophasic. And this is a grayscale clip of a patient with Budd-Chiari syndrome in the sagittal plane. The caudate lobe is markedly enlarged. This is one of the features of hepatic vein obstruction. You see multiple tortuous tubular structures running through the liver that do not correspond to the normal anatomical hepatic or portal veins. These are portovenous collaterals running from the portal vein to the hepatic veins that have formed as a result of the hepatic vein obstruction. And we see here on this color Doppler clip through the same area that the blood is running through these collateral vessels is blue. That's to say they're running away from the liver surface towards the IVC. So the liver is enlarged, specifically the caudate lobe, and there are multiple intrahepatic collateral veins that do not follow a normal anatomical course running from the surface of the liver peripherally towards the IVC, and they will appear blue. Hepatic artery stenosis produces a Tardus parvus waveform distal to the point of stenosis. On the left is a normal common hepatic artery, and the normal waveform has a sharp upstroke in early systole. The Tardus parvus waveform is characterized by a much more gentle upstroke in early systole, a resistive index of less than 0.5, or acceleration time of greater than 80 milliseconds. The acceleration time is the time it takes from the start of systole to the point where it starts to flatten off over here. So in hepatic artery stenosis, the acceleration time, the time it takes to reach maximum velocity, is prolonged. The resistive index is lowered. And in this patient, this waveform was obtained at this point here, marked by this small red arrow. The stenosis is shown by this narrowed area here more proximally, but the Tardus parvus waveform is seen distal to the point of stenosis. The portal vein stenosis is caused by post-hepatic resection or an anastomotic stenosis in the context of a liver transplant. The portal vein can also be narrowed in patients with pancreatic cancer. This is a color Doppler clip of a patient with portal vein stenosis. The normal portal vein is here, and we see a marked narrowing or waste form at the point of this red arrow, with an increase in velocity as the blood goes through and aliasing as a result in the post-stenotic area. So we have turbulent post-stenotic flow marked by this blue and yellow area distal to the point of stenosis, which is marked by the red arrow. This is a corresponding angiogram showing a stenosis in the main portal vein. This was an anastomotic stenosis in a patient who had undergone liver transplant. A velocity step-up of 3 to 1 is considered significant for portal vein stenosis. On the left is Doppler spectrum of a patient with a liver transplant showing a marked rise in velocity of greater than 3 times pre-stenosis to the stenotic point, where we see a velocity of greater than 2 meters per second. Beyond the stenosis, the velocity drops again. And on the grayscale image, the stenotic area is clearly shown by this arrow showing the point of narrowing. There is also dilatation of the portal vein distal to the stenosis. Hepatocellular carcinoma can appear as a solitary mass or a multifocal or diffusely infiltrative mass within the liver. It can be of variable echogenicity on sonography, and it's characterized by high flow intratumoral vessels on color Doppler. Portal and hepatic vein invasion are seen. So this is a patient with a large HCC within the liver, and the portal vein here is full of echogenic material, which actually can be seen on this grayscale image, which is invasion of the portal vein by the tumor. This material within the portal vein is actually made up of living tumor. As is shown by this color Doppler image, the arrow points towards the thrombosis within the portal vein, but within the thrombus we can actually see little flecks of color, and that's because this is a living thrombus. It's actually tumor tissue, and what we are seeing here is the tumor vascularity within the living thrombus. An arteriovenous fistula is an abnormal communication between the hepatic artery and the portal vein or hepatic vein. This is a patient with a large arteriovenous fistula caused as a result of liver biopsy. We see this area of abnormal color Doppler with a mosaic appearance, multiple colors, and we see a large feeding artery in red here, as well as a draining vein. This is another patient who underwent a liver biopsy, and the grayscale image after the liver biopsy shows a complex, partly solid, partly cystic mass inside the liver. But if we look closely at the cystic portion of the mass, we see that there is some movement within it. So this is not a simple hematoma. And color Doppler here shows a red and blue pattern, which has been described as the yin-yang or Korean flag sign, and this is a sign of a false aneurysm. The red and blue is caused by blood entering the false aneurysm, circulating and swirling around the false aneurysm, and then exiting. So this is a large false aneurysm caused as a result of liver biopsy. This is the corresponding CT image showing the feeding artery and the large false aneurysm. And finally, this was a patient who had had a liver transplant a few days earlier and had abnormal liver function. This was the color Doppler image from the liver hilum, and it shows a very abnormal pattern. We see this vessel here in blue, and we also see that it's very high velocity flow because we see aliasing here. So we see a high velocity vessel with flow heading away from the liver. And we see that the portal vein on the grayscale is markedly dilated. This high velocity vessel is arterial, as you might expect. It's very turbulent with velocities of greater than 3 meters per second. This was an arterial portal fistula. The hepatic artery had fistulized into the portal vein and was sending a jet of arterial blood retrogradely into the portal vein away from the liver. This is shown on the MRI in the form of early opacification of the portal vein during the arterial phase, a markedly dilated portal vein. So in conclusion, Doppler ultrasound findings in cirrhotic portal hypertension include a nodular heterogeneous liver with ascites, enlargement of the spleen greater than 12 centimeters or greater than 45 square centimeters, a hypertrophied hepatic artery with increased resistance, a pulsatility index of greater than 1.0, increased resistance in the splenic artery and renal artery, dilatation of the portal vein greater than 1.2 centimeters, slow flow less than 20 centimeters per second, and then with worsening portal hypertension, stagnant flow, then reverse flow. Additionally, there's an increased incidence of portal vein thrombosis and the development of portosystemic collaterals in the form of varices. The splenic vein and SM vein may also demonstrate dilatation and reversal of flow as well as loss of respiratory size variation. And the hepatic veins may demonstrate a monophasic or flat waveform. Thank you.
Good afternoon. My name is Sheila Schath. I'm an associate professor of radiology at Johns Hopkins Medical Institution in Baltimore, and my lecture this afternoon will be on vascular complications in renal, liver, and pancreatic transplants, role of ultrasound. So this afternoon, we'll discuss the role of Doppler ultrasound in the diagnosis of vascular complications of renal, liver, and pancreatic transplants. And so the objectives of this lecture is to discuss the diagnosis of vascular complications in these transplants, and we'll focus on complications that may significantly impact the health or survival of the transplants and emphasize potentially subtle findings and pitfalls, and this will be a case-based discussion. So we'll first start with renal transplants, and in the last statistics in 2013, there were a little under 17,000 renal transplants done in the United States, either cadaveric or live donor. And we'll start with the normal appearance of a renal transplant. So on the gray scale, here's the renal transplant. You can see there is good differentiation between the renal cortex here and the medullary pyramids. We always ask the sonographers to get a good evaluation of the perfusion of the transplant, and you can see on this power Doppler there is very good perfusion of the transplant with small arteries going all the way to the renal cortex. And finally, we do a Doppler spectral assessment looking at the resistive index in the peripheral transplant artery. The resistive index is the peak systolic velocity minus end diastolic velocity over the peak systolic velocity, and as recorded here, so peak systolic velocity minus end diastolic velocity here. In this particular case, the resistive index is within normal range at 0.74. And basically what this resistive index measure is an impedance to flow in the periphery of the transplant, or resistance to flow, and this will be abnormal in certain pathological condition of the renal transplant. Now, to look at perfusion, should we look at power or should we look at color Doppler? And I would answer that I like both. With power, which measures the amplitude of the Doppler signal, you can see smaller vessels all the way to the periphery, these little branching cortical vessels. But you do not have direction of flow. So on color Doppler, you have direction of flow, and you also have aliasing, and that's very important if you want to detect, as this patient had in this case, little arteriovenous fistula. So I think they both play a complementary role. And then we also measure, in addition to the resistive index I mentioned earlier, we measure the peak systolic velocity at the anastomosis between the iliac artery and the renal transplant artery. This, of course, should be angle corrected. And you really need to, because now we're measuring an absolute velocity value, the velocity. And so you want to keep your angle 60 degrees or below to have an accurate Doppler reading. And you simply measure the peak systolic velocity, which is normal here at 136 centimeters per second. And we also evaluate flow within the main renal transplant vein. So this is a normal renal transplant. So let's start with our case number 1, which is a 45-year-old woman who was post-operative day 1 after cadaveric renal transplant, and she had severe oliguria. So right away, when you look at the perfusion of this kidney, as opposed to the normal I just showed you, you can notice right away that there is pruning of the little vessels here. You do not see good perfusion all the way to the cortex. The vascularity seems actually sparse. And this is confirmed when we do the resistive index. You see that there is absolutely no forward flowing diastole in the kidney, which is abnormal. Normal renal transplant should have forward flowing diastole, and this patient has a resistive index of 1. So this means that there is tremendous resistance to flow in the capillary bed of the renal transplant, which is an indication that this transplant is not really functioning normally. And since this patient is only 1 day post-op, the most likely diagnosis is that of severe acute tubular necrosis, or ATN. Now, an abnormal elevated resistive index is a resistive index at or above 0.8. So up to 0.75 is normal. Between 0.75 and 0.8 is in the gray zone, but definitely above 0.8 is abnormal. And in fact, although I just showed you a case where we thought that the patient really had acute tubular necrosis, there is a wide differential diagnosis. And so in addition to the abnormal resistive index, you need to put the history in context. So within 1 day post-operative, the most likely diagnosis, as was the case in the previous patient, is acute tubular necrosis. After post-operative week 1, there's a wider differential diagnosis. Acute rejection can happen. Acute rejection rarely happens within the first week post-op. So acute rejection is definitely a strong consideration, but you can still have acute tubular necrosis, particularly the transplanted kidney had a long, cold, ischemic situation before the kidney was transplanted. Elevated resistive index can also be associated with calcineurin inhibitors, toxicity, polyomavirus, and less commonly, very severe hydronephrosis or pyelonephritis. So in many cases, when the diagnosis is not clear based on clinical findings, then the patient will have a percutaneous renal transplant biopsy, as was done in this case here, to determine which of these conditions are responsible for the abnormally functioning kidney. My next case is a 27-year-old man, which was only post-op a few hours after getting a living-related donor renal transplant, and the patient suddenly had severe oliguria. So we look, I apologize, these slides are dark, but this was done in the ICU in not the best condition. But right away, the striking thing is that both in the peripheral renal arteries as well as the main renal artery, there is actually reversal of flow in diastole. So it's not just a resistive index of 1, but it's negative. There is reversal of flow in diastole. Now, this is a critical finding. Okay, if you see reversal of flow in the transplant artery, this is really an important, potentially very dangerous finding for this transplant. And so the first thing we need to do is look for the renal vein. Okay, that's very, very important, because one of the underlying cause of having reversal of flow in diastole in the artery is that the renal vein is thrombosed. And in this patient, you can see here that there is flow towards the transducer, so there's flow in the arterial system. We were never able to find the renal vein, so our diagnosis was a thrombosed transplant renal vein. This is a condition where you pick up the phone, call the transplant team right away, and the patient had an emergency surgery and unfortunately had to undergo transplant nephrectomy. So reversal of flow in diastole in the renal artery is a dire situation which requires immediate notification of the transplant team. It requires urgent management. In one series of over 5,000 ultrasound done was present in this article here in 1.2% of studies. And the first thing you do is look at the renal vein, because one of the conditions causing reversal of flow in diastole is a thrombosis of the transplant vein. Transplant vein thrombosis is a potentially catastrophic complication seen in about 0.4 to 4% of cases. And because the transplant lacks collateral venous circulation, then the transplant is at risk for having necrosis. You can have it can be resulting from a surgical complication. Usually this occurs within 24 to 48 hours postoperative. And it's important that this patient be taken emergently to surgery, because potentially there is a possibility to do a venous thrombectomy and save the transplant. But you can also have delayed renal transplant vein thrombosis several weeks or days after the transplant. And that is thought to be caused by severe vasculitis, likely secondary to severe acute rejection. And in this case, unfortunately, it is usually not a reversible cause, and most of these patients end up having a transplant nephrectomy. We also have to be aware that a very severe venous kink sometimes can have similar Doppler finding and mimic thrombosis. Now, this is my case number 3. This was a 40-year-old man, post-op day 1 after cadaveric renal transplant, who had severe pain over the transplant site and anuria. So here's the transplant, and really, if you look quickly, there is not really a significant abnormality. But if you look at the clip here, and I'm going to play it again, you can see that the transplant really is not all the way here, right? The vascularity, which seems pretty good in the transplant, stops here. So what is this? So this is actually a hematoma. And again, the still picture confirms it. There was actually good perfusion to the transplant, as you can see here. And this anechoic soft tissue space was basically a hematoma. The patient did have reversal of flow in the main renal artery here, but we looked for the renal vein, and we could actually find the renal vein here. So in this patient, the reversal of flow in diastole in the arterial system was not caused by renal vein thrombosis, but was caused by a perinephric hematoma. Again, this is a critical finding. The patient had a quick CT scan, non-contrast CT scan, confirming that the patient had a subcapsular hyperdense fluid collection compatible with a recent hematoma here. The patient underwent emergent surgical evacuation of the hematoma, and on the surgical table had large urine output, and basically heat transplant improved very, very quickly. So there is a differential diagnosis for reverse diastolic flow. Really, the differential diagnosis depends on timing. As I said before, in the early postoperative period, 24 to 48 hours, the two things you really have to watch out for is renal vein thrombosis, which is the most common thing that I've observed, but also potentially hematoma with page kidney, as we saw in the second case. And occasionally, if you have very severe rejection or ATN, not severe rejection, actually, ATN, very severe, occasionally it can cause reversal of flow in diastole, but that's uncommon. And then within 1 month post-op or delayed occurrence, this will be a slightly different diagnosis, and I'll show you examples of that. Unless there is a treatable surgical condition, having reverse diastolic flow in the arterial system of the renal transplant is a poor prognostic sign, with about 33 to 35% graft loss reported in the literature. So if you look at this situation not immediately post-op, but within a month post-op, then it could be caused by acute tubular necrosis, acute rejection, or delayed transplant vein thrombosis. And then after a month post-op, then other conditions causing reversal diastolic flow include severe rejection, glomerulosclerosis in the transplant, or low cardiac output. Again, remember, however, that this is a relatively poor prognostic sign for the life of this transplant. And this is just an example of a patient that was 10 days post-op. You can see here that the kidney looks kind of edematous. There is loss of the normal corticomedullary differentiation. You don't see the renal sinus fat very well. You have reversal of flow in the arterial system, in diastole here in the main renal artery. And you look at the renal vein, and there is good flow in the renal vein. And this patient underwent a biopsy and had severe acute rejection. Now, in some cases, the vein is the transplant vein is patent, but there is elevated velocity in the transplant vein, as you can see here. So normally the vein, this is a transplant vein here. The velocity is 210 centimeters per second, which is way too high. It should be no more than 40 to 50 centimeters per second. And there's a differential diagnosis for this condition. If it's early in the postoperative period, it could simply be postoperative edema, and this will resolve on its own, or it could be a kink, or as was the case in this particular patient, a severe stenosis, and here I have the MR to prove it. This is a renal transplant with a transplant vein here. Here's the iliac vein, and you can see that this segment of the vein here between the renal hilar region and the iliac vein here, this segment of the renal transplant is severely stenosed, and hence the very elevated velocity. So my next case now is a 38-year-old woman who had a renal transplant 9 months prior to this scan, had a rising creatinine, and had hypertension that was difficult to control by medication. So let's look at her case. So here's her renal transplant. Here's the iliac artery. And you can see here, this is the main renal vein to the transplant, and you could see aliasing. So let us see what is going on here by putting a Doppler spectrum. And when we look at the area of the anastomosis here, we have a very high velocity of 467.5 centimeters per second. So that's very high. And if we look at the iliac artery before the anastomosis here, the velocity is 138.4 centimeters per second. So we suspect here that the patient had a renal artery stenosis in the renal transplant artery. So this complication has been reported in 1 to 16% of patients. Clinically, they present just like our patient presented with worsening renal failure function and hypertension. You use color Doppler to identify the area of aliasing, and you need to have the Doppler spectrum, just as was the case in the case I just showed you for diagnosis. The criteria, there are not that many published papers, but they're basically similar to what you would do for the native kidney. And we use a peak systolic velocity in the main renal artery above 200 to 250 centimeters per second, combined with a peak systolic velocity ratio between the renal artery and the iliac artery above 2 to 3.5. These are variable numbers reported in literature. If there is any question, I think it's a good idea to get an MRA if possible, particularly if the patient has appropriate symptoms. So if you have an elevated peak systolic velocity in the main inguinal artery of a transplant, what is your diagnosis? Well, it could be, again, very early postoperatively. It could be simply postoperative edema, but you think about renal artery stenosis. You can also have a kink in the renal artery. So it's not an anatomic stenosis, but the artery is just kinked, or a size mismatch between a small donor artery and a larger recipient artery. Other vascular complications are perhaps less common. You can have complete thrombosis of the transplant artery or focal infarction. This is a patient, if you look at the transplant here, you can see that even on grayscale, this portion, this portion of the transplant has a different echo texture than the bottom two-thirds here. When we put with perfusion, you can see that there is no perfusion to this upper pole transplant, and this is a focal infarction of the upper pole. A more ominous case here, this patient had 2 kidney transplanted next to each other, and when we put color Doppler here, we can see that there is flow in the left transplant, no flow in the right transplant. So again, this is a critical finding where we suspect that there is arterial thrombosis here because there is no flow whatsoever. And this patient ended up having the right transplant removed. Because there was no arterial flow confirmed on Doppler during the surgical procedure, and the right transplant was necrotic. All right, so my next case now, case 5, is a 44-year-old woman who had gross hematuria after a renal transplant biopsy. So if we look at the grayscale, the patient has a little bit of hydronephrosis, otherwise the transplant looks the cortex looks normal. We put the color Doppler here, and you can see that there is this very large vessel going to the periphery here. And then the key here is to put Doppler spectral interrogation, and you can see here that there is a color brewing in that area, so there's tissue vibration. There is very high turbulent flow in that region, and the patient does have an arteriovenous fistula, a large one for that matter. And because of that, the patient underwent angiogram, and you can see the early draining vein here. So this is an arteriovenous fistula. Post-biopsy complications, arteriovenous fistula are actually not uncommon. It's iatrogenic when the biopsy needle pierces the artery on the venous wall during the biopsy procedures. Many are asymptomatic and resolve spontaneously. If they are large, like the one I just showed you, they may need intervention. Other complications include post-biopsy hematoma. And here what we have to try to look with power or color Doppler is look for an active extravasation or an expanding hematoma. And then less commonly, we have seen pseudoaneurysms either isolated or associated with an arteriovenous fistula. So let's look at a couple of those examples. Here's a patient who had a biopsy in the morning. The transplant is here. Had abdominal pain and was dropping hematocrit a little bit later in the afternoon. So you can see now that there is this big echogenic collection superior to the transplant. And at color Doppler, you could see there is a little kind of bleeder right there, or suspected bleeder. And then this patient here, on the grayscale, you can see there is a cystic structure in the cortex of the transplant. Very easy diagnosis by pushing the color button. You can see that this fills in, and there is a yin-yang, so this part is a pseudoaneurysm. There is also aliasing in that area, so maybe with Doppler spectrum, we can see a little bit what's going on here. And basically, the patient had a pseudoaneurysm, and you can see again, I'll show you the yin-yang sign. But usually, simple pseudoaneurysm would not have a turbulent flow, but there was also turbulent flow. Okay, so what basically this patient had, and you can see nicely at the angiogram, this is an arteriophase study, so you can see here the large feeding vessel, the pseudoaneurysm, and then the early draining vein. So this patient had a combination of a pseudoaneurysm and an arteriovenous fistula. And these, of course, usually need to be treated embolized by angiography. Here's another patient. The transplant perfusion here looks normal. The patient had increased creatinine hematuria. So every time a patient has hematuria, make sure that you put the Doppler over the entire kidney to detect the small arteriovenous fistula who could potentially cause hematuria. And so something's interesting in this patient, because if we look at the mid-pole Doppler spectrum, the resistive index is 1. There is no diastolic flow, so that's abnormal. But if you look at the lower pole, here the vessel's a little bit more prominent, and there is a continuous forward flow in diastole, suggesting that the flow is actually turbulent. So what is going on? Well, we look a little bit more carefully, and what happened is that the patient does have an arteriovenous fistula. Here's the nicely shown large draining vein here. And that was the explanation for the focal turbulent flow in the lower pole. And at biopsy, the patient had drug toxicity, which explained his abnormally high resistive index, but also had an arteriovenous fistula. Okay, so now we'll switch organs and we'll talk about liver transplants. Now, approximately 6,000 liver transplants are done per year. Vast majority, at least at our institution, are cadaveric, but more and more, because of the short supply of cadaveric liver transplant, living-related transplant becomes an option in some patients. And so I'm going to talk about cadaveric liver transplant anatomy here, and I just want to show a diagram, and I'm grateful to Port and Leroy where I could borrow this diagram here, and look at the vascular anastomosis. So when the liver is transplanted, there are 3 vascular anastomoses: the portal vein anastomosis, the IVC anastomosis, and depending on the way that the liver is transplanted back, you can have 2 anastomosis, or a piggyback anastomosis where there is only 1 venous anastomosis for the IVC. And very importantly, because that's the one that creates the most common complications, the arterial anastomosis of the between the recipient and the donor hepatic artery. And then, of course, there's the bile duct anastomosis as well, but we're not going to be as concerned about this today. So this is a normal Doppler spectral evaluation of the liver transplant. So we look for main portal venous flow. And oftentimes, especially early in surgery, the velocity may be a little high. This is 46 centimeter per, this is about 46 or so centimeter per second. It's okay. We look at the hepatic artery, and the easiest place to find the hepatic artery is, of course, in the region of the porta hepatis. But if you can, try to trace it more proximally. Try to find at least a portion of the hepatic artery is possible, and you should have some forward flow in diastole. And then we look at flow in the inferior vena cava and flow in the hepatic veins. And so this is a normal examination. Now, this is just an example of a piggyback where basically there is more back table preparation of the liver, but in the piggyback anastomosis, the donor IVC is anastomosed, usually a side-to-side anastomosis with the recipient IVC, and this is what it looks like. And the advantage here is that there is only 1 IVC anastomosis. So this is the piggyback configuration. So let's start with this case of a 29-year-old woman who was post-op day 1 after liver transplant, had abnormal liver function test, and was acidotic, so not doing well. So here, when we try to find the hepatic artery, you can see there is nice flow in the portal vein here. We could not really find flow in the hepatic artery. So we tried to look more centrally, and there was just maybe a little bit of flow here in the hepatic artery. Very, very difficult to find. So, but we were unable to find flow in the more proximal towards the liver portion of the, distal, or towards the liver portion of the hepatic artery. So this is a critical finding, no flow in the hepatic artery. And basically, the patient underwent an emergency hepatic artery thrombectomy, and unfortunately this was unsuccessful, and she required retransplantation. So hepatic artery thrombosis and stenosis are the most common and the most serious vascular complication after liver transplant. If it's an acute phenomenon, then there is risk of septicemia, gangrene to the liver, and the patient will need retransplantation or will die. If it's a more gradual process, then because the hepatic artery is the only vascular arterial supply to the biliary system, there's a high risk of biliary ischemia. Now remember, the liver has a dual inflow system, portal venous as well as hepatic artery. But the biliary system only has the hepatic artery as its arterial supply, and so if there is delayed thrombosis or stenosis, you have biliary ischemia. And this is a complication that affects approximately 7.9 to 13% of patients who had a liver transplant. Now, hepatic artery thrombosis, so complete thrombosis, account for about 60% of all vascular complications in the liver transplant. It's more common in the pediatric patient. It's a catastrophic complication if it's in the immediate postoperative period. These patients have fulminant sepsis, gangrene to the liver, and may die without retransplantation. But you can also have delayed hepatic artery thrombosis, where there is some small amount of collateral flow which is not sufficient to maintain a healthy biliary system, but has some hepatic arterial peripheral flow. And so these patients present usually with recurrent sepsis, liver abscesses, biliary leaks, and ischemic cholangitis. So this is a patient who had a liver transplant 6 months prior, was doing okay, and then presented with right upper quadrant pain and fevers. And so the first thing we see on these two grayscale images is the patient has a lesion here, which has some cystic areas here, maybe another lesion here. And in a patient who is, septic, of course, you think about hepatic abscesses. And so then we looked for her hepatic artery, and here there is some flow in the hepatic artery, okay? So in the region of the porta hepatis, we do see flow in the hepatic artery, but notice two things. The systolic upstroke here is not sharp. There's an increased slope, and this is a parvus tardus type phenomenon, and also the resistive index is too low. Below 0.5 is abnormal, so there's too much diastolic flow. And so that's a kind of an indirect indication that perhaps there is a problem in the more proximal portion of the hepatic artery. So if you see a Doppler spectrum like that, parvus tardus appearance, a low resistive index, you need to trace the hepatic artery more proximally. And when we did that in this patient, here's the aorta, the celiac axis, the splenic artery, and there is no hepatic artery. So there was an occlusion near the origin of the hepatic artery. And so this patient had what's called collateral transformation of the hepatic artery. This patient did undergo angiogram, and you can see here that there is an occlusion near the origin of the hepatic artery from the celiac axis, but you see these irregular kind of small vessels in the porta hepatis, and this is why when there is delayed hepatic artery thrombosis, you have some hepatic arterial flow in the porta hepatis region. And that's been called the collateral transformation of the hepatic artery. So it's important to realize that in hepatic artery thrombosis, the presence of arterial flow in the porta hepatis does not exclude the diagnosis of hepatic artery thrombosis. Okay, again, this parvus tardus type pattern in the porta hepatis is abnormal. So you have an abnormal Doppler spectrum with a low resistive index below 0.5 and a tardus parvus appearance. And if you see that, you need to trace the hepatic artery more proximally from its origin to the celiac axis. And in patients who have a liver transplant, have repeated liver abscesses or byelomas or cholangitis, you have to maintain a high index of suspicion for this condition. Now, this is another patient who had fever, abnormal liver function test 3 months post-op. And here you can see that there is, so this was a hepatic artery tracing in December 2009, and you can see that there is very little flow here in the hepatic artery. This is all venous flow here. And then follow up a couple months later, we can't find the hepatic artery at all. So this was an abnormal Doppler spectrum here. Couple of months later, we can't find the hepatic artery. There is still some flow in the liver because the portal vein is patent, but this patient had this large amount of gas in the liver here, and on the CT scan, you see nicely that there is a large necrotic area with a large abscess or necrosis caused by delayed hepatic artery thrombosis. And again, this was confirmed on this patient's CT scan. Here's the celiac axis, and nicely shown on this MIP image here, you have the splenic artery, and there is no hepatic artery. This is another patient who presented several months after liver transplant, very similar findings of abnormal liver function tests and fevers. And again, very similar pattern. There is this gas formation in the liver, so we're worried about an abscess. When we looked at the portahepatis, you now can recognize the parvus tardus appearance and the low resistive index below 0.5 in this patient. So we're going to trace the hepatic artery more proximally because we're suspecting that the patient has a problem with the hepatic artery. And in this case, here's the celiac axis. We can see the origin of the hepatic artery, but you can see here that there is an area of narrowing with a waist type appearance. And in that area, you can see that there is very, very high peak systolic velocity, probably above 326 centimeters per second. Okay, so this patient had a stenosis in the hepatic artery, causing very similar symptoms in the patients. And again, nice correlation between the ultrasound here with the area of stenosis, and this is the angiogram at the time of balloon angioplasty. You can see here there's a focal significant narrowing of the hepatic artery, and this patient was treated with balloon angioplasty. So hepatic artery stenosis has a clinical presentation that is similar to delayed hepatic artery thrombosis. It occurs in about 11% of patients of liver transplant recipient. And again, they're the same Doppler finding as hepatic artery delayed thrombosis with resistive index less than 0.5 and a parvus tardus phenomenon. And more proximally, if you're lucky, you can find the area of stenosis with a focally elevated peak systolic velocity above 200 to 300 centimeters per second. Now, Dr. Harrow from Albert Einstein in Philadelphia gave me this case. Some of the patients who have hepatic artery stenosis have a complication of biliary cast. What happens is that they have ischemia of the biliary wall and necrosis of the biliary wall, and then this cast formation, this echogenic, the bile duct is basically filled with this echogenic material. So hepatic artery stenosis with biliary casts. What are the potential pitfalls in this diagnosis? Well, first of all, potential false negatives, as I showed you. And again, remember the presence of hepatic arterial flow at the portahepatis does not exclude thrombosis or stenosis. Potential false positives, severe post-op edema in the early postoperative period. So the thing is, in a patient who has sepsis or abscesses, just think about this condition. Okay, think about it. And then I want to talk a little bit about the syndrome of impending hepatic artery thrombosis. And this was this article published several years ago now, who discussed the sequential Doppler of the hepatic artery shows loss of diastolic flow in hepatic artery, dampened systolic flow, and then a few days later it's followed by complete loss of hepatic arterial flow. So the syndrome of impending hepatic artery thrombosis. So here's an example, post-op day 1. There is a little bit of hepatic arterial flow. You can see, first of all, it's very pitiful. The velocity is extremely low here, probably like 20 or 30 centimeters per second. There is no diastolic flow. So we would recommend very, very careful follow-up of this patient because this potentially could have a thrombosis of the hepatic artery. And sure enough, 2 days later, the patient was not doing well. We bring the patient back, and at this time, even with power Doppler, we can't find the hepatic artery. So again, this patient unfortunately had a hepatic artery thrombosis, hepatic necrosis, and had to go emergency retransplantation. The caveat is that some of these patients are on pressors for hypotension, and if you're on vasopressors, then you may not have forward flowing diastole. That's just a function of the medication they're on. So if I see no forward flowing diastole early postoperative period, I always call the ICU and find out if the patient's on oppressors, because that, in these patients, it could be a good explanation without having to invoke an impending thrombosis. Regardless, I think it's a good idea to have careful follow-up in these patients. Now, portal vein complications in liver transplants are less common and they're less catastrophic. They represent 1 to 2.7% of vascular complications. They're more common in living donor liver transplant, and the complications include portal vein thrombosis, stenosis, either at the anastomosis, usually at the anastomosis with a velocity gradient, or you can have a portal venous aneurysm. And this is just an example of a patient who had a lobe of the liver donated by a living donor. You can see in the portal vein, which is patent, there is an area of aliasing with very high focal elevated velocity of 321.7 centimeters per second. So this is a portal vein stenosis. Hepatic venous complications are also relatively uncommon. They represent 2 to 10% of vascular complications. You can have hepatic vein or IVC thrombosis, or you can have a partial clot, as you can see in this patient, or you can have stenosis. At the anastomosis, you'll see a velocity gradient. And again, these complications are more common, probably because the surgery is more technically difficult in patients who have a living donor. And this is an example of hepatic venous stenosis. Now you can see here right away what is abnormal is that the hepatic veins should really drain towards the IVC. This is a transverse view of the liver. So they should be away from the transducer in blue. And you can see here in this middle hepatic vein that the flow here is reversed. It's going towards the transducer, which obviously is abnormal. And then you can see again aliasing in the right hepatic vein as well, and the patient had an area of stenosis here near the IVC anastomosis and was treated with angioplasty. Okay, and the last organ I'm going to discuss is a pancreatic transplant. About 800 pancreatic transplants were done in 2012 in the United States. 800 combined renal and pancreatic transplant, and maybe about 450 pancreatic transplant alone. They tend to be diabetic patients, and basically, you transplant. Usually, they also have renal failure, so they get a renal transplant for the renal failure and the pancreatic transplant for the islet cell endocrine pancreas. So there are two different surgical techniques. The one that is used most commonly at our institution, the pancreatic transplant is transplanted in the iliac fossa, so it will have a systemic vascular drainage, and the vascular anastomosis will be done with the iliac vessels. And remember, it's important to have an exocrine drainage of the pancreas as well, and the drainage is done in the bladder more commonly than in the bowel. And then there's also another technique that's been described, portal enteric drainage, where the pancreas stays in its anatomic location. So it's higher in the abdomen. The venous drainage is in the SMV, and the exocrine pancreas of the transplant is drained in the small bowel. So this is, again, courtesy of University of Minnesota diagram of the pancreatic transplant, which is draining in the systemic circulation in the iliac fossa. So here's the transplant here. You have the vein here draining in iliac vein, and the SMA and celiac type vessel is taken from the pancreas, from the donor, and it's grafted in the iliac artery of the recipient, and there is the splenic vein and SMV ends are tied off here, and then there is a piece of duodenum connecting the pancreatic transplant to the bladder for the exocrine drainage. And the advantage of this also is that if you want to assess the health of the pancreatic transplant, you can measure the amylase in the urine, and if the amylase drops, it means that perhaps the pancreatic transplant is not functioning properly. So this is a normal pancreatic transplant. In grayscale, maybe a little challenging sometimes to find them, but basically it just looks like a pancreas. Okay, this is in the iliac fossa, and you want to look for good vascularity within the transplant here. And you want to look at the venous anastomosis between the portal vein and the iliac vein here, nice venous flow. And usually there are two arteries, one which has more of an SMA type flow with higher resistance, and the second one which has more like a celiac axis type flow with lower resistance. So you look for one venous Doppler signal and two different arterial Doppler signal. So this is a normal case. Now this patient was a 50-year-old man who had a pancreatic transplant 1 day prior and had increasing insulin requirement. So if we look at the transplant here, there is some perfusion here, but we couldn't find the portal vein, and we were wondering, is that the area of the pancreatic vein? Is it expanded? Is there a clot? And then when we look at the arterial Doppler, you can see again the dreaded reversal of flow in diastole here. So just like in the kidney, you have to concern that there is very high resistance, something's going on. And combined with this finding, we're suspecting that the patient had a no flow in the pancreatic transplant vein, and the vein was actually thrombosed, and the patient did undergo an emergency thrombectomy. So what are the complications? Well, vascular complications are found in 2 to 19% of cases, and biochemical markers are very important to detect graft dysfunction. As I mentioned, one of the ways to do it is to measure the amylase in the patient's urine. They also are prone to other complications, including graft rejection, pancreatitis, and fluid collections. So in conclusion then, there are many challenges to be met when we evaluate a vascular complication of transplants. You need to know the surgical technique. You need to be able to interpret the Doppler parameters, and they vary with the type of of organ transplant. So it's going to be very different what you're looking for in a liver versus a renal transplant. And so what I would suggest is that you get as much clinical information as possible. If you can, look at the postoperative note or talk to the surgeons. We need a meticulous scanning technique. And to remember all these numbers, I recommend you have a cheat sheet either online or in the reading room to remember the numbers and the criteria. And again, another challenge that I should mention, that especially early on, these patients are done in the ICU, they're very sick, and the image quality is also sometimes challenging. So, but I hope that I've helped you look at some of the complications and how to deal with them. And I thank you very much for your attention.
And we're going to be talking first, of course, about some anatomy and normal Doppler parameters, but also look at the common causes of transplant complications. There's lots of people out there who have transplants nowadays. And then talk about some of the pitfalls. And again, when to use correlative imaging other than ultrasound. So just a reminder, the transplant is usually positioned in the right lower quadrant, unless it's done with the pancreas, in which case it'll be on the other side. But we have three hookups, basically the renal artery, the renal vein, and the ureter. So our goals are going to be to look at the complications of the vascular system, the collecting system, which we just mentioned, but also what happens in the parenchyma and what happens around the kidney as well. And lastly, we'll talk a little bit about biopsy guidance too. So in my lab, we want to have some protocols, of course, and our normal imaging includes measurements of size, and these should be young and healthy kidneys, so we're not so worried about measuring the cortex here, at least in the beginning. We want size in all three dimensions because actually the normal transplant will hypertrophy up to 20 or 25%. If it gets more than that, you have to worry about is it rejecting or is there something else wrong with it. We're also going to be looking at Doppler, and again, we want some parameters. So we're going to be looking at peak systolic velocity of the main renal artery at the anastomosis, as well as going through the hilum, and also the feeding iliac artery, because we're going to be using that for our ratio. We want to demonstrate a patent main renal vein and an iliac vein. And we want to demonstrate flow throughout the transplant. So also we're going to sample in the upper pole, mid-kidney, as well as the lower pole, mostly to make sure our sonographers are looking all the way around. And normal in a transplant sometimes is a little bit higher than in the native kidneys. We'll accept certainly up to 0.8. I used to say 0.7, but we've gotten a little more liberal. So our acute complications, I decided to present it basically in a timeline form. So acutely, we're going to be looking at major complications of the artery and vein. Later on, we're going to be looking at some parenchymal complications. And lastly, some things that develop later on. In the very acute period, which is in the first couple of days post-op, the main things to worry about is the kidney perfused? And one big problem would be renal artery thrombosis. And this can either just be from clots that have formed in the kidney or from problems with the anastomosis, with a dissection, etc. The patient will present with anuria, and the treatment is immediate. This patient needs to go back to the OR. Our imaging with transplants is so good that if you don't see any flow in the kidney, basically that kidney goes back to the OR. It doesn't go to CT. It doesn't go to angio. Here's a patient who had no urine output in the recovery area. They asked for an ultrasound, and the waveform you see here is a very bizarre one. This is almost called a wall thump waveform. You just see something sort of pulsing here. There's no diastolic flow. This is just some noise. And when you check the iliac artery is fine. This patient needs to go back. And when his kidney was flushed out, you can see this is the kind of flow and perfusion you should see. This was actually performed intraoperatively, but tremendous perfusion. This kidney is getting all the blood flow of the body because the native kidneys aren't working. Okay, my sonographer called me. This was a 12-year-old and had a living-related donor transplant. And the question is this normal? So we look at the lower pole, the mid-kidney, the upper pole, and you see flow, and the waveforms look okay. What's wrong? I'm going to give you a close-up. No flow here in the back half of the kidney. So be sure you're looking all the way from front to back. So she wanted to know, is this a technical problem? We all know that Doppler actually has more of a penetration problem than the grayscale does. So was her Doppler frequency just too high? So I suggested she do something we can always do with ultrasound, which is change her approach to the patient. So she turned the patient coronal, and here is that anterior part of the kidney, lots of flow, posterior part of the kidney, no flow. And again, this is a patient who had a living-related donor. It had multiple arteries, and some of the arteries were just not working. Another patient, no urine output post-transplant, so that's going to be an immediate call for ultrasound. And the waveform we see here is quite different, right? We see a very, very sharp upstroke here, and we have reversed flow in diastole. And when we check here in the transverse image, you can see flow in the artery, again, that same waveform. No flow in what? No renal vein. Make sure you check the iliac artery. Yes, that's okay. That's got a normal triphasic waveform here. Iliac vein is patent. So this indicates renal vein thrombosis. And again, this is a surgical emergency. Occurs very early on. You can salvage the patient with early detection. The criteria are that absent venous flow. If you see that, that's one very helpful thing. A dilated vein with thrombus, as John just showed you in the natives. And this reverse diastolic flow in the intrarenal arteries is very useful in the transplants. Note that it also can occur with some other things like rejection or compression syndrome, but it's basically a sign of renal vein thrombosis until proven otherwise. So this is your call to take this patient back to the OR. Here's another patient, same idea here, nothing in the renal vein, and we can see that that's another case. Here is your first question. We're testing short-term memory today. So this waveform in the renal arteries indicates arteriovenous fistula, chronic rejection, renal artery stenosis, or renal vein thrombosis. And the answer is renal vein thrombosis, basically until proven otherwise. Renal artery stenosis, you would not expect to see this reverse diastolic flow. So renal vein thrombosis can occur actually asymptomatically. This patient had a transplant 6 weeks ago, had a rise in creatinine. We did an ultrasound, and you notice on the grayscale that there's this little echogenic area here sitting in the vessel, and when you put the color on, you can see flow goes around it. This patient was asymptomatic. The rule is you can't make those people better. They did not actually anticoagulate, and this transplant went on to survive for another 7 years. Now, as I said before, this waveform is not completely specific. It's very sensitive for renal vein thrombosis. So the question here is what's going on. This patient, you can't see any diastolic flow. It's reversed. Again, you don't see a vein. If your sonographer says renal vein area, that's a bad sign. So the patient was returned to the OR, and the transplant was repositioned. And following the repositioning, it looks like this. Normal waveforms, normal renal vein. So I've entitled this renal vein compression, and this is part of something that we've learned about recently. It's called transplant compartment syndrome, and it's related to an ischemic injury, and the transplant swells from reperfusion and basically sort of outdoes its space that it's in. The Doppler findings will mimic renal vein thrombosis, but the surgery is the same. They have to go back to the OR. The surgical pressure relief preserves the function in the transplant. Here's just another example. Main renal vein area, no flow in the renal vein, reverse diastolic flow, goes back to the OR, everything is beautiful again. So there's another form of compartment syndrome that can occur, and it's very different. You can see here, look at these are very tardus parvus waveforms. We shouldn't be seeing this at all. You can see in the hilum, again, slightly tardus parvus, lots of diastolic flow here. And what you need to do here is to look for an obstructing lesion, and when you look down, basically down towards the anastomosis, you found an area that was very, very high velocity, and the ratio was over 3 to 1, similar to what Dr. Pellerito was talking about. So your diagnosis here, sort of too early to have a stenotic anastomosis, and the anastomosis is way over here. So this is another compartment syndrome. This is actually a kink, and it's arterial compression form of the compartment syndrome. And again, treatment is the same. The patient needs to go to the OR and have this relief. So an abnormal resistive index, we just looked at a couple of them. I didn't title them as such for you. It can be from a number of things. So we're looking at what's happening in the flow out here in the parenchyma of the kidney. Normal, we said, should have a nice diastolic flow. This has no diastolic flow here whatsoever. So that can be due to edema in the parenchyma. It can be due to ATN, infection, rejection. We saw obstruction of the renal vein, and even extrinsic pressure. Some fluid collections can do this. And we've also seen a little bit of diminished flow. We'll get into that in a little bit. This patient, when you look at this, you really can't see the cause. But when you look at it carefully, actually, this patient had a compressive hematoma, and the border of the kidney actually is right here. So just to give you another example, this patient, where is the kidney? Very, very high resistance waveform here, high resistance, RI is 1, here's the renal flow. And when you look at this, when your sonographer puts the cursors on it, this looks like it's a kidney. This is all a hematoma. This is the kidney right here, all compressed by this hematoma, and when that was evacuated, you can see that, again, returns to normal. So the kidney looks much better without all that pressure. Another cause of a high resistance waveform, one that's pretty common, again, this little bit of reverse diastolic flow you can see here, but you're going to look for what? Renal vein, right? Is this renal vein thrombosis? Beautiful renal vein. So this happens to be acute tubular necrosis, which is a very, very common complication of transplants. It occurs in over 30%. Up between 10 and 30% of those will need dialysis, and it's related to how long the kidney has been outside of the body, basically. Recovery is usually in 1 to 2 weeks. These people do very well. In addition, you can see these elevated resistive indices from drug toxicity and either from cyclosporin or tacrolimus. And the last thing I want to talk about in terms of elevated resistive index has to do with rejection, which is actually pretty common. So hyperacute rejection, fortunately, is very, very rare, but if you see, again, this very high resistance reverse diastolic flow, but you've got renal vein in the hilum, you could be thinking about ATN, but in this patient, unfortunately, she had received a living-related donor from her husband, and she had become sensitized to him through a pregnancy. They had RH incompatibility, and at that time, they were not doing HLA testing for that. So he gave her a kidney, which she immediately basically rejected when it became hypercoagulable, DIC, etc., and the kidney had to be removed. Acute rejection is a lot more common. Up to 40% of patients, it peaks at 1 to 3 weeks, and it usually spares the glomeruli. So these patients will have that elevated resistive index because it's the rest of the kidney that's involved. They get an interstitial edema, often with hemorrhagic infarction, which I think is what's going on with this patient. These areas that are bright and acrogenic here are probably areas of hemorrhage. You can see also that the urothelium is thickened and inflamed as well. And chronic rejection, this is sort of an unusual case from the AFIP where I worked for a year, and you can see that there are actually areas of calcifications called osseous metaplasia. These patients, it's multiple episodes of rejection that have gone on for a long time. Usually what I see in chronic rejection is the transplant just gets thinner and thinner and thinner. It looks like those kidneys that Dr. Cronin showed you with the very, very thin cortices, but these patients can actually go on and ossify as well. An elevated renal transplant resistive index indicates an arteriovenous fistula, nonspecific graft dysfunction, an infarct, or renal artery thrombosis. Nonspecific graft dysfunction, which is why we need to do biopsies. Most of the time patients will come in with elevated creatinine or their transplant's not doing well. Occasionally, if they're doing some experimental therapies, we'll do some prophylactic biopsies before they change therapy or withdraw steroids. And the procedure's been reviewed for you. It's ultrasound guided, local anesthesia. We want at least 2 or more cores, and you need the cortex, not the medulla. And we want to use post-biopsy images to check for bleeding. And I can tell you that almost everybody that you stick a couple of times in the kidney, it's a high-pressure system. They're going to bleed. Most of the time we don't see it, and if we do see it, most of them are small. So I'm just showing you an example here. And this position for this biopsy, not too bad, right? It's mostly through the cortex. Some of them, however, are big, and this patient, you can see the biopsy going through here. What's wrong with it? It's a little too deep. Here's the hilum here. So you have your new nephrology fellow putting the needle in, and sometimes they get very aggressive. So unfortunately, a day later, you can see this large hematoma sitting right here. What's important, though, is that it's actually not compressing the kidney. You can see a normal waveform here, good acceleration time. One more thing about planning your biopsy. Okay, this patient, his kidney looks fine. We're going to go to the lower pole. That's the closest. Maybe go like this. Turn on the color. You do not want to biopsy something that's infarcted. So you can see very clearly, even with color Doppler, you don't necessarily have to use power. This whole area of the kidney is infarcted. You will just get nothing on your biopsy. You'll just get fibrosis. So you want to replan your route. And so it was changed to the mid-kidney. And how about this biopsy? Too deep, right? Post-biopsy, a new artery has appeared, which can just spout out there if it wants to. And in addition, a new waveform has appeared. You can see here's the arterial flow going towards the transducer, and down here is this arterialized venous flow going away from the transducer. And these are very common post-biopsy. You may or may not see them at the time of your biopsy. The patients can present with hematuria, but most of the time these are small and asymptomatic, and they'll resolve on their own. And you identify them, as Dr. Pellerito showed you, by that focal aliasing that you can see here. This low resistance arterial flow, you can see here the resistive index is less than 0.5, and here on the venous flow, the outflow, you can see an arterialized waveform quite clearly. So just an example, you may not see them right away. Here is a routine biopsy was done here. You can see the area of the biopsy. Looks like nothing there, right? 2 days later, ooh, should you panic? No. Here is basically the arterial flow. Here's the venous flow. 4 months later, completely normal. No therapy. So, your next question. Arteriovenous fistula and a renal transplant. A is a rare sequelae biopsy. B is identified by a high resistance arterial waveform. C requires retransplantation. Or D usually resolves spontaneously. The answer is D, usually resolves spontaneously. Okay, pseudoaneurysm, as Dr. Pellerito, is much less common than AV fistulas. You can see a nice one here. The appearance is the same as a pseudoaneurysm anywhere else, and you want to manage it conservatively if possible. I'm going to turn now to something that's a little bit controversial, and that's renal artery stenosis. In the literature, it says it's between 1% and 8% of cases, usually at the anastomosis. So we're going to be talking about it like we're thinking about renal artery stenosis in the natives. The clinical presentation is sort of similar. It's either refractory hypertension or progressive renal impairment. It's often in the first 2 to 3 years post-transplant. It can, of course, happen earlier or later. We screen. Ultrasound is your screening modality. So this is where, even if you're not a transplant center, you may be called upon to do surveillance for these patients. And the confirmation is usually with MRA or CTA. So the question is, can we use the same criteria that we use in the native kidney? And the answer is actually not. In the native kidney, we use a peak systolic velocity of 200. In the transplant, you can see it's all over the map. Next question, what about the ratio? In the native kidney, we use the 3.5 ratio. In the transplant, there was one guy from South America who used this very low ratio, but it was positive for 50% lesions, which may or may not be significant, okay? More recently, this group found a 3 to 5 to 1 ratio, same as we use in the native, very useful, again, for a fairly significant lesion, 80%. And what about the intrarenal criteria, the tardus parvus waveform? A couple of different acceleration times, but also variable reliability, similar to what we've seen in the natives. Here's an asymptomatic patient, so we're not going to make this patient better, okay? Velocity 280, that's high. When you look at it with grayscale, it's even higher, 300, but the iliac artery was only 144, so it's not barely even a 2 to 1 ratio. The other thing is when you look at the renal arteries, our native renal arteries come off at sort of 90 degrees. The transplants often come off at this 180-degree curve, and the fluid has to accelerate to get around that curve. So depending on how you sample this, you may have a lot of trouble. The other thing is this is nearly parallel to your transducer face, so you have a very bad angle here. So here the anastomosis, 500 centimeters per second, iliac 153. That would be a 3 to 1 ratio, right? When you maneuver around and get a better angle on the vessel anastomosis, only 224, so now it's normal. So you have to be really careful with your technique. And the last thing is, you want to make sure that always with Doppler that your grayscale agrees. Again, transplants give us a great opportunity. They're superficial. We can use high-resolution probes. So you can see here, 428 centimeters per second in that velocity, but it's wide open on grayscale. And again, ratio is normal down here. So if the peak systolic velocity doesn't work, what about the intrarenal waveforms? Well, I'll just give you some examples. One thing that I find happens is my sonographers tend to sample a little too far out. They tend to be out here in the parenchyma rather than the hilum, as Dr. Colorito was suggesting. And when you do that, you can artificially make tardus parvus waveforms. If you look carefully, the early systolic peak is right here. But your eye tends to go around. So this looks rounded to you. But when you look here, 6 months later, better sampling, normal. What about timing? We all know that the anastomosis is going to give us some edema, and the velocities should decrease over time, and this has been proven in the literature as well. But lastly, numbers mean nothing without symptoms. If the blood pressure is controlled, nobody's going to do anything. So here's somebody with a very, very elevated velocity, 384, it's at least 2 to 1, it goes towards 3 to 1, and medical management only, velocity came down. Now, if the patient isn't doing well, then you really need to go on to another modality. So this patient has a Brui, he's 6 months post-transplant, and you can see here again the velocity 440, well above our 350 threshold, even if you use the highest that they got in the literature, and definitely more than a 3 to 1 ratio here. You can see here that there's a kink here in the iliac, and also it's narrowed here at the anastomosis. However, they decided it wasn't enough to treat, and no intervention, and you can see here velocity, again, came from 635 down to 135 over 10 years. So it doesn't matter. And this is sort of interesting. This is the National Transplant Database. They say we have an 8% incident of renal artery stenosis. I don't see that at my institution. About 20% had angioplasty, and it made no difference in either their blood pressure or their renal function after the angioplasty. They did find that in the patients who had renal artery stenosis, there was an increased risk of graft loss. And here in a single center study with less patients, about 2/3 had angioplasty, 1/3 with conservative therapy, and there was no difference in graft loss or death. So I'll just close with this one for you. Is this renal artery stenosis? So you can see a tardus parvus waveform here. Also at the anastomosis, velocity within normal limits, right, for our threshold of 350. And you can see here iliac artery velocity 191, so no significant ratio. Notice that the iliac artery is also abnormal. And so this should make you do what? you want to look upstream, and this is a significant iliac artery stenosis. And they may choose to treat this or not treat this depending on how the patient is doing. This patient had a transplant 5 years ago. This is a little bit late, but now he's hypertensive, very, very high velocities, confirmed with an angiogram and successfully angioplasty. So I want to leave you with this. A ratio of 3 to 1 or greater is more useful in my experience than an absolute number. And the 2 to 1 ratio that's in the literature probably is not significant because it's only for a 50% lesion. They're not going to treat it. If you're using a peak systolic velocity, correlate with the patient population. If it's symptomatic patients, you might want to drop down a little bit, but for an asymptomatic patient, I would be up to 300, 350 at least. And I would use the ratio to add to my specificity. I'm going to move quickly through the rest of the things, which are the ureters and the fluid collections and the tumors. So early on, you can get all kinds of things from edema, blood clots, later stenosis, and so forth. What I want to emphasize here is that patients who have transplants often have hydronephrosis. This is a collecting system that's dilated, but the bladder is full. And when you empty the bladder, post-void, no hydro. This patient, some hydronephrosis, later, nothing. So these patients often have variable degrees of distension of their collecting system. How about this patient, pre-biopsy? You can see some cheliactisis here. This looks a lot worse. It was about 10 minutes later, but it was post-void. This patient has reflux. And here, after the biopsy, there's no hydro whatsoever. So beware. These patients can reflux, and then they have a capacious collecting system. The patients I worry about are those with new hydronephrosis and abnormal renal functions, and in that case, you want to do renal scintigraphy, or in this case, we did a nephrostogram and showed that there was a severe stenosis that needed angioplasty. The fluid collections basically look very similar. Part of them are going to depend on how soon after the transplant. Urinomas, not that common. The thing to remember there is if it's a new or enlarging collection with an elevated creatinine, think about a urinoma, especially if the patient is developing hydronephrosis. Here's some hydronephrosis, a little fluid, not specific, but the creatinine was rising, and the patient goes on to nephrostogram, which shows the leak. It's the nephrostogram or the nuclear medicine study that's going to show you the leaks. Again, rising creatinine, suspected urinoma, even if you don't see any hydronephrosis, because the patient can be decompressed. And large urinomas certainly can happen without hydronephrosis. Hematomas, we looked at a little bit with biopsies. The thing about hematoma is acutely they look solid. So the clue here is this transplant's too deep. You don't see anything here, right? Waveforms are fine. 2 weeks, now you're seeing this. Is it a new hematoma? No, it's an evolving hematoma. So it was there all along, and here it is at 4 weeks. It is anechoic. It has some little bit of debris. It's basically progressing. These usually go away on their own. When you need to treat them are when the patient is at risk. Here's a patient with a falling hematocrit. Again, the kidney looks okay in terms of the perfusion, but you've got this swirling blood in here, and she needs to go back to the OR. How about this? This is a hematoma, 6 months post-transplant. Well, that's an unusual time to have bleeding, right, unless you've had a procedure. So you can see this fluid collection that has septations, but this is a common time to see a lymphocele. So these are these patients who have disrupted lymphatics along the vein, frequently in the first couple months post-op, but often later as well, and you'll see these internal septations. The complications rarely are compression or infection. Most, again, will resolve spontaneously, as this one did. You can see here all the fluid is pretty much gone. Here's some vessels passing through one. Again, normal waveforms tell you that the transplant is not impacted. Is there intervention needed here? Well, this one is large, and it's actually pushing the kidney. When you get a lot of things going on and you can't see the relationships, I'd encourage you to go on to CT. Even if you don't give contrast, and you can see that this is displacing, compressing the kidney, and actually displaced the bladder. So this one needed to be drained. This one is very large as well, obstructing new hydronephrosis, so this needed to be drained also. And lastly, abscess. You can recognize them sometimes by the thickening along the wall. Otherwise, they have these septations, and we are not very good at telling that something is infected. And if you think it is, again, go to CT, Give the patient some contrast to be sure. If you see things in multiple locations, can't connect them by ultrasound, don't hesitate to go to CT. Here's the kidney. Here's a strange collection with these echoes in it. And you can see here, this looks like bowel, doesn't it? So that was in the other quadrant. And this was just a huge abscess that wrapped around. You can see the gas here. Here's the kidney. So again, extensive disease, go on to another modality. Just a reminder that not all gases necessarily means you're going to lose the transplant. Here's a patient with some echoes. Here is a little bit of a twinkle artifact from the gas, thickening the collecting system. Patients in gram-negative sepsis. So this is actually emphysematous pyelitis involving the collecting system, but the parenchyma is okay. And she did well with antibiotics. Here she is later with some contrast, a little bit of pyelo still left. Unfortunately, if you have emphysematous pyelonephritis involving the entire kidney, as you can see here, you can see it on the plain film as well, this unfortunately is not salvageable. And I'm going to give you about 1 minute run through with tumors. As we all know, these patients are immunocompromised. They are at risk for post-transplant lymphoproliferative disorder. It's mostly non-Hodgkin's lymphomas related to Epstein-Barr virus infection. And by ultrasound, we see a solid mass that's vascular. And remember, it's a pre-lymphoma, basically, so you require a core biopsy if you're going to biopsy it. And just an example, hypoechoic mass almost looks like fluid. You've got to turn on the color anytime you see something that looks like a cyst. And you can see it's vascularized. Here it was on MR. And with reduction in immunosuppression, this patient recovered. Not all patients are so lucky. They have risks not only of lymphoma, but renal cell, transitional cell, melanoma, etc. And again, diffuse large cell lymphoma, this one could be a PTLD, but it persists despite immunotherapy reduction. And you can see again the flow, this kidney came out, and you can see the mass here as well. This patient had a biopsy, and it came out as renal cell. We also saw a mass in the liver, and unfortunately, at final path, it was PTLD, which would have altered his course. So again, remember to be careful with your path, make sure you do course. Renal cell carcinoma looks like renal cell carcinoma from the natives. It gets adenopathy, it invades vessels, compresses the cava as this one does, and has a poor outcome. And the tumor may not be in the organ of interest, it can be separate. Here's a colon cancer, also a B-cell lymphoma in a patient with a transplant, and you can see this responds nicely to chemotherapy. And as I said, the native kidneys can also get renal cells, as this patient did who had lupus and a renal transplant. So ultrasound is essential to diagnose and monitor our complications since the allograft malfunction is nonspecific. We use grayscale to look at the identification of mass lesions, look for hydronephrosis, fluid collections, and abscess collections. Doppler detects stenosis or thrombosis, tumor vascularity, infarcts, and fistula, and we use biopsy to diagnose rejection, drug toxicity, as well as focal lesions.
My name is Wei Chong. I'm at MD Anderson Cancer Center, Houston, Texas, and I'm going to talk about renal transplants. Okay, renal transplants. So the one-year survival rate for renal transplants is now 80%. 80% of transplants are from cadavers and 20% are from living donors. Transplants are placed extraperitoneally in the contralateral iliac fossa. And this is a graphic showing how a left kidney is placed. It's usually in the right iliac fossa. And in this particular case, the anastomosis is an end-to-side renal artery to the external iliac. Here is an alternative way of anastomosing the renal artery. Here it is going into the internal iliac artery, and the anastomosis here is going into the external iliac vein. So sonographic assessment of renal transplants. First point I want to make is that Doppler ultrasound is the first-line imaging modality for evaluation of renal transplants. We use grayscale, first of all, to look at renal parenchymal echogenicity. We look at the collecting systems and ureters for hydronephrosis to diagnose obstruction. We look for perirenal fluid collections. We use Doppler to look for flow in the renal artery and the renal vein to look for obstruction. Then we look for peripheral resistance in the renal artery bed as a marker of graft dysfunction. And the metric we most commonly use is the resistive index, or RI, which I will refer to in the rest of my presentation. And we use color and power Doppler to assess renal perfusion. So Doppler assessment of renal transplants. The resistive index, or RI, is the main parameter for peripheral resistance. We use the acceleration index and the acceleration at time obtained from the main, segmental, and arcuate renal arteries. We obtain angle-corrected velocities from the main renal artery and iliac artery, and if main renal vein stenosis is suspected, we obtain angle-corrected velocities from the main renal vein. And most but not all of the problems related to vascular obstruction occur at the anastomotic site. So that's where you want to focus your attention. So a couple of words about the resistive index. The resistive index is a measurement of peripheral resistance within the renal artery bed. It is independent of angle correction. And high resistance indicates renal dysfunction. A normal resistive index is less than 0.7. Between 0.7 and 0.8, it's indeterminate. And above 0.8, it's abnormal. These are not hard and fast numbers. This is a kind of soft categorization. And it's particularly important to observe the trend in the resistive index on serial scans rather than rely on a single measurement. I.e., you should see if the RIs are rising on serial measurements or falling. And the most severe form of elevated peripheral resistance is when the diastolic flow is reversed, as on this image here, where you have forward flow in systole but reversal of flow in diastole. This indicates very high resistance and is a sign of severe abnormality. The color Doppler analog of this is what I call a red-blue flashing. Basically, you see the renal artery in red during systole and blue in diastole, and it flashes red, blue, red, blue. Power Doppler allows visualization of smaller arterial branches and parenchyma, and you can, to a certain extent, assess cortical perfusion. Here you see a normal renal transplant colored with beautiful colorization with the Power Doppler, and you can see flow all the way to the edge of the cortex. This is a brief review of the complications of renal transplantation. Vascular complications can be in the artery or the vein, and you can have false aneurysms and arteriovenous fistulae. You can get ureteric obstruction, fluid collections, extrinsic compression. So these categories overlap to a certain extent. So extrinsic compression can lead to arterial and venous obstruction. There's an entity known as compartment syndrome, which I'm going to talk about a little bit. And then there's renal parenchymal disease, which is a catch-all phrase for rejection and acute tubular necrosis and immunosuppressive drug toxicity. And then finally, we'll talk briefly about transplant-related malignancy. So the vascular complications, starting in the renal artery, you can get a stenosis in the renal artery. That usually occurs at the anastomosis, and that presents on Doppler as elevated velocities at the site of narrowing and tardus parvus waveforms distal to the point of stenosis. A renal artery kink is a folding or twisting of the vascular pedicle due to malposition or lack of space. So if the renal artery is a little bit tortuous and the surgeon packs it into a kind of small space, it might kink. And this is a form of compartment syndrome. It usually presents immediately post-surgery and has the same sonographic signs in terms of Doppler as RAS. It's easily correctable, so it's important for us to pick it up. The renal artery can thrombose. The renal vein can be thrombosed and also stenose, and you can get AV fistulae and false aneurysms. So renal artery stenosis in the transplants. It is less common with cadaveric allografts because a cuff of aorta is harvested during a cadaveric transplant, allowing larger caliber anastomosis. Doppler ultrasound is essentially a kind of screening tool because it's highly sensitive for renal artery stenosis, but it tends to be less specific. So if you get a positive Doppler ultrasound finding, then the patient will proceed to CTA or MRA. So the Doppler criteria that are out there are peak systolic velocity of greater than 3 meters per second, renal artery to iliac artery peak systolic velocity ratio of 1.8 to 1, greater than 1.8 to 1, and TARDIS parvus waveform with an acceleration time of greater than 0.1 seconds. There is some early data out there to indicate that contrast ultrasound may be as sensitive as Doppler, but with higher specificity, and we're probably going to see a lot more of that in the years to come. So here is an example of renal artery stenosis. Here we have the Doppler cursor at the anastomotic site, and we see a very high peak velocity of 7.7 meters per second and a very turbulent waveform. This is the same patient, and now we have our Doppler spectrum from the intrarenal arteries, and this is the classic TARDIS parvus waveform with a slow rising early systolic spectrum. And this is another patient showing how the TARDIS parvus waveform can change or improve after treatment. So here's a patient with renal artery stenosis on the left. This is the intrarenal artery waveform showing TARDIS parvus. The same patient after successful angioplasty, and the TARDIS parvus has gone away. You got a nice sharp upstroke in early systole. Renal vein thrombosis presents with the following signs. The kidney may be enlarged. You may get reversal of diastolic flow in the renal artery, and you may get absent or monophasic flow in the renal vein. In the example I have here, you see the cursor and Doppler cursor is on the renal artery, and you have reversal of flow in diastole, very high peripheral resistance, and the arrow here is pointing at the thrombosed renal vein, which is this hypoechoic structure over here with clot inside it. Renal vein stenosis presents with elevated velocities, and in this case we see a stenosis at the renal vein IVC anastomosis, and we have a peak velocity here of 2.1 meters per second. You may also see elevated RIs within the renal artery caused by the outflow obstruction here. There aren't any precise figures for renal vein stenosis as they are for a diagnosis of renal artery stenosis because it's a relatively rare entity, but it's something you want to look at if you have someone who has a very high RI with no visible cause, and you see on color Doppler an apparent focus of elevated velocity in the main renal vein at the point of anastomosis. Infarcts in the transplant kidney may show up as filling defects on power Doppler. This is a case here of an infarction which shows up as a wedge-shaped filling defect on this power Doppler image. Power Doppler is more sensitive than color Doppler for low flow states, but generally speaking, we are not that good at picking up infarcts with our standard ultrasound techniques, although contrast may change that in the future. False aneurysms and AV fistulae. Now, I've put them together because they have some features in common, although they are quite separate entities in terms of their flow dynamics. First, they're most commonly secondary to transplant biopsy, although they can be a surgical complication. You can get this multicolored or mosaic appearance where you have red, blue, green, yellow, a kind of red, blue, green, yellow blob in the area of the aneurysm or AV fistula. This is caused by turbulence. This is the color analog of spectral broadening. And it may be difficult to differentiate a false aneurysm from an AV fistula. They may be difficult to distinguish from each other if they are small. So this is an example of a false aneurysm, and this is a particularly dangerous one because it is outside the kidney. So here is the transplant kidney, and we see a cystic area on the gray scale outside the kidney. And when we turn on the color Doppler, this is the renal artery heading into the hilum, and we see the classic yin-yang waveform filling the cystic area here. And this is a saccular aneurysm of the renal artery. This one was a surgical complication, not post-biopsy. And this kind of aneurysm is more like, this kind of post-surgical false aneurysm is more likely to rupture, because it's unlike the false aneurysms that occur inside the kidney as a result of biopsy, there's no renal parenchyma to buffer it. This is a post-renal biopsy arteriovenous fistula. These are very common in that they occur in 10% of biopsies. The Doppler findings are focal high velocity, low resistance, and turbulent flow. And on color Doppler, you may get the tissue reverberation artifact. That's something that Dr. Kluwer mentioned during his talk. Basically, you get a false Doppler signal due to tissue motion from the adjacent turbulent flow. So here you have the mosaic pattern. That multicolored area represents the AVF, and you get all this false color, which is the tissue reverberation artifact around the AVF. And you may see arterial waveforms in the renal vein. And in this case, we see a turbulent Doppler spectrum. No treatment is required if the patient is asymptomatic, but embolization may be necessary if there is hematuria or renal failure. Here is another example of an arteriovenous fistula, and this patient, here we have the Doppler spectrum on the renal artery. You can see very high velocities in that renal artery branch, 6 meters per second, spectral broadening, and very high flow during diastole. Ureteric obstruction in a transplant has multiple causes, but it most commonly occurs in the distal ureter at the anastomotic site due to ischemia or fibrosis. It can be caused by external compression from fluid collections or hematomas, from kinking, fungus balls, papillae, or calculi. And there's an increased incidence of calculi in transplants. Hydronephrosis is not always synonymous with obstruction, because hydronephrosis due to reflux from a full bladder is commoner in transplants than in native kidneys, because the UVJ valve doesn't exist to the extent that it does in a native kidney and ureter. So hydronephrosis does not always imply obstruction. One of the complications of ureteric obstruction at the anastomosis is that it can lead to leak at the anastomosis and a urinoma. So here we have a transplant kidney with hydronephrosis and a dilated ureter down to the level of the anastomosis, where there is a stricture, and and here is the bladder here. So I'm just going to briefly cover the causes of elevated resistive indices or elevated peripheral resistance inside the transplant kidney. You can put them in two broad categories. There's parenchymal disease, which is rejection, ATN, immunosuppressive drug toxicity, and pyelonephritis. And the take-home point here is that ultrasound cannot distinguish between these, generally speaking, between these entities. Then there are the morphological causes: renal vein thrombosis, ureteric obstruction, extrinsic compression due to hematoma or compartment syndrome. And what ultrasound can do is it can distinguish a morphological cause from the parenchymal causes. Renal transplant compartment syndrome is something that's not well recognized in many places, but it is now not well seen in many places, but it is a recognized entity. And it is defined as graft failure from extrinsic compression due to confined space at the transplant site. Basically, the kidney is too big for the space that the transplant surgeon is trying to fit it into. So he packs it in, and the kidney is under pressure. And it usually presents immediately post-op, and it is defined as pressure of greater than 20 millimeters of mercury on the transplant kidney. The Doppler findings are variable. It depends on which part of the kidney and the vessels is being pressured the most. So if the entire kidney is being globally pressed, you might get elevated resistive indices because of increased resistance to flow. If the renal artery is being squeezed and kinked, you might get focal narrowing in the renal artery and elevated velocities, as I described earlier. You generally get reduced renal vein velocities. So this is now becoming more and more well recognized, and in fact, there's actually a society dedicated to this entity of abdominal compartment syndrome. It's called the World Society of Abdominal Compartment Syndrome, and they actually have ambassadors to go around the world and spread the gospel about ACS. So I thought if I wasn't a radiologist, I might like to be an ambassador and go to a party and introduce myself as the ambassador for the World Abdominal Compartment Society. So it is a very well-recognized entity, and they have a convention. Next one is in Ghent in Belgium. Okay, so how does it look? Well, if the kidney is being compressed, you're going to get elevated RIs. But when you turn on the power Doppler, you should look for something like this. So here's a patient with an RI 1.0 because the kidney is being squeezed. And on power Doppler, you can see that the orange color does not extend all the way to the capsule, unlike in this patient here, where the RI is normal. And this is a sign usually that you are dealing with a situation of elevated peripheral resistance, and that prevents the color from the power Doppler from going all the way to the edge. And this, of course, an extreme case when the artery is completely occluded and you have no power Doppler signal at all. Here's another type of, another variation of compression, if you like. This is a subcapsular hematoma compressing the kidney. Here is the transplant kidney. Here is kind of bowed in a kind of arch-like manner. Here's the collecting system all collapsed, and it is caused by this lenticular fluid collection, which has a fluid level. It's actually a hematoma that has partly liquefied, and when we put the Doppler on the renal artery, we see reversal of diastolic flow in the renal artery due to renal compression, and this is called a page kidney because this is a subcapsular hematoma. It's pressing on the kidney, and it is causing high resistance to flow within the renal artery. Okay, so I'm going to just briefly cover renal parenchymal disease. Acute rejection. This manifests as a rapid rise in creatinine, greater than 25% over 24 or 48 hours, decreased urine output, and definitive diagnosis requires biopsy. So there are some features on grayscale ultrasound. You might see features of renal edema. The kidney may be big. You can get thickening of the collecting system, the thickening of the urothelium, and you get thinning of the renal sinus fat. The pyramids may become more prominent, and you may see increased or decreased cortical echogenicity. The resistive index can go up, but remember that rejection can be present with normal RIs. So this is a patient during his rejection phase and after he had his treatment. So note the kidney when it was being rejected was much bigger. There's loss of the corticomedullary differentiation. It's much more echogenic. The urothelium is thickened, and this is how he looked after he had been given anti-rejection medication. So this is a sign of renal edema. This is the thickening of the wall of the renal pelvis. Normally it's pencil thin. Here you can see it's at least several millimeters, and this is just a feature of the global edema that you're seeing in the kidney that extending into the collecting system. Chronic rejection is defined as slow deterioration occurring over months or years. And this is something we cannot diagnose generally on ultrasound. There are usually no morphological changes, and resistive indices may be normal. Acute tubular necrosis is characterized by an acute decrease in glomerular filtration rate, an increase in creatinine and anuria that is maintained for several days, followed by spontaneous recovery. It occurs in the immediate post-transplant period. It almost always occurs in cadaver transplants and is directly related to the length of graft ischemia period prior to the transplant. It does not affect ultimate graft survival. On ultrasound, the kidney may appear normal or may demonstrate hyperechoic renal cortex with elevated RIs. So this is an example of acute tubular necrosis, and the only thing that we could see that was the abnormally elevated RI with reversal of flow in late diastole. So the renal transplant patients get drugs to prevent rejection, but these immunosuppressive drugs themselves are nephrotoxic, and these drugs are now the calcineurin inhibitors, of which the most commonly used are cyclosporine and tacrolimus. So although they have markedly improved allograft survival by reducing rejection, they have a nephrotoxic effect that appears as an arteriopathy and a microangiopathy. The nephrotoxic effect occurs even when the serum concentration is within the therapeutic range, and the nephrotoxicity may be acute, subacute, or chronic. Acute and subacute are dose-related, while chronic nephrotoxicity occurs 60 days after the transplant and is not dose-related. On ultrasound, we see echogenically normal kidneys with elevated RIs, and the definitive diagnosis requires renal biopsy. Peritransplant fluid collections can be classified as lymphoceles, which is a leak of lymph, urinoma, hematoma, or abscess. So this is an example of a perinephric fluid collection anterior to the transplant. Hematomas usually occur immediately after surgery or biopsy, and they look like hematomas everywhere, heterogeneous, partly solid, partly cystic masses. Here we see a large perinephric hematoma anterior to the transplant. Lymphoceles are the commonest fluid collection. They occur on a different time scale. They classically happen 4 to 6 weeks after transplantation. They may be asymptomatic or compress or obstruct the kidney and may contain debris or septations on ultrasound. They frequently recur after percutaneous aspiration, and they may require surgery because of this recurrence. Urinomas tend to occur in the early post-transplant period. They are caused, as I mentioned earlier, by a leak at the ureteric anastomosis, and they are associated with ureteric obstruction. They are usually transonic, but may contain debris, and they tend to grow because as the urine continues to leak out. Abscesses are infections of pre-existing hematomas, lymphoceles, or urinomas. They usually contain internal echoes, and the appearance of debris or gas in a pre-existing echo-free collection is suspicious for abscess. So remember, all these patients are immune suppressed, so they may not show classical signs of fever or pain, so you have to be on the watch out. This is an example of a renal abscess. We see a hypoechoic area inside the lower pole of this transplant kidney, and it's got internal echoes, and that this has no internal flow on Doppler, so it's not a mass. And this is the MRI showing a lot of enhancement and internal septations, and this is turned out to be an abscess in the inferior pole of the transplant kidney. I'm just going to briefly mention transplant-related malignancy. It's all in your handout here, but patients who have transplants have a much higher incidence of RCC, 6 times higher. It's mainly in the native kidney. They can also get transitional cell carcinomas and non-Hodgkin's and post-transplant lymphoproliferative disease, which is a B-cell lymphoma associated with the Epstein-Barr virus. This usually occurs outside the transplant. They may get massive adenopathy, and you might see hypoechoic masses. They also get increased incidence of sarcoma, Kaposi sarcoma, and skin cancer. This is an RCC appearing inside a native kidney. The kidney itself is markedly echogenic and shrunken, but so the RCC stands out quite well. I'm going to spend just a minute talking about ultrasound guidance for renal transplant biopsy, which is something that most transplant centers offer to other nephrologists. We try and biopsy the upper or the lower pole, and we find a track where there's no bowel or major vessels in the needle path. So this is the biopsy guide here, these two dotted lines, and the needle will traverse between them. We use spring-loaded automated biopsy needles, and the trajectory should pass through the cortex like this and avoid the hilum. So we tell them, avoid the white stuff in the middle of the kidney. You have to explain that to the nephrologist. The complication rate is low with reported graft loss rate of 0.4 to 1%. This is how not to do a renal biopsy. You can see that the nephrologist needle has gone right into the white area, which is what we tell them not to do. And this is what you don't want to see. And this, you try not to hit the panic button when you see this kind of thing, but you can see an active extravasation from the lower pole. And here are some of the other things that will happen when your biopsies bleed. You can get a perinephric hematoma here. You can get rapid appearance of hydronephrosis. That's always a bad sign due to clot inside the collecting system, and you look in the bladder and there's huge clot inside the bladder. So in conclusion, Doppler ultrasound is the first-line imaging modality for evaluating renal transplants. Doppler can diagnose renal artery and vein obstruction. Elevated resistive indices are nonspecific and can be caused by parenchymal disease and morphological causes. Definitive diagnosis of renal transplant disease requires biopsy. Rejection can be present with normal resistive indices. Thank you.
So, we mentioned Doppler before, and just, a few words about Christian Doppler. He's from Salzburg, Germany. He died in 1853. Interestingly, he was supposed to be a stonemason, but didn't quite have the strength for that. And so he studied mathematics and astronomy, became professor of physics at the University of Vienna, where he formulated the Doppler effect, which, as you know, has lots of different applications these days, including GPS, weather forecasting, and radar guns. He read his paper in 1842 concerning the colored light of double stars. And every time I see that, it just sort of reminds me of a Pink Floyd song or an album. It just, it's so psychedelic. And he described fluctuations in the frequency of sound or light when there is motion between the source and the eye or ear of the receiver, which is the basis of flow and measurement. And I can't imagine he has any idea how we use that these days. It would definitely blow his mind. So let's go ahead and talk about the renal and mesenteric evaluation. I will speak first in general terms about how to optimize the exam. And then I will go into the specifics for each exam. And then we'll do the same questions at the end of the presentation. So what I'm going to do is talk about optimization. We'll talk about criteria and protocols. And hopefully that will improve the quality in the interpretation of the studies that you do. So, of course, these are challenging studies, really more challenging, I guess, for the sonographer, because they're the ones who have to present that data to you and make sure that it's in a format that you can interpret. And so, obviously, using the best equipment with harmonic imaging, I find very, very important to improve the quality of the study. Of course, the other key element here is getting the right views, and I call these money views, and I show these to my sonographers right away when they do these studies. Once they're able to get these views, obtaining the data is relatively straightforward. They know to change the position of the patient from one decubitus position to the other, sometimes even going coronal for the renal arteries to get those views. And you can see here's a look at the right renal artery. And the way we get the right renal artery in its entirety is by scanning through the liver, turning the patient up. And you can see the renal artery in this patient in its entirety. And so it's just a matter of dragging the sample volume from the origin, from the aorta, into the hilum of the kidney to get all the information on that side. Of course, if you optimize the color Doppler and you see a nice homogeneous pattern like that, you know that there's no stenosis. But that requires adjusting your color gain or your PRF so that you would see a stenosis. And here again, renal vein, renal artery, very well seen. For the left kidney, again, it's essentially just turning the patient left side up and using the kidney as your window, and as I'll show you in a second, able to see it extremely well. For the mesenteric arteries, a little more challenging because of the fact that you tend to go midline. You can adjust the perspective and where you try to find the abdominal aorta and the branches coming off, but we tend to use a longitudinal approach for those. And that requires having less bowel gas, which is why we fast the patient prior to the study. So again, as I mentioned to you, adjusting the color gain, the PRF, and the wall filter are really key. Adjusting it for that patient, very important. Here's another look at the right renal artery. Again, very well seen. No aliasing, no flow disturbance. So we have a really good idea that there's no underlying stenosis even before we get our Doppler velocity measurements. Here we also notice in this particular case there's early branching of the renal artery. Nice to see the anomalies right away. By adjusting your PRF and looking for flow disturbances, you're able to easily see aliasing when it occurs. And here's an example here of focal aliasing at the origin of the left renal artery, which tells you there is likely a stenosis there, particularly when it's paired with a Color-Brewery artifact. Other things to optimize, making sure the sample volume is relatively small. Okay, and here we're looking at the sample volume in the mesenteric artery, again, small, so it's just in the lumen. You're not getting conflicting signals, overlapping waveforms. Angle correction, always have to make sure it's 60 degrees or less. And make sure when you record those waveforms that you record the whole waveform and you're not aliasing everything. You want to increase your PRF so you can include the waveform on your tracing. Normal waveforms. Okay, obviously, whenever we talk about a different application, most important is recognizing normal. We talked about carotids before. Have to recognize normal velocities, need to know normal waveform shapes. That's how you determine pathology. Even if they miss the lesion, you can sometimes infer the pathology because the waveforms have changed. They're no longer normal. When we talk about the celiac, the renal arteries, they provide blood flow to those high metabolic organs. The liver, the spleen, like the brain, demand continuous forward flow throughout the cardiac cycle. So you expect to see lots of forward diastolic flow. No flow reversal. When we talked about the carotid before, lots of forward diastolic flow. There should always be forward diastolic flow. Same with the celiac, same with the renal and the proximal aorta that provides blood flow to those vessels. And we contrast that with the mesenteric arteries, the SMA and the IMA, which are high resistance in the fasting state. So we see little diastolic flow and sometimes a little bit of flow reversal on those waveforms. And that's exactly what we see in the distal aorta, because distal aorta is providing blood flow to the extremities. And as we'll see in some of our other cases today, high resistance flow, triphasic waveforms are the normal flow pattern in the peripheral arteries. So it doesn't matter what type of Doppler study that we're doing, the approach remains the same. When we talked about the carotids earlier, we talked about looking for plaque, looking at the color pattern, looking at velocities and waveforms. It's really the same thing. Optimizing the image so you can see the plaque allows you to tell right up front whether you expect that there's going to be a stenosis or not. A lot of plaque in the aorta, particularly near the ostia of the vessels, really clues you in that there's probably some disease there. And then it's just a matter of getting the rest of the information, putting your clues you in that there's probably some disease there. And then it's just a matter of getting the rest of the information, putting it on your color, looking for the flow disturbances, and sampling where you see abnormal flow. Some quick examples here, looking at the renal artery, seeing plaque. Even here, it's relatively hypoechoic plaque, good resolution. Seeing the plaque, seeing the narrowing, even before you put the color on, allows you to make a determination there's going to be something there. And also looking for other things, looking for evidence of dissection, looking for a flap, looking for fluid around the aorta, looking for other things that are abnormal, like an aneurysm. All important parts of the exam. Turn the color on. And here in this case here, we can see that there's stenosis in the celiac artery, there's narrowing, there's aliasing. Like I said, with a high-grade stenosis, you'll see Color-Brewery artifact, and it allows you to be fairly certain you have an abnormality, usually flow-reducing lesion. If it's occluded, you optimize it, look for the absence of flow, and you can also look for collateral vessels, which confirms to you, again, that there's a problem there. When you see the collaterals and no flow in the main vessel, clearly then that means that it's occluded. The criteria, just like with the carotid, we say the main velocity criterion, the peak systolic velocity, is where we start. But we augment that by looking at the ratio and by looking at the waveforms. And I find that by combining those, you really have a high accuracy. It's the same principle. Don't rely just on the numbers. put the whole picture together. You've looked at the grayscale, you've looked at the color. Now you have these other features that will confirm for you that it's a significant stenosis. By combining that information, you're going to have very high accuracy. In general, for the celiac, for the IMA, for the renal, we use a velocity cutoff of 200 centimeters per second. The only exception is the SMA, where 275 works better. Bear in mind, as we said before, velocity cutoffs don't work for all patients, particularly very old patients or very young patients. As we said before, younger patients typically have normally high velocities that may be surpassing the threshold. Very old patients with cardiac disease may have relatively low velocities, which may not make the cutoff for you to decide it's a significant lesion. Which is why we like to incorporate velocity ratios. When you have very high flow or very low flow, the ratios can help you in those situations. And when that ratio is greater than 3-to-1 or 4-to-1, then you can now start to be very suspicious it's flow reducing. And the icing on the cake are these post-stenotic waveforms. You know, this shaggy waveform, that sort of picket fence appearance that you get in the post-stenotic area, is the confirmation that it's flow reducing. We see these distal to just about every significant stenosis. We say it's bidirectional because, as I mentioned before, when those red blood cells come spilling out of the stenosis, they're moving at different velocities in different directions, giving you that chaotic appearance. So, you know, some people call it shaggy picket fence. My friends at Cleveland Clinic call it Bart Simpson hair. You know, it all looks the same. And in general, they tend to have very low velocities because as they shoot out, not only are they losing energy, they're losing pressure and they're losing velocity. So you can go from a very high velocity waveform in a stenosis to this turbulent low velocity waveform in the post-stenotic space. Now, we also mentioned tardus parvus waveforms, and that's that slow rise to systole that we see in the post-stenotic area. Now, this is typically a little bit further down from that post-stenotic signal. The post-stenotic signal is that shaggy one, and if you go further downstream, then you start to see that the red blood cells start to reform that flow pattern, but it has that slow rise to systole. And you learn to recognize that. You can do that by calculating acceleration time or acceleration index. But in general, I just have my sonographers and my docs look at the waveforms. I want them to look for that TP shape, and when they see that, then they know that it's a tardus parvus waveform. You know, they can calculate it, but I don't find that that's necessarily reproducible, and I want to train their eyes to look for those waveforms. Now, here I borrowed from an article from Ultrasound Clinics, and you can see that with increasing severity of disease, you can see that there's prolongation of that delay. So the first waveform is the normal one, the rapid systolic upstroke, perpendicular to the baseline, and as you get with increasing stenosis, you start to see delay until it's finally completely rounded with a very tight stenosis. Okay, and here's just another example. Here's a patient with a celiac stenosis. The velocity is very high in the stenosis, and as I move it just a couple of millimeters downstream, you can see now it's a disorganized flow pattern. The velocities have come right down. I've got a bidirectional signal with a shaggy pattern. Always look for that. Always make sure your sonographers continue to move the sample volume, because if you get a borderline velocity, say you're looking at a celiac and they give you 210, it's right at the borderline. So you're not going to be sure. So you say, well, what's the velocity in the aorta? So you can compare it. Well, if that's 180, that's probably not a stenosis. But if they give you this really abnormal post-stenotic waveform, then you say, oh, that probably is significant. Because look at the change in the flow pattern across that stenosis. That's the key. So let's start out by talking about the mesenterics. Now, patients who present to the ED with severe pain, where you're concerned about acute occlusion, they're going to go for CT angiography, typically in the ED. But it's the patients that we see that have chronic pain, that's gone through multiple tests. They've had endoscopy, they've had CT scan, there's no diagnosis. They may even give you a history of not enjoying food or weight loss. Then those are the patients that have come to you for the mesenteric exam. And, some will give you the classic history, some will just give you this history of chronic pain. Now, intestinal ischemia, can have different etiologies. It could be related to arterial disease, it could be related to venous thrombosis, or just a low flow state. Now, obviously, if the patient's in the unit and they're not doing well and they have abdominal pain, obviously you worry about shock, you worry about sepsis. But typically what we're looking for is evidence of arterial stenosis, occlusion, or venous thrombosis, and we can do this on our sonographic exams. And in fact, the ACR appropriate criteria puts ultrasound right below CT angiography for these diagnoses, on par with arteriography and MRA. Now, grayscale ultrasound is going to be nonspecific. You may see signs of bowel abnormalities. I think it's always important to look at the bowel. Is the bowel dilated? Is the bowel thick-walled? I mean, there's a lot of information that you can get just by looking at the bowel, even before you hit the color button, looking for ascites. But you can improve and fine-tune your differential diagnosis by adding the Doppler, because if it's inflammatory bowel disease, if it's Crohn's disease, you'll see not only bowel thickening, but increased blood flow in the wall. If it's related to ischemia, you typically have decreased flow in a thick wall of the bowel. So there's a lot of ways to utilize it in these cases. For the mesenteric artery evaluation, we're typically going to look for abnormalities in blood flow in all three vessels, the celiac, the SMA, the IMA, typically dragging the sample volume from the aorta into the proximal portions of the vessels that we see. For the diagnosis of chronic mesenteric ischemia, we need to see abnormalities in at least two of the three vessels. One vessel usually is enough because there's so much collateral circulation that the patient compensates by having disease in only one vessel. So you need to see involvement in at least two of the three vessels to call it chronic mesenteric ischemia. Our protocol, again, we start out with the abdominal aorta, look for evidence of aneurysm, look for evidence of plaque, and then we start to take samples from the celiac, SMA, and IMA. Again, here are the normal waveforms. We mentioned before the aorta is going to be relatively low resistance at the origin of the celiac because it's supplying blood flow to the liver and the spleen. The celiac will also have low resistance flow pattern, like the internal carotid, but the SMA is going to be very high resistance in the fasting state. If you have a low resistance SMA, that means there's either a significant abnormality at the origin of the vessel, or the patient has really cheated and had breakfast or lunch before coming to see you, which is usually the case. If you see a very low resistance pattern, you have to really push them. Did you really fast? And many times they'll say, well, I only had coffee and toast today. I didn't have my cereal and my waffles for breakfast. So to them, that's fasting, but that's not the case. Normal velocity measurements, okay? So we said for the ICA, it's 60 to 100 centimeters per second, and we tend to be in the same range, maybe a little bit higher for the mesenteric arteries. So the celiac is about 100 centimeters per second, a little bit higher for the SMA and the IMA, which is why we have that higher cutoff of 275 for the SMA. So for a flow-reducing lesion, we say the velocity cutoffs are 200 for the celiac and the IMA, 275 from the SMA. That comes from work that was done long ago by Greg Mineta, from the University of Oregon, and that work has held up. Now, I did some work looking at the IMA because I felt the IMA was neglected, and yet you can see the IMA. The IMA is not hard to find if you look for it. The way you find the IMA is by going in a transverse plane down from the celiac, and the SMA, and then you see the renals coming off, and if you continue down inferiorly, you'll see the IMA coming off to the left. It's right there. And if there's significant mesenteric disease, the IMA is hypertrophied and even easier to see. And we came up with the velocity cutoff of 200 centimeters per second. So some years ago, we did a Doppler review of 205 patients, trying to see which of the Doppler criteria worked the best in this examination. So we looked at the peak systolic velocity, we looked at the mesenteric aortic ratio, and we looked at the end diastolic velocity because these are the criteria that are out in the literature. And we found that the best measurement, as we would suspect, just like from our other Doppler studies, is the peak systolic velocity. It performs the best. And that the ratio has a higher specificity, but then it has a sensitivity. So we start out with the velocity, and then we look at some of the other parameters that we talked about. And in terms of diagnosing chronic mesenteric ischemia, the peak systolic velocity performs the best, and we had a 93% accuracy for that diagnosis. So these are the recommended criteria that we use, which we've already mentioned. Look at the velocity, do the ratio in your head, and then look at the waveforms to see if there is a flow-reducing lesion there. And by combining these features, you should have a pretty high accuracy with this diagnosis. Color Doppler will show you the aliasing, the Bruy artifacts. The pulse Doppler will give you the high velocities, abnormal ratio, and the poststenotic turbulence with the tardus parvus waveforms. Here's a 68-year-old presenting with abdominal pain. The celiac has a velocity of 131, so that's in the normal range. The SMA is elevated at 400. And here you can see the Bruy artifact right at the origin of the SMA. And then we go to the IMA. That velocity is also elevated. And you can see here the abnormal flow in the IMA compared to the aorta, which is in the normal range. So you have two-vessel disease. It's classic chronic mesenteric ischemia. Now, there are a number of pitfalls, just like with any study. And I already mentioned the postprandial state. You get higher velocities after patients eat because there's vasodilatation of the vessels to improve digestion. There's increased blood flow to the gut, just as you would expect. So that will increase the velocity, but that's why we have the patients fasting, and it also gives us a better acoustic window. Other things to think about: vessel tortuosity, aneurysmal dilatation, aortic stenosis. These will all be confounding elements. And there's ways to sort through all of these things. The one I want to focus on here is the median arcuate ligament syndrome. I'm sure most of you heard of this before. It's very common, particularly in our younger patients, younger women. This is something that is frequently seen if you look for it. This is caused by a leaflet of the diaphragm that compresses the celiac at expiration. You can see here on the MRA the indentation that occurs across the top of the celiac near its origin, which obviously will elevate the velocity. But that's only seen in expiration. If you have the patient breathe normally or take in a breath, you see that that velocity is usually relieved and the velocities come back into the normal range. Patients get pain probably not from the decreased flow, but from the nerve compression that occurs from the leaflet. And over time, you can get scarring in that area, and I've actually seen fixed defects in patients with median arcuate ligament, particularly in those older patients. And so going to surgery may not necessarily correct the abnormality. So we see elevated velocities in expiration or at rest, relieved with inspiration. Here's my fish hook appearance of the celiac. You can see it's tugged down, and you can appreciate that in real time. You could see the celiac being tugged down as the patient breathes out. And here's the examples. With expiration, the velocity is 450, which you'd call a stenosis, but have the patient taking a breath, and the velocities come all the way down to 176 centimeters per second. Other things to keep in mind: sometimes you'll just pick up another abnormality. Here's a case of a dissection. I've got a number of dissections in my collection. Most of them incidentally picked up. Now, some of them have had a dissection that was known on a prior CT scan, usually an extension of a thoracic dissection that's moved into the abdomen. And sometimes they're picked up incidentally, as this case was. And here you can clearly see a dissection. Even if, the best way to see the dissection is to turn the color off, and you can see the flap. But if you have the color on already, you can see that there's a double lumen there, and you could see the delayed fill-in of the false lumen in diastole. And here you could see pretty well on the CT scan. You can also evaluate patients post-stent. I find Doppler is the best way to look at renal and mesenteric stents. They're very small. It's very hard to tell on MR, which sometimes has so much artifact, or on CT, the luminal reduction of a stent, whereas we actually can calculate the velocities pre and post-stent. And I'll show you again with renal stents. It's really easy to do if you find the stent. And again, turning the color off, you can see the stent pretty well. And here again, comparing it to the other modalities can be very tough. And we're certainly not sending patients to angiography just to confirm patency of the stent. In my last few minutes, I'll talk a little bit about renal arterial disease. Most commonly these patients are atherosclerotic. Every once in a while you get a patient that has another etiology, such as FMD. They can both produce hypertension and ischemic nephropathy. Our protocol, again, we look at the kidneys first, and then we look at the aorta. We get peak systolic velocity measurements from the renal arteries, and then we take waveforms from inside each kidney at the level of the segmental arteries to look at the waveforms. Looking at the kidney first, we look for evidence of atrophy, right? Scarring, look for hydronephrosis, look for stones, and we look for masses. Here's a patient that has a large mass incidentally picked up from the upper pole of the right kidney. And what I do for those is to make sure that it's solid. I put the color on. I could see tumor vascularity within it. If it has high velocity flow, then I get concerned it's renal cell carcinoma, as was the case here, incidentally picked up. We do the direct examination of the renal arteries, getting samples origin, proximal, mid, and distal, making sure angle corrected, easy to review from each side. And then we're going to take waveforms from the segmental branches inside the kidney to look for changes in the waveform that may suggest that there was an occult stenosis that we missed. And sometimes there are duplicated arteries, which you may not have picked up, may have a stenosis. You'll pick it up with the indirect exam. Or once, even less commonly, you can have a segmental artery stenosis you'll pick up with this test. So again, we talked about this earlier. Turning the patient allows you to get the views that you can see the artery in the vein. Here's the left renal artery scanning through the kidney. That's our window. We see it in its entirety. The criteria for the renal exam, again, peak systolic velocity greater than 200, coupled with an elevated ratio. The renal aortic ratio has been around a long time, pretty well established, greater than 3.5, and looking at the Hyla waveforms. Here's a stenosis in the proximal right renal artery. You can see the aliasing there. The velocity is almost 400. And you can see here the TARDIS waveforms inside the kidney. So this is an easy one, because everything's there. Same thing, here's the left renal artery. We see turbulence, aliasing at the origin of the left. The velocity is over 700 centimeters per second, more than 3 times the velocity in the aorta. Classic TARDIS parvis in the left kidney. And if you compare, if you're not sure, you say, is that really TARDIS parvis? Bring up the right side. And the right side has a perfect upstroke with an early systolic compliance peak. See that little peak there? That you see in normal waveforms. So big difference between the waveforms when you're not sure if there's TARDIS. Here's a patient with FMD, and we see it on this MRA involving the iliacs. You can see the beaded appearance. And we also had FMD in the renal artery. Again, FMD occurs in younger patients. It occurs in the mid and distal portions of the artery, unlike atherosclerosis, which likes the origin. So when you have a younger patient, hypertension, when you want to evaluate for renal vascular disease, you need to make sure you see the whole artery really well. And here we have another example of FMD, mid-portion of the vessel, elevated velocities there. Looking at our series, we again found that, like the carotids, complementary findings, the peak systolic velocity very sensitive, the ratio very specific. TARDIS waveforms, not very sensitive. We do not rely on the indirect exam, but when you see them, very specific. So by incorporating this information, you can have pretty high accuracy. People mention the resistive index. I usually don't, because it's like flipping a coin. The resistive index plays no part in trying to determine if the patient has an underlying stenosis. I mentioned about the value in renal stents. Obviously, we can see through the stent, see the high velocities before and after successful stent placement. Also, you can also assess the Hyla waveforms. Here they're abnormal pre-stent, and they go back to a normal appearance after successful stenting. In our study, we came up with a peak systolic velocity of 240 and a ratio of 3.2 to evaluate for in-stent restenosis in our renal arteries. Finally, in my last minute or so, other things, there's lots of other things we see incidentally in the kidneys. We can see aneurysms. We can see occlusion. We can see pseudoaneurysms. And like I mentioned before, we can see tumors. So that's why we include an evaluation of the kidney when we look at the vessels. Here's a patient that has a renal artery occlusion. The kidney is small, it's atrophic. You can see there's barely any parenchyma surrounding the echogenic hilum. We just see a nubbin at the origin of the right renal artery. You don't see the artery at all. correlating very well with the MRA, and you may see flow inside the kidney. But if you do see flow inside a kidney with an occluded artery, it's typically very abnormal, very low velocity, and a very rounded appearance, because this flow is coming in via collaterals. Here's an example of a renal artery aneurysm with the angiographic correlation. Not very common, but you will see them once in a while. They occur more often in women than men, typically middle age. 90% of them are extrarenal. They can be, usually the true aneurysms are related to some connective tissue disease like Ehlers-Danlos, and you typically wait for 2 to 3 centimeters before considering intervention. And one thing we tend to pick up once in a while, patients who present with back pain or hematuria. We may pick up infarcts. Here was a patient that had a history of atrial fibrillation, developed hematuria and pain, and you can see very nicely the wedge-shaped defect in the upper pole on the power Doppler study. Again, a bunch of cases like this. Patient went on to have a CT scan just to confirm the wedge-shaped abnormality on the right side. So I'm going to conclude the presentation by saying we do have a number of different techniques that we can use to evaluate the vessels: ultrasound, CT angio, MR. We've had a very high success rate with ultrasound. The advantage of Doppler is that it determines the hemodynamic significance of a lesion that we see. It's not just a morphologic test. By assessing the poststenotic signals, we can tell that it is indeed flow reducing. We've had the best results by combining both the direct and the indirect examination. And of course, making sure that you train your techs to look for all these things will improve their experience and your diagnostic accuracy.
Hello, I'm Dr. Oksana Baltarowicz, a radiologist from the Department of Radiology, Thomas Jefferson University Hospital, and from the Jefferson Ultrasound Research and Education Institute in Philadelphia. I'll speak to you today about sonography of the pancreas and spleen. First, I'd like to talk about the pancreas. I'd like to review the anatomy, some details, and highlight the vascular markers for the gland. Then we'll talk about some pathologic manifestations and the role of ultrasound. So why do ultrasound of the pancreas? Well, first of all, ultrasound is a screening modality for jaundice. So any patient with jaundice should first get an ultrasound. So that's a good place to start, and at least to look at the head of the pancreas. Now, although CT is much more accurate in pancreatic diagnosis, and also MRI now is a wonderful modality, and they provide more information for us, but we have to remember that not all patients can have a CT. For example, pregnant women, children, patients who have contrast allergies, who may not want to take the risk and undergo steroid prep, because a certain percentage of those patients break through with anaphylactic reactions. So in these cases, we should be prepared to do a full, proper evaluation of the pancreas. CT is not always available. Now, usually in the United States, there are CTs everywhere, even multiple CTs in a hospital, but in some of the countries outside the U.S., CT is not that available. Let's look at the pancreatic anatomy. The pancreas is a retroperitoneal structure. It lies posterior to the stomach. So the stomach with air in it would interfere with visualization of the pancreas, but also we can introduce water into the pancreas. So if we have to do a thorough evaluation of the pancreas, it's a good idea to have the patient drink some water and provide a sonic window for us. Now here we're going to peel away cut away the stomach, and right behind it is the pancreas. Notice how the head of the pancreas is hugged by the C-loop of the duodenum. This pancreas is very intimately related to a number of very important vessels. Here's celiac axis, splenic artery just above the body of the gland. Behind it is the superior mesenteric artery. Behind it is also the SMV and splenic vein forming the portal confluence. Notice the gastroduodenal artery that lies on the anterior surface of the head. Lots of very important anatomic markers, which we'll talk about in a few seconds. Here's a very classical, very well-known appearance of the pancreas on ultrasound. This is the splenic vein, and just in front of it is the pancreas. So we have the head of the pancreas, we have the neck, then the body, and here at least a portion of the tail. Then the tail wanders away towards the splenic hilum, so usually it's obscured by bowel gas. And here's a little piece of pancreas that hooks behind the splenoportal confluence and behind the splenic vein. That's the uncinate process of the pancreas. In Latin, uncus means hook, so this is a portion of the pancreas that hooks behind these vessels. This is a classical scan through the pancreas. However, this is very misleading because the head of the pancreas is 4 centimeters long. The body of the pancreas is about 2 centimeters in length in the sagittal plane. So we're only imaging a very thin section when we're hanging around this splenic vein. There are a number of vascular landmarks that we use to identify the pancreas and look for abnormalities. So I'd like to discuss the veins that are related to the pancreas, and that includes the splenic vein, superior mesenteric vein, the main portal vein, and the inferior vena cava. The splenic vein runs posterior to the body and tail of the gland. The superior mesenteric vein travels in a sagittal plane, and the two of them join together in a confluence. So this is a wider area where the main portal vein begins. The main portal vein crosses obliquely in front of the inferior vena cava, which is posterior. Notice here that the main portal vein is located at the superior surface of the pancreatic head, and the pancreatic head is rather long. Here's the uncinate process hooking behind the superior mesenteric vein. Now there's a number of arteries that are intimately related. There's the aorta, and off of it comes the superior mesenteric artery, which is right behind the splenic vein. Then we have the celiac axis. That's superior to the pancreas. It gives off the hepatic, the left gastric, and the splenic artery. This splenic artery travels along the superior border of the body and tail of the pancreas. Usually the pancreas goes no higher than the splenic artery. The gastroduodenal artery, which is not drawn here, would lie on the anterior surface of the head of the pancreas. So let's look at the splenic vein on ultrasound. Splenic vein lies posterior to the body and tail of the pancreas. It ends at the portal confluence, where there's a little bit of a enlargement that resembles the shape of a cobra head. Some people have referred to it as the scallion, the little onion shape. And this is our marker for the body and tail. It's immediately in front. Here's another classical cut showing that portal splenic confluence a little better here with pancreas anterior to it. Now the splenic vein is a useful anatomic structure because the pancreas being in front of it, we know that if masses are found anterior to the splenic vein, then they are of pancreatic origin. However, if there should be a mass located posterior to the splenic vein, then that's not a mass of pancreatic origin. That would be an adrenal mass or a retroperitoneal mass or a neurogenic type tumor related or a sarcoma of some sort, but not pancreas. The superior mesenteric vein courses parallel and just to the right of its partner, superior mesenteric artery. This vessel ends at the portal confluence where it joins the splenic vein. So it's the splenoportal confluence. This superior mesenteric vein is a marker for three parts of the pancreas. The head is lateral, the neck is anterior, and the uncinate process hooks posterior to the superior mesenteric vein. So we use that as a landmark. And here we have the head of the pancreas, the uncinate behind this portal confluence, and neck in front of the portal confluence. If we were a little lower, we would see it in front of the vein itself. Now, that was transverse. Now, when we look at the longitudinal sagittal scan, the superior mesenteric vein is a vein that looks kind of suspended in the middle of this abdominal cavity, and it ends in a little bulbous appearance, kind of resembling a cobra head. And that's the superior mesenteric vein, but on a longitudinal sagittal section. And this portion here that's bulbous is because of the splenoportal confluence. So the neck of the pancreas is anterior to this, and the uncinate process is posterior to the superior mesenteric vein. Now, when you look at an image like this, very often people see this characteristic kind of appearance of the vein, and they right away think that they're looking at the splenic vein. But be careful, because if it's a sagittal section, a longitudinal section, this can't be the splenic vein. This is the superior mesenteric vein ending at the portal confluence. This then is neck of pancreas, and the little echoes behind would be uncinate process. Very similar appearance on a transverse section of the body where we see the splenic vein. Now, we know we're transverse because we have the spine. There's a cross-section of aorta, cross-section of inferior vena cava. Here's a little superior mesenteric artery, splenic vein in front. Here we have a longitudinal appearance of a vessel and then spine behind. So here we're transverse. Here's our splenic vein. Here's longitudinal superior mesenteric vein. So we have to be careful not to mistake the superior mesenteric vein for the splenic vein. The longitudinal superior mesenteric vein is on a sagittal scan. The longitudinal splenic vein is on a transverse scan. And SMA, superior mesenteric artery, aorta, and spine are posterior to the splenic vein. Now the main portal vein. The main portal vein crosses obliquely and anteriorly to the inferior vena cava. The pancreatic head extends just inferior to that point of crossover. So here we are on a sagittal section. This is the inferior vena cava. This round dark area is the main portal vein crossing in front of the IVC. That's our marker for the head of the pancreas. So all of this is head of pancreas that extends about 4 centimeters inferiorly, 4 centimeters in length. So this is our marker for the cranial aspect of the pancreatic head. Now the superior mesenteric artery. On a transverse scan, the superior mesenteric artery is cut crosswise, in cross-section, as a circle located anterior to the aorta. The superior mesenteric vein has a very characteristic echogenic triangle of mesenteric fat around it. That makes it easy for us to recognize. And in front of that then is splenic vein and then pancreas. Now, you may have a patient with a lot of bowel gas, but if you just visually spot that echogenic triangle with the hole in the middle, you know you are at the superior mesenteric artery. So that's going to be aorta in the back. The left renal vein crosses in between. The splenic vein is just anterior, and anterior to that is body of the pancreas. So we know that at least this part is part of the pancreatic body. Again, an echogenic triangle of fat on a transverse scan with a hole in the middle is SMA. In front of that is splenic vein. In front of that is pancreas. Notice here that the pancreas has a little hole in the back. That's the common bile duct passing through the head of the pancreas posteriorly, and a little hole anteriorly, and that's the gastroduodenal artery that lies on the anterior surface of the head. Now, if you ever see a picture like this, which is very confusing, and you use these landmarks to help you sort out where you are, you know you're transverse because here's the spine. This looks like aorta and inferior vena cava, and then you have all these masses, but you recognize an echogenic triangle of fat with a hole in the middle, so you know that's SMA. It's far and spaced far away from the aorta, and then you realize that you are staring at masses all over this region, the region of the pancreatic gland. On a sagittal scan, the superior mesenteric artery originates anteriorly off the aorta. The first branch off the aorta is the celiac trunk, and very close after it comes the superior mesenteric artery. Now, the celiac trunk is short. It points, I think of it as a long finger that points to the body of the pancreas. But the superior mesenteric artery curves and has a long course and parallels the abdominal aorta. It also has quite a narrow angle in between through which pass some important anatomic structures, which we will address later. That superior mesenteric artery has an echogenic kind of border around it because that's that mesenteric fat that surrounds it. In front of that is splenic vein, and in front of that then is body of the pancreatic gland. Now, this shallow acute angle of the superior mesenteric and aorta, there is a left renal vein that has to pass over the aorta. It comes right through this acute angle. So sometimes when the two arteries have too high of a pressure, they can pinch off the left renal vein. A little bit inferior would be uncinate process, and then the third part of the duodenum crosses over. But the important thing is the left renal vein. So if you're looking at this sagittal section of the body and you see the aorta, but you do not see a normal superior mesenteric artery paralleling the aorta, you see that you recognize the vessel, but the angle now is very wide, and then you notice that all this tissue is surrounding it, displacing the artery from the aorta, and this is all an invasive tumor of the pancreas, recognized by with invasion of the superior mesenteric artery due to that narrowing. Now, the celiac artery, I already mentioned that it's the first major trunk coming off the aorta. It's not very long. It looks like a long finger pointing to the body of the pancreas. Notice that we have the abdominal aorta, and it's paralleled in front by a thin hypoechoic stripe. That's the crus of the diaphragm, or a slip of the diaphragmatic muscle, which stops approximately at the takeoff of the celiac artery. And then comes the superior mesenteric artery. This patient shows the collapsed left renal vein passing between superior mesenteric artery and aorta. This celiac artery points to the body of the gland, behind which is the splenic vein. The splenic artery has a tortuous course, and it travels along the superior border of the pancreas. It's a marker for the cranial edge of the pancreas. It lies superior to the vein, which is directly behind the body of the gland. So it's a marker for the cranial aspect. Notice also that it has a very tortuous course, and it sort of weaves in and out and up and around the top part of the gland. We don't know why it tends to be tortuous, but even in young people it may be somewhat tortuous. Now this is something to remember because there's a pitfall that can occur with this splenic artery. If you ever see a little cystic mass in the pancreas, the first thing you should think of, could this possibly be a piece of the artery that's weaving in and out? And you turn on the Doppler, and sure enough, this was just the splenic artery. Any cystic structure then in or around the pancreas should be interrogated with color Doppler at least. Now the same thing holds for a little calcification. If you see a little calcification coming from the gland, and here's another example, a little calcified rounded mass with shadowing. Here's another one, looks like a calcified structure in the body of the gland with shadowing. Turn on the color because this could be that tortuous calcified splenic artery, and it often calcifies. So do not think that this is a calcified little mass in the spleen, in the pancreas. It's in the artery. So here's a summary of all these vascular markers for the pancreas. The splenic vein marks the posterior aspect of the body and tail of the gland. The superior mesenteric vein and the confluence are borders of the head, neck, and uncinate process. The splenic artery marks the cranial edge of the body and tail, and the main portal vein, not seen on this picture here, marks the cranial margin of the pancreatic head. So as you're scanning around and you see some unusual tissue, you wonder where you are, what's going on, you immediately refer to your landmarks. You say, okay, spine, aorta, IVC. You can recognize the SMA surrounded by an echogenic triangle of mesenteric fat. And now you know exactly where you are, and in front of that should be the splenic vein, which we can't find. Instead, there's some lumpy, lobulated solid tissue with small cystic spaces, and this turned out to be a diffuse pancreatic cancer involving the gland and already invading the splenic vein. Now, if you are asked to do an ultrasound of the pancreas itself, you should not only scan all of these margins, but all of these surrounding vessels, but you should also do sagittal sections of the pancreas. So I'd like to go over these. Let's look at a sagittal section through the head, through the neck, through the body, through the distal body or proximal tail, and through more of the distal body. Let's see what those sections look like. Here goes sagittal section through the head. Our markers are IVC with the crossing main portal vein. Just below is the 4 centimeter long pancreatic head. We move to the left, towards the left of the patient, and here we run into this vessel that has a blunted end, looks like a cobra head, but it's on a sagittal. So we know that's superior mesenteric vein, and in front would be pancreatic neck, and behind are uncinate process echoes. We move more to the left of the patient, and we pick up the aorta with SMA. In front is splenic vein. The celiac points to the body of the pancreas. We go more to the left, and we see 2 rounded structures, like 2 eyes looking at us. That's the splenic vein behind the body of the pancreas, which lies behind the antrum of the stomach. And the one that's more superior is the splenic artery, which rides along the superior part of the body and tail of the pancreas. And then as we progress a little more lateral, we can follow the echogenicity of the tail, and then we will lose it as it heads towards the hilum of the spleen. There will be too much surrounding bowel gas. So I want to bring you back, now that you know how to examine an entire pancreatic gland, I want to bring you back to this classical picture that on a daily basis is imaged by sonographers. Is this a normal pancreas? Well, we see aorta, SMA, IVC, part of the splenic vein. We see some echoes from the pancreas, uncinate, head, neck, body. Looks okay, a little heterogeneous maybe, but we don't see any unusual problem. That's about as much as you usually get on a standard view of the upper abdomen. You don't get the additional cuts, so you cannot say that the pancreas is normal. All you can really say is that portions visualized are normal or portions visualized are grossly normal. The same patient, a few centimeters inferior, had a mass, a solid mass when biopsied was pancreatic cancer. So this is a sagittal of that cancer. This is IVC. This is a main portal vein. Here's the pancreatic head, and hanging off the inferior part of the head is this solid pancreatic cancer. So we have to be careful. We do not want to mislead clinicians by saying there's a normal pancreas when we haven't examined the complete gland. Another little anatomic detail is the pancreatic duct. Now this is a small little tubular structure that runs down the very center of the gland, seen here as a thin tubular structure down the middle, surrounded by pancreatic echoes on both sides. There is no vessel that runs down the middle of the pancreas like this. So the only thing there would be the tube, pancreatic duct, which is not more than 2 millimeters in diameter. Here's another picture of this visible little duct here surrounded by pancreatic echoes, and if you follow it, it will curve around and join the common bile duct and then onto the duodenum through the ampulla of Vater. Now, sometimes you look at the image of the pancreatic area and you see a dark stripe. Be careful, don't call this a pancreatic duct until you're sure that it's a duct. And what I mean by that is follow the course of this stripe. This does not assume the course of the pancreas. Even though it kind of faked you out at first, you'll notice there are no pancreatic echoes on the other side. So this is not the pancreatic duct. In fact, this is the posterior wall of the antrum of the stomach. Here's the anterior wall, and this is internal collapsed mucosa, and then filling with the gas. So just to call pancreatic duct dilatation, we want to see it directly inside the gland. And if you follow that posterior wall, you'll see that it blends and stays with the stomach. The common bile duct courses through the head of the pancreas. It should not be mistaken for a pseudocyst, especially when it's enlarged. But when it's enlarged, what we should do is track down the duct, take small sections inferiorly to make sure there's no stone or tumor down there. Here's the head of the pancreas, SMV, SMA, and lateral is the head. There's the distal duct with an obstructing calculus directly embedded in the distal duct. So we want to follow that, make sure we don't miss that. One other thing you should know about the pancreas is that it can have, there can be two shades of echogenicity in the head. Sometimes you'll see that the most posterior part is a bit hypoechoic. Embryologically, the pancreas originated from fusion of the dorsal and ventral Anlage, so-called Anlage. Now, the reason it has different shades is some investigators tell us that there are different fat content within this mass, therefore different echogenicity. The important thing here is not to mistake this for a mass. Notice it has a fairly straight edge of demarcation. Here's another one, hypoechoic, more in the uncinate compared to the anterior part of the head. Sometimes it gets kind of prominent. We watch for the internal architecture, but if it gets too round and too dark, we have to think of a mass. Now, this one was a cancer in the head of the pancreas, and these were just areas of different fat infiltration. Let's look at some pancreatic pathology. We'll look at acute pancreatitis, chronic pancreatitis, some of the pancreatic tumors like cancers, and some others. Now, acute pancreatitis is usually a diffuse process, although it can be focal. It's a diffuse enlargement of the gland, and the gland becomes hypoechoic relative to the liver. In this case, it's not hard to recognize because the gland is swollen. But we have to be careful when, let's say, it's a subacute situation, because sometimes the liver is fatty, which makes it more hyperechoic, which could make the pancreas look hypoechoic. So we have to watch this relationship and see which of the organs is abnormal. Is it the liver that's too hyperechoic, which makes this look hypo, or is this truly acute pancreatitis hypoechoic, and this is just a normal liver? On this sagittal image, the head is markedly enlarged. Here's the portal vein located inferiorly. Here's the bile duct heading into the posterior part of the head of the pancreas. Looks large and bulbous, and this was also involved with acute pancreatitis. Acute pancreatitis can be focal, and that can mimic carcinoma. That's why we do follow these patients in the next 3 or 4 weeks with a scan to make sure that all of this has resolved. This type of focal appearance is more likely to occur in the pancreatic head than it is in the tail. If it occurs in the tail, it's much more likely that that's going to be a carcinoma. There are complications of acute pancreatitis. If this is not treated and does not start to resolve, the process can worsen. It can turn into a phlegmon. Necrosis of the gland can ensue. It can turn into an abscess. It could bleed into itself. If it heals, a pseudocyst may form. It can obstruct the biliary tree. There's problems with veins. There's problems with arteries, and we'll see some of these. Here's a pancreas, SMA. Splenic vein was in here, and the gland is edematous. But off to the side, we saw streakiness throughout the abdominal wall musculature and in the retroperitoneum. And this is what a phlegmon looks like, which is formed from edema and continuous leakage of these activated pancreatic enzymes in between these tissues. Now, pancreatitis can become infected. There will be leakages of fluid around the gland. Sometimes there's areas of irregularity, which could be tissue necrosis. If it's superinfected, if the patient gets fever, there could be abscess formation. Here there's some shadowing. When the acute pancreatitis becomes infected, this is a life-threatening complication from this. Now, what is the role of ultrasound in patients with acute pancreatitis? Well, it's not so much the imaging of the gland, it's all the other things. First of all, gallstones. Patients who have gallstones can have recurrent bouts of acute pancreatitis. Now, usually people think of CT as the imaging modality for pancreatitis, but on CT, gallstones are poorly visualized. Only about 15% of gallstones are calcified, which means you can see them on CT. The other 85% of gallstones are not calcified, so they don't show up on CT. So ultrasound would be a great way to first investigate and see what's going on in the gallbladder. We can see biliary ductal dilatation by this swollen edematous gland. We can look for the complications that we just talked about. If there's a fluid collection, we can follow the fluid collection with ultrasound rather than keep repeating CTs. We can use it for aspiration of collections and a guidance for drainage. And sometimes we pick up unsuspected cases of pancreatitis. As the process continues and slowly begins to heal, a pseudocyst may form. Pseudocysts are cystic masses that form 90% of cystic masses of the pancreas. This fluid becomes encapsulated. It's a mass-like fluid collection. Inside is tissue, edema, enzymes, blood, debris. All of this then incites an inflammatory response, and there's a thick inflammatory fibrous capsule that forms. Pseudocysts can range from small ones, 2 centimeters in diameter, to 20 centimeters in diameter. They can be multiple, as they were in this patient who had 1, 2, 3, 4 pseudocysts. They may occur in remote areas. Remember, the tail of the pancreas wedges its way into the splenic hilum, so the pancreatic enzymes can dissect into the hilum, can dissect into the spleen. You can have intrasplenic masses, collections. They can extend into the paracolic gutters. They can even extend into the mediastinum. Now, pseudocysts can have complications of their own. They can become superinfected. They can bleed into themselves. They can even rupture. They can have calcifications in the wall. And here we see several of these complications. Another complication of acute pancreatitis is thrombosis of adjacent veins. So intimately related is that splenic vein that it easily becomes thrombosed. Spiromesenteric vein can become thrombosed, and the thrombus can extend up into the portal vein, as it is in this case. Another complication happens when the enzymatic juices dissect into an arterial wall and then destroy part of the wall, and pseudoaneurysms are formed. So that can happen in any one of those intimately related arteries, like splenic artery, gastroduodenal artery, superior mesenteric artery, hepatic artery. So once again, any cystic structure in or around the pancreas should be interrogated with Doppler. Here was an innocent-looking little cyst, but when they turned on the color Doppler, it had a to and fro yin-yang type of flow, which is seen with a pseudoaneurysm. A pseudoaneurysm can occur in the splenic artery in the hilum. These enzymes dissect into the hilum and erode the spleen. And a similar appearance can also be caused by a pseudocyst. So pancreas can cause a large cystic mass in a spleen in 2 different ways. One is that it's a pseudocyst in the spleen, and the second way is that it's a large pseudoaneurysm of the splenic artery, for which color Doppler will be very useful. Always turn on Doppler with pancreatic cystic masses or splenic masses. Now, there's a chronic pancreatitis that can occur. Now, once the gland has undergone these insults, it can heal with fibrosis. Calcifications can be precipitated. Usually what we see is a smallish gland with increased echogenicity, and it's very heterogeneous, with punctate calcifications, sometimes coarse, causing shadowing. There's an irregular, dilated, beaded pancreatic duct. The pancreas echoes are on both sides of this arrangement, and fluid collections can also form. Now, this chronic pancreatitis sometimes is focal. Now, most of the time it's diffuse calcification, diffuse process, but sometimes it can be focal and can mimic a carcinoma. The giveaway is the areas of bright reflectors and shadowing, which is the calcium. So we can have scattered calcifications. That would be our clue. And sometimes we see small cysts in the pancreatic mass, the focal pancreatitis. This was chronic pancreatitis. These patients have to be followed. Sometimes a biopsy is done, but the calcium would be a very telltale sign, important telltale sign of chronic pancreatitis. Cancer of the pancreas. Now, cancer is hypoechoic. Cancer of the pancreas is dark. It's hypoechoic. There have been no cancers of the pancreas that have been hyperechoic. There have been no cancers of the pancreas that have been hyperechoic. So here's a hypoechoic mass in the head of the pancreas. Here's a hypoechoic mass in the body of the gland. 60% of the pancreatic cancers are in the head, 40% are in the body and tail region. Here's a patient with pancreas, and as we were imaging down the tail, we noticed a hypoechoic mass, lobulated irregular mass, extensive down the tail. Now, when we see such a mass, we immediately look for adjacent vessels because invasion of the vessels or encasement of the vessels is a common presentation. Here the splenic vein is barely visible because it's invaded, and here on a sagittal section the artery is present, but the vein is hardly discernible. We will check for biliary obstruction. Here's bile duct dilatation. At the end of the duct we see a hypoechoic solid mass. And we look for biliary dilatation inside the liver, for which we can do color Doppler to show that those are not vessels, that they are bile ducts that are not filling with color. A mass in the head of the pancreas will cause obstruction of the pancreatic duct. That means the duct is enlarged, and the duct shows up as a beaded type of tubular structure running down the middle of the gland. So here we have SMA, splenic vein, pancreatic duct down the middle of the gland, and a very abnormal mass in the head of the pancreas. And here's the cancer also on this slide. Now, after we've assessed the pancreas, it's very common for the pancreas to metastasize to the liver. So we're right there. We check the liver. Here's a metastasis, a focal lesion. Here's another patient. This changes everything. This is now stage 4 disease. You can easily take a needle, stick it in there, get tissue diagnosis, and have a diagnosis in 24 hours. You can see adjacent lymph nodes. You can see the tumor invading locally. Lots of things to pick up with ultrasound. There are cystic neoplasms that occur in the pancreas, such as microcystic adenomas, cystadenomas, well known, macrocystic adenomas, including mucinous cystadenocarcinoma, cystadenoma, can occur. There are tumors called IPMNs, intraductal papillary mucinous neoplasms of the pancreas. There are larger multiseptated cystic masses that grow quite large in the tail. There are also a whole separate category of pancreatic masses that originate from the endocrine part of the gland. All the cancers that I've been talking about till now are originating from the exocrine part of the gland. The endocrine part of the gland have unusual presentations. These are these islet cell tumors, and they have different names based on what they secrete. So if a patient is having too much insulin and having episodes of hypoglycemia, then these are insulinomas. If they have high gastric secretion production, these could be gastrinomas. There are vipomas, there's glucagonomas, there's somatostatinomas. These are these tiny ones. They're often not even visualized. We're lucky here in this case to see a small little nodule. Usually they're small, very hard to find, but the endoscopic ultrasound that the gastroenterologist passes into the stomach and images from inside the stomach, that's really the most sensitive way to find these small tumors, which could be biopsied. It's not unusual for surgeons to call us into the operating room for us to come with our laparoscopic ultrasound to help them find the little mass which they can't see. So what happens is the surgeon has the abdomen and retroperitoneum and the gland exposed. We come to the operating room, glove up, dress up in sterile technique, cover the probe, and then run our probe over the surface of the gland after they put a little saline in, of course, and then we can sometimes pick up a very small tumor with our high-resolution laparoscopic probe. In some cases, we can't even find it. Sometimes the surgeon just does a blind kind of a resection. This is a very unusual disease of the pancreas, and that is lymphoma of the pancreas. Here's two cases for you to look at. They're just infiltrative, very large, not very characteristic masses. They're rare to be primary in the pancreas most of the time. There's other disease elsewhere. There will be enlarged lymph nodes, etc. So that's usually a very difficult diagnosis to make. Okay, now the spleen. The spleen is a small organ that sits in the left upper quadrant, very closely applied to the left hemidiaphragm. It almost looks like the echogenicity of the liver, except that it does not have the bright portal vein walls that are characteristic of a liver. The spleen has a different architecture. It's made of red pulp, white pulp, so it has basically a nice homogeneous texture with a few little vessels penetrating it that you can see near the hilar area. It's homogeneous, moderately echogenic. The spleen sometimes moves around. There is a phenomenon called the wandering spleen, also called floating spleen, ectopic spleen, ptotic spleen, aberrant spleen. The spleen is on a vascular stalk, and sometimes it can move around the abdomen from the left upper quadrant to the middle. This one landed in the pelvis. It looked like perhaps even an endometrioma in the pelvis. Here's the ovary. Here's the retroverted uterus. And this patient eventually twisted its vascular pedicle, and the spleen underwent torsion, and the diagnosis then was proven. What about splenomegaly? When is the spleen too large? Now, there's conflicting information in the literature. Some say over 14 centimeters long. Others say that you should just look at the way the spleen looks in relation to the kidney. Certainly, if the spleen is much longer and larger than the adjacent left kidney, that's splenomegaly. I personally like to use 13 centimeters. Anything beyond that would be splenomegaly. Others might use 14 or more. If I sometimes think the spleen is too long, but I'm not sure if it's really enlarged, I sometimes use more than 6 centimeter thickness as another indicator that that spleen is enlarged. Certainly if it has a mass effect on the kidney, that's another sign of enlargement. Around the spleen you will see small isoechoic nodules. These are quite common. They're usually small, less than 3 centimeters in diameter. They are accessory little spleens. They're developmental. They have their blood supply coming from the splenic artery. You can see them in up to 10% of patients. They're more common when the spleen is enlarged. They're usually solitary, but they may be multiple. But importantly, they should not be confused with lymphadenopathy and should not be confused with masses from adjacent organs like an exophytic renal mass. So you have to be aware of this. Now there's another way that we can see little spleens in the body. Now what I showed you just before was accessory spleens. There is such a thing as splenosis, these small little masses that are splenic tissue. But splenosis occurs only after spontaneous disruption of the spleen. And there's not spontaneous, but after splenic trauma or rupture. And then we have these little islands of splenic tissue that spontaneously transplant around the peritoneal cavity. They parasitize blood supply from the peritoneum. They can implant anywhere. They have a very characteristic appearance. They can even extend down into the pelvis. They can attach to peritoneum, omentum, mesenteric surfaces. In the pelvis, they simulate endometriosis, which happened in this patient. However, she had had a splenectomy after a motor vehicle accident, after her spleen was ruptured, and she had several of these little masses. These were removed. They were splenic tissue splenosis. They parasitize blood supply from adjacent areas. They're not fed by the splenic artery. There are masses that occur in the spleen. Here's a list of cystic masses that can occur. We'll show you a few of these. Here's a pure cyst that occurs in the spleen. The true cysts with the true lining are rare. Most of these are secondary to old trauma or hematoma or even a pseudocyst inside the spleen. They can be complicated by hemorrhage or infection, just like any cyst. Most of the time when there is a splenic laceration or hematoma, that is handled by CT. But in some patients, like in children or young adults that are stable, that do not need to have CT follow-up, for example, we can evaluate and follow the spleen. Look, here we have linear hypoechoic defects throughout the spleen, which is a laceration that was stable. Here's a patient who developed a spontaneous bleed on anticoagulants. Both were stable, did not require any surgery. We can see subcapsular hematomas, and there is sometimes difficulty in defining the extent of the subcapsular hematoma, because it can often look very much like the spleen itself. One thing that could be helpful is to do Doppler and watch where the vessels end, so we would know that's the end of the spleen, and all this heterogeneous material outside is perisplenic hematoma. Another thing that you should be aware of is that the left lobe of the liver can come around and hug the spleen. Now, it gives kind of a two-tone, double-shaded appearance to the spleen. The splenic tissue itself is homogeneous, and look for little portal vein walls inside this piece of liver that's coming way over to the left from the left lobe. This is easily mistaken for subcapsular hematoma. So if you see such a thing, such an appearance, think of liver adjacent to spleen rather than a hematoma. There can be a liver abscess. It looks like an abscess anywhere in the body, usually regular, thick-walled with internal debris. Especially think of bacterial endocarditis, secondary to embolism or septicemia in such patients like drug abusers or immunocompromised patients. Hydatid disease is an endemic disease in certain areas of the country, usually related to sheep raising areas. It sometimes bypasses the diagnostic list, but in endemic areas this certainly is known. Here's two examples of multiseptated masses. Little small microabscesses can occur in the spleen just like in the liver, and these are usually due to fungal infection and have little small target lesions with a little echogenic nidus, which is the bullseye lesion of the microabscess. Intrasplenic pseudocysts can occur after trauma, which means that there was an organized hematoma after an occult rupture, or it can originate from the pancreas, a pseudocyst from dissection by the enzymes. Cystic masses around the spleen can be due to arterial problems, in this case a splenic artery aneurysm, which can form after atherosclerotic disease or from septic emboli, infection, or trauma. This has high morbidity and mortality and usually has to be treated when it's over 1.5 to 2 centimeters in diameter. They're somewhat rare. The pseudoaneurysm would be more common from pancreatitis or trauma, and in this case there are 2 of these. These happen to be intrasplenic pseudoaneurysms. More cystic lesions that occur in the spleen could be primary metastases from a primary tumor that is cystic, like an ovarian cystic mass. Sometimes there's a metastasis that undergoes cystic degeneration, maybe internal hemorrhage, necrosis, or infection, and that can cause this irregular, thickened appearing mass, which would be suspected of being tumor or an abscess. When we talk about solid splenic masses, again, we have a list of things. The most common thing would be little granulomas. These are little calcified granulomas, echogenic spots and dots throughout the spleen. Tiny little shadows can be demonstrated coming from these, and these usually are due to granulomatous disease, exposure to histoplasmosis, in some areas tuberculosis, and think of sarcoidosis. Now, spots and dots in the spleen can also be caused by something called gamma-Gandhi bodies. This is known in MRI, but occasionally can be picked up on ultrasound. These are siderotic nodules, nodules of fibrous tissue that contain iron and calcium salts. That's why they're picked up on MRI. And these are actually little healed focal hemorrhages with necrosis. That's why they become hyperechoic. When you see these, you have to think of portal hypertension. Sickle cell anemia is probably the next most common cause. And then there's some other more unusual entities. However, seeing these spots and dots, you think of granulomas, you think of gamma-Gandhi bodies, you think of histoplasmosis, sickle cell, and disseminated pneumocystis can look just like that. Here's a patient with HIV. He has disseminated pneumocystis carinii, and here's his spleen in the left upper quadrant with left kidney, little spots all over the parenchyma. Here's the liver, also with echogenic numerous foci, and the right kidney. These patients, we used to see more of these in the past when patients were treated for HIV with pentamidine. So they would inhale the pentamidine to protect their lungs, but the disease would go then systemic and affect their parenchymal organs like liver, spleen, pancreas, and kidneys. We don't see as much of this because HIV is much better controlled, but in case you do spot this, you should think of HIV first. Infarcts are a classical wedge-shaped, peripherally located hypoechoic defect, which can be seen with septic emboli or just simply thrombosis of vessels. It's the most common focal lesion in the spleen. With septic emboli, we have to think of drug abusers. It occurs in patients with endocarditis, atrial fibrillation, and patients who actually get vessels thrombosed in the spleen. We have to think of sickle cell disease, pancreatitis, leukemia, and lymphoma. Hemangioma in the spleen looks just like hemangioma in the liver. They're rare in the spleen, but occasionally you'll see them. They're typical masses. They do have variable features. They're indistinguishable from any other etiology. So this can be a difficult diagnosis. MRI is usually helpful. and they may actually even require splenectomy to make the final diagnosis. The spleen size, however, is usually normal. Hamartomas can occur in the spleen. These are benign neoplasms. They're asymptomatic, often incidentally discovered at autopsy. Now, lymphoma, that's a common mass of the spleen. So if we see single or multiple hypoechoic solid masses throughout the spleen, we have to think of lymphoma. It could also be hyperechoic masses. We would look for additional lymphadenopathy and additional history. Now, metastases, that's another big category. So we've got like granulomas, hemangiomas, lymphoma, and metastases in the spleen. Rarely, these are seen, or at least they used to be rarely seen outside of autopsy, but now with all these imaging techniques, we do see masses, late manifestation of metastases in the spleen. Usually they arrive there by hematogenous spread. The important tumors are melanomas, breast, lung, and colon that like to do this. And the longer patients survive with better treatments, the more likely we are to see these manifestations of advanced disease. And finally, at the very end, there's one tumor that's kind of specific or special to the spleen, and that's the angiosarcoma. It's very rare. It's a primary malignant tumor, originates from epithelial cells. It's usually solitary. It's very heterogeneous and complex looking, and it's usually the last thing on your differential that the patient can present with. And one thing you should remember is that they can spontaneously rupture and could actually present with a hemoperitoneum and an acute abdomen coming from this complex mass in the spleen. So that's an overview for you of the pancreas and spleen by ultrasound. Thank you for your attention.
Hello everyone, my name is Anthony Meddock and I'm a faculty member in the ultrasound division, and today we're going to be speaking a bit about hepatobiliary ultrasound. This is a brief overview of our approach today in terms of our discussion. We'll talk a bit about some relevant anatomy, then we'll go over the technique step by step in a bit of detail so you have a better understanding of how to perform the exam. We'll review some examples of pathology that you might encounter in the emergency department, and then we'll wrap up with some pearls and pitfalls that you should hopefully seek to avoid moving forward. By way of introduction, as you know at this point, ultrasound obviously is a quick and safe modality that is used on many different applications in the emergency department. It can be used to expedite patient care, and specifically as pertains to patients that have abdominal pain, it has many applications, including the evaluation of your patients that may have right upper quadrant or epigastric pain, that have new jaundice, or that have new or worsening ascites. Here's a nice illustration of some relevant anatomy. Obviously today we're going to be focusing on how to identify the gallbladder and the common bile duct, and just remember that the gallbladder and the cystic duct will course and combine with the common hepatic duct to form the common bile duct that will traverse along just adjacent to the portal vein and ultimately will terminate by draining into the duodenum. Additionally, in terms of other anatomic key concepts that we should discuss, I just want to touch on a couple of quick things. First of all, I'd like you to recall what comprises the portal triad. That's going to be the common bile duct, the portal vein, and the hepatic artery. Although we won't be specifically looking to identify the hepatic artery as part of our bedside ultrasound exam of the hepatobiliary system, it is relatively easy to identify the portal vein, and once you find the portal vein, if you know that the common bile duct is just adjacent to it as part of the portal triad, it'll make it much more easy to identify. And the common bile duct is a particular structure of interest with this exam. Further, the common bile duct runs just anterior to the portal vein prior to entering the duodenum, and again, this will be important when we're trying to identify the common bile duct as part of our hepatobiliary ultrasound exam. Lastly, one thing that I'd like to point out is that there's a lot of anatomic variation in terms of the position, shape, and size of the gallbladder, which unfortunately can make this exam a little bit difficult at times and somewhat frustrating, because if someone has just eaten or if someone is overweight, it can make the exam a bit more challenging. But in terms of my perspective, if you're aware of this ahead of time, there are certain measures you can take to mitigate that and hopefully give you greater success. And we'll go over those as we move forward, going through the step-by-step technique. Now let's talk a bit about technique. Ideally, you'd like the patient to be NPO because, as you well know, bowel gas is going to lead to impaired image quality simply because the sound energy cannot penetrate through the gas. In terms of the equipment you're going to use, any type of low-frequency transducer that you have on your ultrasound system will be appropriate. You can use a curvilinear probe or a phased array probe. Either will give you reasonable images. In terms of patient position, I oftentimes do this exam with the patient supine, but if you're having particular difficulty getting good images in good windows, you can place the patient in a left lateral decubitus position and use the liver as an acoustic window so you can get better images of the gallbladder. And much of this is just going to be based on your own experience and the patient's body habitus. Now, in terms of doing this exam, the first thing we're going to want to do is find the gallbladder. Now, there are many different ways to do this, and I'm not proposing that the steps that we are going to discuss in the next few slides are the only way, but this is the way I do it, and I have had reasonably good success. So I propose, if nothing else, this is a starting point, and you can modify this technique as you go, as you yourself obtain some additional experience at the bedside. I generally will start by placing the probe under the costal margin in the midclavicular line. I'll have the marker dot oriented towards the patient's right, and then I slowly fan the probe in a craniocaudal orientation until I can see the gallbladder. And when you do, you'll get an image that looks similar to this. As you can see, this is the liver. This is the portal vein, which we'll talk about in more detail in the coming slides, and particularly you can know that because of the very echogenic walls that you can see here. And then lastly, you can see kind of this pear-shaped structure here that is largely anechoic, and that is the gallbladder. Now, in terms of finding the gallbladder, it's not always that simple. If you see the gallbladder with the steps that I outlined a moment ago, that's great. If you don't get frustrated. One thing you can do that's rather easy is you can ask the patient to take in a deep breath. As the patient breathes in and out, their diaphragm, of course, is going to go up and down. And as their diaphragm comes down, that is going to bring the liver and also the gallbladder closer to your probe beneath the costal margin, and oftentimes that'll be sufficient to bring the gallbladder into view. Once you've found the gallbladder, then you want to make sure that you get both longitudinal and transverse views of the gallbladder, and so you just simply want to rotate the probe 90 degrees from one orientation to the other so you examine the whole structure. Once you've obtained a long view of the gallbladder, then you want to gently manipulate the probe to verify communication of what you think is a gallbladder with the portal triad. Sometimes you might mistake a loop of bowel to be the gallbladder, and by just taking the time to identify your gallbladder, again, this is fundus of gallbladder, body of gallbladder, and neck of gallbladder. In general, the gallbladder neck should course towards the common bile duct and the portal vein. If it doesn't, or it courses in another direction, you might be looking at a loop of bowel instead of actually looking at the gallbladder itself. Now, once you've found the gallbladder and you're certain you have the gallbladder, then you want to scan the gallbladder in multiple longitudinal and transverse planes so you can look for some evidence of pathology, including gallstones. You want to assess for gallbladder wall thickness, and you also want to assess for fluid around the gallbladder, which is known as pericholecystic fluid. Here's an example of a normal gallbladder. This is a normal gallbladder in the fasting state. So you can see this very nice thin wall. There's no fluid around it. There's no stones within the gallbladder. Based on this one limited image, everything appears to be within normal limits. This is a postprandial gallbladder, so it's also normal. However, it's important to note that if someone has recently eaten, the gallbladder will be contracted, and that will sometimes give the false appearance that the gallbladder wall is abnormally thickened. But if you don't have any pericholecystic fluid, you don't have any pain upon palpation of the gallbladder, and there's no obvious cholelithiasis, be wary that this could in fact just be a fake out of a postprandial gallbladder as opposed to an abnormally thick and inflamed gallbladder wall. So, once you've identified the gallbladder, then again, as I said, you want to look for evidence of pathology. Now, one of those is going to be the presence of gallstones. Now, gallstones are going to be hyperechoic. They will have what's known as an acoustic shadow, so you'll see kind of this blackened area of anechoic signal deep to the structure, and those are two findings that are consistent with gallstones. Now, in addition to this, gallstones are generally going to be dependent, so they're going to move with gravity. This is a cool video clip where you can see the sonographer is actually moving the patient, and as they rotate the patient over onto their side, you can see the gallstone in a dependent fashion just moving along freely within the gallbladder. So clearly, that is not a polyp, that is not a malignancy, and that is not an impacted stone, because as the patient is being moved and rotated on their side, this gallstone is freely, in a dependent fashion, just traversing along within the gallbladder itself. Now, if you look for just a hyperechoic structure within the gallbladder, you can sometimes be fooled, because gallbladder polyps and malignancies can have a similar appearance, but they generally will not have the shadowing and they will not be mobile. So those are two things that are important to keep in mind. So here is a still image showing a gallbladder with a single gallstone with acoustic shadowing. And again, by acoustic shadowing, you can see this area of anechoic signal that is just deep to this very echogenic signal. So this is a gallstone with acoustic shadowing. In addition to that, you can notice the location. This particular signal is located at the inferior dependent most portion of the gallbladder, which is also consistent with a gallstone. Contrast that with this lesion. It's hyperechoic, but you notice there is no acoustic shadowing, number one. And number two, as this gallbladder neck is coursing along here inferiorly, this lesion defies gravity and it is actually adherent to the wall. So this would not be consistent with a gallstone, but this is consistent with, in this case, a gallbladder polyp. In addition to looking for stones, you're also going to want to assess for gallbladder wall thickness. In general, the gallbladder wall will measure up to approximately 4 millimeters. It can be thickened due to multiple processes, including acute cholecystitis, which is what we are most interested in as emergency physicians. But in addition, there are other disease states that can lead to an abnormally thick gallbladder wall, and those include CHF, low protein states, or folks that have end-stage liver disease and are hypo-oncotic, or also patients that have carcinoma of the gallbladder. In addition to assessing the gallbladder wall, you also want to assess for pericholecystic fluid, which is simply anechoic signal or fluid that is layering around the gallbladder. Now again, if you have a patient that has end-stage liver disease and has a large amount of ascites, that ascites fluid will track around the gallbladder as well. So you have to be wary that there can be false positives. But in general, in the right clinical context, when you see an impacted gallstone, a thickened gallbladder wall, and an anechoic signal that goes nearly circumferentially around the whole structure, that's pretty consistent with pericholecystic fluid noted in the setting of acute cholecystitis. Another sign that we often look for, and you may have heard referenced to in the past, is something called the sonographic Murphy sign. And essentially, a sonographic Murphy sign, I like to think of as essentially an ultrasound correlate to the Murphy sign that you would do when you're doing your initial physical exam and palpating the right upper quadrant. However, as opposed to just blindly palpating in the right upper quadrant when you're doing your physical exam, the sonographic Murphy sign involves placing the ultrasound probe directly over the fundus of the gallbladder and then applying pressure. And if the patient has pain during inspiration, or if they stop inspiring at that point during your gallbladder compression, that is a positive sonographic Murphy sign. It indicates that there is inflammation in the area of the gallbladder. Intuitively, this seems like it would be more sensitive and specific than the traditional Murphy sign. However, there's not a lot of data to support that statement. Okay, so now we've found the gallbladder, we've looked for stones, we've looked for gallbladder wall thickening, we have looked for pericholecystic fluid, and now we're going to find the portal triad, specifically because we would like to assess the common bile duct. Remember, the portal triad is portal vein, common bile duct, and hepatic artery. Now, to do this, there's a couple different ways it can be done. I personally like to proceed as follows. I like to find a longitudinal view of the portal vein, which I find is easiest. And once I've done that, then I'm going to want to look for these hyperechoic vessel walls to help me be certain that I'm looking at the portal vein. And as we do that, then we can look for the common bile duct itself. So here you can see this is the liver, this is inferior vena cava, and this is a large caliber vessel running within the hilum of the liver that has echogenic walls, and that is the portal vein. Now, once the portal vein is visualized, you can rotate the probe 90 degrees and you can look at the portal vein either in short axis or in long axis. If you look at the portal vein in short axis, there's something that some people refer to as a Mickey Mouse sign, which will allow you to see the whole portal triad in short axis. And you'll see the portal vein, the common bile duct, and the hepatic artery all in one transverse view. And it looks something like this. So here we have the gallbladder, Here we have the portal vein in short axis. This is the common bile duct in short axis and the hepatic artery in short axis. So basically your Mickey Mouse sign refers to the portal vein itself being Mickey's head, for example, the common bile duct and the hepatic artery representing each of his ears. And as you can see, they should be rather symmetric. So that's one way to assess the common bile duct. And you can see how it lies just adjacent to the portal vein. In video, here's what it looks like. Portal vein, common bile duct, hepatic artery. And being able to differentiate one from the other really isn't that crucial. The bottom line is they're symmetric and very, very small, and so you know, therefore, that the common bile duct is not enlarged. And for our purposes, that's sufficient. Now, in measuring the common bile duct, you can measure it in either short or long axis. I personally find that doing it in long axis is a bit easier. So I prefer to find a portal vein view in long axis. And again, remember the portal vein is going to have very echogenic walls, so it'll stand out and be a bit easier to find. Once I found a good long axis view of the portal vein, I will sweep through the area, I will hit freeze on my ultrasound system, and then pretty much every ultrasound system that you're going to have in this day and age is going to have a function called cine, where you can hit freeze and then you can use a trackball or the trackpad to go back frame by frame through the image and look for that common bile duct that is going to be a linear structure in the same plane and just anterior to the portal vein. And when you find that structure, that is the common bile duct. Take a look. So here you can see portal vein. Just adjacent to it, you can see these hyperechoic walls of portal vein and then also of common bile duct running just anterior to the portal vein. Vena cava, portal vein, and then this is a common bile duct just anterior to the portal vein. When you measure the common bile duct, keep in mind that the normal diameter is approximately 5 millimeters. The upper limit of normal increases with age, and it can be up to almost 1 centimeter after a patient has had a cholecystectomy. An enlarged common bile duct and right upper quadrant pain suggests that the patient has choledocholithiasis. Here's another nice image where you can see the gallbladder, you can see the portal vein, and then just anterior to the portal vein, you can see this nice linear structure, very small in caliber, with hyperechoic echogenic walls. That represents the common bile duct. Normal, by the way. If you're uncertain, if it looks dilated, or you can't differentiate between what's portal vein and what's common bile duct, you can always use color flow. And in this instance, you can see this very nice echogenic walls of the structure that has a very robust signal on color flow Doppler. And just above it, you can see that tiny little lumen that's not lighting up at all. That represents a normal common bile duct. Contrast that with this still image here. Here we have the portal vein. Just anterior to it, there is another lumen that looks almost the same size as portal vein. And this is an example of an enlarged, dilated common bile duct. Here's a video clip demonstrating that same pathology. Portal vein with the echogenic walls. And then just adjacent to it, what should be a tiny little common bile duct resting just on top of it, is in fact really dilated. Now, if you're uncertain if perhaps that's another vessel, you can always turn on color flow. And if you do, you can see the color flow lighting up the portal vein and not lighting up the structure just anterior to it, because that is a dilated common bile duct. Now, when we talk about cholelithiasis, just remember that ultrasound is a modality of choice for imaging the gallbladder, but also remember that cholelithiasis does not equal cholecystitis. Just because one has stones doesn't mean stones are the cause of your patient's symptoms. There's plenty of literature to demonstrate that we as emergency physicians can become very good at detecting stones with a moderate amount of training, certainly a lot less than you're likely to receive in your residency training. The sensitivity and specificity for a bedside ultrasound performed by emergency physicians looking for cholecystitis is quite good, on the order of 90% in several studies. So we talk about gallstones, remember, they're very echogenic, which just essentially means, again, that they're going to be very bright white. They create an acoustic shadow, and that shadow will be proportionate to its size. They are dependent, and they typically will be mobile unless they are impacted and perhaps causing pathology and some symptoms within your patient. Here you can see we've outlined the degree of acoustic shadowing in this particular gallbladder that is literally filled with gallstones. So here's a video clip demonstrating a single mobile gallstone with typical acoustic shadowing. Now, before a stone actually becomes a stone, oftentimes you may have heard the term that the patient has sludge in their gallbladder. And sludge is essentially just a term describing the lithogenic bile that can be seen in the gallbladder. So it hasn't yet become solidified and turned into a stone per se. It often will layer out in the dependent position, and it may shadow or it may not. It all depends. Here's a video clip demonstrating a gallbladder filled with this echogenic material within it, and that is all gallbladder sludge. Now, other examples of pathology that are a bit more rare, there is something called a porcelain gallbladder, which just has to do with a gallbladder with marked acoustic shadowing from calcium deposition within the wall. Sometimes these patients, in fact, oftentimes these patients may be asymptomatic, and this can be found incidentally. However, there is an association of gallbladder adenocarcinoma with this porcelain type gallbladder, and as a result, these patients would often be scheduled for cholecystectomy. In the acutely ill patient with right upper quadrant pain, the diagnosis of acute cholecystitis is based on the following: the presence of stones or sludge, any notable gallbladder wall thickening, the presence of pericholecystic fluid, and the presence or absence of a sonographic Murphy sign. The likelihood of your diagnosis is going to increase with each positive finding. So essentially, if you have a patient with just stones and nothing else, and the story is not that convincing, your likelihood that you have acute cholecystitis is rather low. However, if you have stones, you have wall thickening, you have pericholecystic fluid, and you have a sonographic Murphy sign, you can be quite certain of your diagnosis. Here's a nice still image representing some classic findings of acute cholecystitis on ultrasound. First, it's quite obvious. You can appreciate this gallstone in the gallbladder neck. You can see the acoustic shadowing. But in addition, it's a bit more subtle, but you can appreciate this anechoic signal tracking here posteriorly along the gallbladder wall. That represents pericholecystic fluid. And in addition, if you look anteriorly, you can see these two markers here. This represents the boundaries of the gallbladder wall anteriorly, which is probably on the order of a centimeter thick, so quite abnormal. So we have gallbladder wall thickening, we have a gallstone, and we have pericholecystic fluid. And that, with the combination of right upper quadrant abdominal pain, gives us a diagnosis of acute cholecystitis. Now, other patients may not have abdominal pain at all. They may have other presenting symptoms in your emergency department. If someone presents with jaundice, obviously that has a wide differential diagnosis. They could have hepatitis, they could have a pancreatic malignancy, but they could also have choledocholithiasis. And this is an image that you're not likely to see very often that's pretty cool. This is the portal vein, this is the common bile duct, which is a bit dilated, and if you look closely right there, that is a stone within the common bile duct, and that is indeed choledocholithiasis. Now, when you have a patient with jaundice, you want to assess particularly and measure the common bile duct, and obviously, as always, you want to examine the gallbladder for evidence of stones. There are also going to be some structures that you may identify and think is actual pathology when in fact they are just normal variants. And here's a couple examples of those. This is what's called a septate gallbladder. So here we have a large dilated gallbladder that's just kind of folded over on itself, and as a result, the wall just kind of has this hyperechoic appearance because you just basically have it folded over on itself, but you notice there's no shadowing. So you don't want to mistake this for a gallstone. This is just a septate gallbladder, and there's a bit of gallbladder sludge that's kind of layering out here. So this is not indicative of pathology. This is a slight variation of that called a Phrygian cap, where basically, again, you have a large dilated gallbladder, and the fundus of the gallbladder is folded over on itself, and as a result, you get this hyperechoic appearance right here, but this is not a gallstone. Note, there's no shadowing, and in addition, this is not dependent. If this were a stone, it should be way down here towards the neck of the gallbladder, not way up here as part of the fundus. So this is just a Phrygian cap, which is a normal variant and not indicative of pathology at all. Another thing you might encounter when you're doing your hepatobiliary ultrasound exam is you may occasionally encounter hepatic cysts. Now, a cyst is going to have very sharp, well-demarcated margins. It's going to be completely anechoic within the structure. There will be no septations. There won't be any evidence of material within the lesion itself. And you're also going to note posterior acoustic enhancement. So the area just deep to the lesion is going to be more echogenic than the areas adjacent to it. So this is pretty classic for a hepatic cyst. Now, contrast that with this liver. You see the diaphragm here. This is all liver parenchyma. Here's gallbladder. And if you look closely at the liver parenchyma, it does not look homogeneous. In fact, there are several areas of increased echogenicity, and unfortunately, this is an individual that has metastatic colon cancer, and these are hepatic tumors and metastases, unfortunately. Quite different than the hepatic cyst we saw on the previous slide. So one common pitfall is misidentifying the gallbladder. Sometimes the IVC may have a similar appearance, and you want to make sure that it's not also a loop of bowel that you're mistaking for the gallbladder. Remember, the gallbladder is going to communicate with the portal triad. So if you follow the structure and it tapers towards what looks like the gallbladder neck, and that tends to terminate with the portal vein and common bile duct, then you know you've got the right structure. The other thing that is a common pitfall is inadequate visualization of the gallbladder. You want to make sure that you look at the gallbladder in both a short and long axis, so scan it in two planes, and you want to make sure you get a good view by making sure the patient is properly positioned. You can either have the patient supine, you can try the deep inspiration technique that we talked about, or if those fail, you can rotate the patient left lateral decubitus, use the liver as a window, and come from the kind of anterior or middle axillary line, and then scan from a lateral to medial orientation to get a better view of the gallbladder as another alternate approach. Remember also that all shadows do not equal gallstones. There can be bowel gas. You can have edge artifact, as you can kind of see right here, for example. You see a little bit of kind of anechoic signal here, but that's not from a gallstone. That is from edge artifact. You can also have that from spiral valves within the biliary system as well. So just remember that all shadows don't equal gallstones. Look for the hyperechoic structure with posterior acoustic shadowing. And a very important thing to recall is that any gallbladder that has gallstones does not necessarily mean you have cholecystitis. Gallstones are common. In fact, they're present in approximately 20% of the patients that are over 50 years old. So a lot of people have gallstones. That doesn't mean that they have acute cholecystitis. So in closing, remember that right upper quadrant ultrasound is complex, but there's plenty of clinical experience and literature to support the fact that emergency physicians can do it very well with training and experience. It's not necessary to identify every structure you see on the screen. Remember, this is a focused, clinically driven exam. Ideally, you should be looking pretty much only for the gallbladder, the portal vein, the common bile duct, and then, of course, paying close attention to any irregularities of liver parenchyma, etc. But for the most part, you want to just focus on the questions that you're looking to answer. Don't get lost in the details. Start simple. Identify the gallbladder, identify the portal vein, look for the presence or absence of gallstones, and then if you're able, as you get more experience, try to identify the common bile duct. Assess for the sonographic Murphy sign. Fairly straightforward to do. These are some references used for this presentation, and I'm happy to take any questions. You can always reach out to me via email or also on Twitter. Hope that was helpful. Thanks so much for your attention.
I'm Kathleen Carter, RN, RVT. I'm a vascular sonographer. I live and work in Norfolk, Virginia, affiliated with Eastern Virginia Medical School. And I'm going to talk to you today about abdominal ultrasound, specifically the aorta and mesenteric systems. I'm going to talk about the abdominal Doppler, protocols and tips, specifically about the abdominal aorta and the mesenteric system. A little review of anatomy. The celiac trunk comes off just below the diaphragm, giving rise to the hepatic and splenic. And usually within 1 to 2 centimeters below that is the takeoff of the superior mesenteric artery, followed within another centimeter or so by the renal arteries. The inferior mesenteric artery is usually located just above the iliac bifurcation, prior to the division of the iliacs, and the common iliacs then of course divide into the external and internal iliac arteries. We're going to talk about aneurysmal disease that affects the abdominal aorta, aortic iliac occlusive disease, a little bit about dissection, and then we'll go on and talk about the mesenteric vessels. The adult abdominal aorta normally tapers as it traverses distally. It is normally about 2 centimeters in diameter. When ectasia is present, the diameter may range between 2 and 3 centimeters. So let's look at what this looks like. A normal aorta has smooth walls. You can see the takeoff there of the superior mesenteric artery and the abdominal aorta tapering as it traverses distally. When ectatic aorta is present, then you see you have irregular walls, some dilation that is less than an aneurysmal dilation, but irregular borders to the wall of the aorta. Once dilations become greater than 3 centimeters, and some literature says greater than 3.5 centimeters, that's usually considered aneurysmal disease. Once that now becomes greater than about 5.5 centimeters, intervention is usually indicated. In the iliac arteries, we usually look at an increase in the diameter of the artery by 1.5 times the normal diameter to call that aneurysmal. When the iliac arteries exceed 3 centimeters, that's when intervention is usually indicated in the iliac arteries. It's very important to measure these accurately, particularly since we're going to be measuring and following patients serially for increase in size of any aneurysm. So you need to be perpendicular to the vessel in both the transverse and longitudinal views. And we're going to look in transverse sagittal and perhaps coronal planes. So this is a transverse view of fusiform aortic aneurysm. We'll look and evaluate that, measure carefully, and estimate the amount of thrombus that might be present within the lumen. The iliac arteries generally are about 15 millimeters in size in men and a little smaller in women, and the externals are a little bit smaller than the common iliacs. When an iliac aneurysm is encountered, and this is a very large iliac aneurysm, almost 4 centimeters, we need to measure that. Again, estimate the amount of thrombus within that. You can see there's a smaller lumen, residual lumen, in this very large iliac aneurysm, and it's then evaluated both in transverse and longitudinal views. And you can see that this one actually extends down into the bifurcation of the iliac, internal iliac and external iliac arteries. When we encounter these, we need to measure them again carefully with a perpendicular orthogonal plane so that we're sure that we're measuring accurately. Aneurysms are usually fusiform. They may be saccular. It is good for us that most of them are fusiform because those are easier to measure accurately. A true aneurysm involves all 3 layers of the arterial wall. Pseudoaneurysms or false aneurysms are usually caused by injury or a hole in the arterial wall with flow maintained into a hematoma and do not involve all 3 layers of the arterial wall. Here's an example, both in longitudinal and transverse view, of fusiform aneurysms. You want to make sure, again, that you're truly perpendicular as you're doing these measurements. Saccular aneurysms produce a little bit more of a challenge to figure out exactly where to measure. It's usually an outpouching, as seen here, and may be easier seen in the long axis. So we're going to measure in both the longitudinal and transverse views for accurate measurement, and they should be somewhat similar. Now, I talked about how important it is to do accurate measurements, and we know that maximum aneurysm diameter measured by ultrasound and standard axial CT is not equal. And that's due to aortic angulation. Many times as people get older, the aortic neck will angulate, particularly when people begin to get a little bit shorter. It almost becomes redundant. So a study was done at the institution where I was working in Norfolk, Eastern Virginia Medical School, and that study was published in the European Journal of Vascular Surgery. I'll give you that in a moment. But the important thing is that we compared the ultrasound measurements to 3D reconstruction CT scans in which a perpendicular line could be mechanically dropped in and measured, and then compared that to axial CT. And in the presence of aortic angulation, there was significant difference in the measurements, and that's because the axial CT is doing a transverse cut through to the body, and when the aorta is angulated, you end up with an oval measurement, which is slightly larger on axial CT. The orthogonal CT or 3D reconstruction CTs, in which a true perpendicular line was placed, correct for that angulation, as does ultrasound. And as sonographers, we can correct for that angulation and perform these measurements perpendicular to blood flow. And again, this was published in the European Journal of Vascular and Endovascular Surgery in 2004 with the main author of Richard Sprouse. Good orthogonal measurements look like this. You make that fusiform aneurysm as round and large, as you can, and they should be fairly symmetrical, and that's what a good measurement should look like. Let's talk about the abdominal aorta spectral Doppler. When we encounter the aorta proximal to the level of the renal arteries, SMA and celiac, in that region, you're going to have more diastolic flow because the aorta is feeding partially the celiac artery, the renal arteries, which they're feeding a lower resistance vascular bed, such as the kidneys, the liver, and the spleen. So you're going to get more diastolic flow. Once you are below the level of the renal arteries, the aorta is pretty much just feeding a high resistant peripheral vascular bed and has a much higher resistant flow pattern. Aorta-iliac duplex can localize disease. We're going to be doing direct assessment of the aorta and iliac vessels. And careful color duplex ultrasound can determine a number of things for us. We can decide if the disease is focal, figure out the length of any focal disease, or is it diffuse throughout the entire arterial tree. And this piece of information may impact whether or not the patient gets surgical treatment, endovascular treatment, or just medical therapy. So we can determine the exact location of disease, estimate the severity, determine the length of stenosis. We may even be asked to measure the external diameter of the vessels and the residual lumen, and that may assist in sizing of any appropriate endovascular devices, such as catheters and balloons. We need to use high-resolution duplex ultrasound that has good spectral and color Doppler. We're going to use a variety of transducers that are based on the patient's body habitus. Usually we keep these patients in PO for 8 or 12 hours. They usually do not need a bowel prep. So the crux of the protocol is going to include examination of the aorta-iliac segments in transverse and sagittal planes, the entire abdominal aorta, and the iliacs. And the iliacs are usually best imaged in the long axis. And I include a picture here of a 3D reconstruction CT just so that you can see how tortuous these iliac arteries can be in many of these patients. And it is very difficult to maintain a 60-degree angle around a lot of the bends that you're going to encounter. So it becomes a bit of a challenge. Color flow can really be helpful in these exams. Because the iliacs are tortuous, they're deep. You may have overlying bowel gas. So you may need to use different approaches, and the lateral decubitus approach can be very helpful sometimes to change the approach and lay the vessels out in a more opportune approach for achieving that under 60-degree angle for spectral Doppler waveform collection. Need to recognize that there are some limitations and challenges to this exam, which would include patients who are obese, poor patient cooperation, and the ever-present abdominal bowel gas. We're going to look at the aorta-iliac, or the aorta first in proximal, mid, and distal, and collect samples there. And then the iliac, we'll look at the common iliac, the external iliac, the hypogastric or internal iliac in both transverse and longitudinal views using imaging, color flow, and Doppler. Special attention can be paid when there are changes. If you have your scale and your PRF set correctly, the color flow can give you a clue to where there are areas of increased velocity that you might need to investigate. Sample at less than 60 degrees with your spectral Doppler being parallel to the vessel wall at proximal, mid, and distal in each segment of the artery as you go all the way down to the groin. When we evaluate the abdominal aorta, here you can see this is the proximal aorta sample being taken parallel to the wall, and you would do proximal, mid, and distal. If there are any increases in size in the aorta as you go down, obviously we're going to measure those. We want to be, as in this example of the external iliac artery, parallel to flow at an opportune Doppler angle to get the optimum waveform. When you do encounter a stenosis, as seen here in a common iliac artery, we want to sample prior to the stenosis, within the stenosis, and document the peak systolic velocity, and then also document the post-stenotic turbulence that's present. In order to call a 50% diameter reduction that you might encounter across the course of an iliac artery, you need to have at least 100% increase in the peak systolic velocity from the adjacent segment and document the post-stenotic turbulence. There are some other criteria in the literature for if you want to break down anything between 50 and 99% stenosis, and sometimes a ratio greater than 4.1 is used to suggest a greater than 75% diameter reduction, or a peak systolic velocity greater than 400 centimeters per second. The severity of lesions distal to a high-grade stenosis may be underestimated, so that may be a limitation of the exam as you go through. So if you have a high-grade stenosis and then encounter further stenoses downstream, those stenoses may be underestimated in their severity because the head of pressure isn't going to be enough. Another sort of hampering of this exam is that in the aoroiliac segments, you can have a very severe stenosis in the iliac, or even a short segment occlusion, and if it's really well compensated with collaterals, at rest the ABI may be normal and the common femoral artery be near normal, and the only way you'd really uncover that is with exercise or reactive hyperemia. So that may be a limitation of looking at this exam. This is an example of when it is clear that there is not good compensatory flow. This is a common femoral distal to severe iliac disease. You can see that there's a very delayed rise to peak. There's a lot of diastolic flow when you normally would see no diastolic flow, and a dampened waveform where the peak systolic velocity is only in the 30s. Occasionally we will identify aortic occlusion. When that is done, you want to see where the runoff is, where the collaterals are coming out, document the occlusion with spectral Doppler, and follow down. Here you can see this is occluded all the way to the terminal aorta and no flow present within that segment by spectral Doppler. When we talk about dissections, sometimes you can identify new dissections or even old, more healed dissections. You can see the intima here in both transverse and longitudinal views is lifted away from the wall. You may or may not get 2 channels of flow within this. It just depends on whether or not the dissection has begun to heal down or not. But this should be documented in its length, and if there are 2 channels of flow, certainly should be documented with spectral Doppler in both areas. The extent of the aortic dissection should be determined. These can spiral up and dissect into the visceral vessels as well. Here's other examples of where plaque was present, and there is a short segment dissection that is curling up in certain portions of the cardiac cycle and then laying down in certain portions of the cardiac cycle. And in transverse here you can clearly see where the aortic dissection is. You want to have your PRF or your scale set so that if you do have any cavitations into the wall of the aorta, as in this case where you have a short dissection that became aneurysmal, if there's a small amount of flow going into this cavitation, then you want to be able to pick that up, and so make sure that the color scale is set appropriately. You can have pseudoaneurysms, and in this case a multilobular pseudoaneurysm associated with the aorta. Does not involve the layers of the wall of the aorta, as you can see, and that should be measured. Color Doppler and spectral Doppler can identify where there's any flow within those pseudoaneurysms. Also should be measured in size and what the residual lumen is that is still patent. We're going to go on now and talk about the mesenteric arteries that come off of the aorta. We're going to talk about the celiac. We're going to talk about the superior mesenteric as well as the inferior mesenteric arteries. Again, the review of the anatomy. The celiac trunk is the first branch off of the aorta after the diaphragm, followed within 1 to 2 centimeters by the superior mesenteric artery, and then the inferior mesenteric artery is located just above the common iliac bifurcation. The celiac axis is the first abdominal branch off of the aorta. It is about 2 to 3 centimeters in length and gives rise to the splenic, common hepatic, and left gastric branches. This can be evaluated in either longitudinal or transverse views. You get that sort of Y division there where the hepatic and splenic form a seagull or Y approach, some people call it. This again can be evaluated in either longitudinal or transverse, whatever works out best to see the bifurcation of those. Replaced hepatic artery can occur when the hepatic artery arises from the SMA instead of the celiac, and that can happen about 40% of the time. It is very rare for there to be a common trunk of the SMA and the celiac. So replaced right hepatic can occur about 17% of the time, a common celiac and SMA trunk about 1% of the time, and a separate hepatic off of the aorta about 1% of the time. And here is the celiac artery seen in transverse, so you see the aorta in transverse giving rise to that 2 to 3 centimeter length of celiac artery, and then the origins of the hepatic and splenic artery. We normally think about atherosclerotic disease when we're talking about the mesenteric vessels, but this is just an incidence in which we encountered high velocity, turbulent flow within the celiac axis as it took off from the aorta. And in this particular case, it was not due to stenosis, it was due to a dissection. So just keep in mind that there are other things besides atherosclerotic plaque that can cause increased velocity in these vessels. There was a study at Dartmouth that also suggested that we want to note the flow direction in the hepatic artery, and when the flow direction is reversed, that is usually compatible with severe stenosis or occlusion in the celiac artery, and you can backtrack to identify that. The superior mesenteric artery originates a centimeter or 2 distal to the origin of the celiac artery. It most often takes off from the aorta at a very sharp angle, almost 0 degrees, comes up, and then courses inferiorly parallel to the aorta as it arborizes into many branches. Color Doppler can be very helpful to identify the distal course of this and its branches. The normal spectral waveform in the fasting patient is fairly high resistant, and then postprandially, when all the blood vessels in the mesentery will dilate, you get forward diastolic flow throughout diastole. The inferior mesenteric artery looks much like that of the spectral waveform looks much like that of the superior mesenteric artery. It is the last major branch off of the abdominal aorta before the iliac bifurcation. It originates from the anterior aortic wall and then curves to the left and inferiorly. And it serves as a source of collateral flow. Some people have a difficult time identifying the IMA, and inability to identify it doesn't mean that it's occluded, it just means that you were not able to identify it. But with the practice, it's not that difficult to identify. Now, these blood vessels are connected through a rich collateral network through the arc of Rioland, sometimes called the wandering artery of Drummond. And this is very helpful because one vessel remaining of the 3 can supply the entire small bowel. So it's very important to know that these have such a rich collateral network that's present. Normal Doppler spectral waveform analysis of the celiac demonstrates forward flow throughout diastole with spectral broadening expected due to the size of the sample volume relative to the size of the artery. We expect peak systolic velocities normally to be less than 200 centimeters per second. In the superior mesenteric artery, we expect high resistant flow in the fasting state with a sharp systolic upstroke. There may be a little bit of turbulence proximally becoming more laminar distally as it does that sharp turn off of the aorta. We expect that normally peak systolic velocities will be less than 275 centimeters per second and the end diastolic less than 45 centimeters per second. So the mesenteric vascular diseases that are usually present, we're not going to talk much about acute mesenteric ischemia because there's very little role for the vascular laboratory or Doppler in the diagnosis of this disease. We'll talk more about chronic mesenteric ischemia. We may see ischemic colon disease, celiac axis syndrome, or mesenteric venous occlusion. Acute mesenteric ischemia is relatively rare. It has a very high mortality. It requires a very rapid, aggressive diagnostic and therapeutic approach before the bowel begins to die. Problems associated with this disease include delayed or uncertain diagnosis that leads to death of the tissue, accurate identification of where the lesions are, and usually intra-op is where decision-making happens. The etiology of acute mesenteric ischemia is usually embolic or thrombotic. It can be caused by venous thrombosis. Duplex has no real proven role in this. It's not a reliable test in unprepped patients with acute symptoms, and usually these people are diagnosed with biplane angiography. The clinical features associated with acute mesenteric ischemia is severe abdominal pain out of proportion. They're usually elderly with a history, comorbid cardiac and peripheral vascular diseases. They may have peritoneal signs and symptoms and bloody diarrhea. Atherosclerosis is about the main cause of chronic mesenteric ischemia. About 95% of chronic mesenteric ischemia is caused by atherosclerosis, and it usually involves the orificial portions, first 1 to 2 centimeters of the major visceral vessels. When we talk about the other 5% of things that can cause mesenteric ischemia, it can be arteritis, radiation, the autoimmune disorders, fibromuscular intimal hyperplasia, arcuate ligament compression, or coarctation of the abdominal aorta. 2 of the 3 mesenteric vessels, celiac, SMA, and IMA, must be abnormal for that patient to be symptomatic. If one is abnormal, you have to really try hard to find that IMA and look for any disease, especially if the patient is symptomatic. A single patent visceral artery is capable of supplying the entire small bowel. So if that occlusive disease develops slowly, patients can be asymptomatic with only one vessel really supplying it. Remember, though, that if one vessel is diseased, there may be elevated velocities throughout the remainder of the vessels due to compensation. So that piece of documenting peak systolic turbulence or post-stenotic turbulence to rule out compensatory flow as the main cause for increased velocity is very important. All 3 vessels are usually involved when there is disease present. One of the 3 vessels may occlude, and that's usually the celiac axis if it does. The SMA is usually the one that is most involved in narrowing, significant narrowing. Signs and symptoms of chronic mesenteric ischemia can include a gnawing and dull periumbilical or epigastric pain. It usually is occurring postprandially after meals and may persist for 1 to 4 hours. These patients develop a food aversion because food is what is causing their pain. They don't want to eat. They have significant weight loss and may get cramps in the abdomen that radiates to their back. Many times they have an epigastric bruit. The diagnosis can be made for this disease with either duplex ultrasound or angiography. The typical patient presentation is a female in 40 to 70 years old, displaying postprandial pain, weight loss, food fear, and usually these patients take a long time to get worked up for diagnosis. They're usually worked up for many months for ulcer, gallbladder problems, cancer, before the diagnosis is made of chronic mesenteric ischemia. So here are some examples of celiac and mesenteric stenosis where you can see that the velocity is so high, over 700 centimeters per second in the celiac here, that in its aliasing you can see a bruit associated with it, particularly in the SMA where the velocity is almost certainly over 500 centimeters per second. And then in the hepatic, distal to that celiac, you can see that the waveform is abnormal, it is bowed over, there's a delayed rise to peak, and it's certainly post-stenotic. Here is the splenic in that same patient where you see the splenic artery again is bowed over, has a delayed systolic rise time, and has a transmitted bruit even still within that splenic artery. This example is a very high celiac artery flow, but this was not due to celiac artery stenosis. This was a patient who had an infrarenal aortic occlusion and critical SMA disease. So the main runoff from the aorta was going out the celiac, causing a very high amount of flow within that. Stents. So many times these patients are treated with stents, and when we're looking at patients after the stent is placed, we need to walk the Doppler throughout the course of the stent. You may get higher velocities throughout the course of the stent as long as there's no focal increase. That may just be due to the decreased compliance of the vessel because of the stiff stent that's placed in there. But we would expect in a certain percentage of the time that these stents may restenose. So we want to walk the Doppler all the way through them, from the aorta all the way through to the end of the course of the stent. Interpretation of mesenteric disease, the celiac velocity should be less than 200 centimeters per second. If it's over 200, and has poststenotic turbulence, that's consistent with significant celiac disease. The SMA velocity should be less than 275 centimeters per second. Again, greater than that may be consistent with significant stenosis within that vessel. And the IMA, there's no absolute number associated with that, but it should be visualized with normal flow patterns and any focal increase in velocity documented. Are the distal waveforms dampened? Is there poststenotic turbulence? Is there a lot of collateral vessel development? All of those that can be clues to hemodynamically significant stenosis present. Now let's talk briefly about median arcuate ligament compression syndrome. Celiac artery velocities can be increased due to extrinsic compression by the median arcuate ligament. In that instance, the signals will normalize and decrease in velocity when the patient is examined sitting erect or during a very deep breath. So the SMA is almost never involved with this syndrome, and patients usually have a normal arterial wall and aorta. So we want to evaluate these patients both in the supine and sitting position, and if you can normalize the waveform and velocity, then it's not due to intraluminal problems, it's due to extraluminal compression by this median arcuate ligament. Now, interestingly, most patients who have this are not symptomatic. And about 50% of patients that have this situation are completely asymptomatic, which kind of indicates that the symptom complex may not be due to arterial stenosis. Thank you very much.
Hello everyone, my name is Anne Kennedy. I'm a radiologist working at the University of Utah in Salt Lake City in the USA. I actually do women's imaging as a career, but I am part of the abdominal imaging section, and one of my colleagues asked me to put together a talk on pancreas ultrasound for a session on abdominal imaging at the SRU meeting in Chicago this November 2011. So I did that, and I will admit that I am not a great advocate of pancreatic imaging, but I think like everything with ultrasound, if you apply yourself, there are many things that you can see and do to assist in triage of patients.
Okay, so we're going to talk about ultrasound of the pancreas. If you think about imaging the pancreas, in many cases ultrasound doesn't come to your mind as the first modality. Most people think about CT and MRI first, but many patients come into the healthcare system via the ultrasound department, either from the emergency room or for their family practice doc, with things like vague abdominal pain, maybe abnormal liver function tests.
When you think about ultrasound, there's a couple of different ways of approaching the pancreas. The standard one that we as radiologists use is the transabdominal approach, but our GI partners use endoscopic ultrasound, our surgical colleagues use intraoperative ultrasound, and our more imaginative colleagues are actually figuring out ways where you can use fiber optic technology to use intraductal ultrasound, whereby you're actually scanning the pancreas from inside the main pancreatic duct. There are also techniques like elastography and contrast-enhanced ultrasound that are not necessarily widely available but have potential to help us with differential diagnoses. And these are just some pictures that I have downloaded from the internet. This is elastography, and it shows the difference between a malignant and a benign lesion. Malignant lesions are very densely fibrotic and tend to be hard, and so they come out looking blue on the elastography. More benign masses, such as focal inflammation, tend to be less fibrous, less serous, and come out in the shades of yellow and green. Similarly, contrast enhancement of ultrasound is widely available in Europe and Asia. It is not FDA approved in the USA, unfortunately, but this is an example showing a swollen edematous pancreatic body and tail. Following contrast administration, the body enhances here, but the tip of the tail does not. And this indicates pancreatic necrosis, which is a very important complication of acute pancreatitis. And the beauty of this is that this exam can be performed at the patient's bedside in ICU. No need to transfer very sick ventilated patients down to the CT scanner. The other thing that we often do in the ultrasound department is do image-guided biopsies. And you can certainly use CT, but ultrasound allows you real-time visualization to look at your needle position at all times. We can do transabdominal ultrasound-guided biopsy. Similarly, our GI colleagues can do endoscopic biopsy, and this is an example of this with a lesion coming through the stomach wall into a pancreatic mass and the needle clearly in the lesion there. Our surgical partners use intraoperative ultrasound to localize masses. This is actually in the liver, but they can do the same in the pancreas, either to perform a biopsy for frozen section or to help them create their surgical planes for excision of a mass. As a prenatal imager, everything that I do revolves around embryology and anatomy, and the pancreas arises from two buds, a dorsal and a ventral. One arises near the stomach and the ventral arises near the liver. As the GI tube elongates and curves, these buds migrate and eventually fuse. The dorsal bud forms the pancreatic body and tail. The ventral bud forms part of the inferior portion of the head and the uncinate process. The normal arrangement is that the duct from the main body and tail unites with the duct from the ventral component to form the main pancreatic duct, and the distal portion of the dorsal duct atrophies or becomes the accessory duct of Santorini. If that doesn't happen, you have pancreas divisum, where the ventral portion drains into the major papilla, which is where most of the duct should go, and the main portion of the pancreas actually drains to the minor papilla. This is not something that's easily seen on ultrasound, but it is an important developmental variant because it can predispose to acute pancreatitis. Other developmental variants to think about are migrational abnormalities, and you can have ectopic pancreas left where these little buds migrate down to their final location. Those are most common in the gastric mucosa or in Meckel's diverticulum. The annular pancreas occurs when the buds, instead of getting to one side of the duodenum and fusing, actually encircle the duodenum and obstruct it. And this is a radiograph of a fetus. Well, it was a fetus that I saw. This is the radiograph of the newborn infant. And you can see the double bubble sign with a dilated stomach, dilated duodenum. And we thought prenatally that this was not typical for a duodenal atresia, as might be seen in Down syndrome, because the degree of obstruction seemed to be too far into the second portion of the duodenum. And we actually raised the possibility of annular pancreas as part of the diagnosis. And the baby was delivered, had a nasogastric tube placed correctly, and was taken to the local pediatric hospital, which is across the walkway from our institution, and had surgery confirming an annular pancreas. There are many contour abnormalities that happen if the buds fuse in an unusual manner, and this is just an example from the literature showing the bifid pancreatic tail that you may see if the buds don't unite in the conventional manner. Anatomy is everything in terms of imaging diagnosis. If you don't understand your normal anatomy, you can't pick out pathology. So the pancreas is a retroperitoneal organ. It lives in the anterior pararenal space. It's deep to the stomach, the colon, the greater omentum, and the left lobe of the liver. The splenic vein is structure that marks the dorsal or posterior border of the body and tail. The neck is marked by the confluence of the SMV and splenic vein to form the portal vein. The only parts of the pancreas that are actually behind vessels are the head and uncinate process, which wrap around the venous confluence, so that you actually have pancreatic tissue posterior to the SMV and SMA. The head itself is nestled into the curve of the duodenal loop, and the splenic tail, or the tail of the pancreas, goes up to the splenic hilum. And of course, although it's not in this image, the splenic flexure of the colon sits up here as well. The celiac axis marks the upper border of the pancreas, and the SMA travels behind the body of the pancreas, in between the body and the uncinate process. Here's an example of a CT scan with contrast. This is cropped down to show pancreatic anatomy, and I've put it side by side with the transverse ultrasound obtained in the epigastrium. And you can see that all of the anatomy that's displayed on the CT scan is also displayed on the ultrasound. This is the spine, as shown here. This is the right kidney. Here's the right kidney on ultrasound. Inferior vena cava and aorta, IVC and aorta on CT. Here is the pancreas running just superficial to or anterior to the splenic vein, body and tail of pancreas, and here's the portal vein confluence with the pancreatic head, the edge of which is slightly obscured by bowel gas in the duodenum. And this is the bowel gas in the duodenum on CT. If you think about the anatomy of the pancreas, the gland should be homogeneous in echogenicity and should resemble something like fine sandpaper. Overall, generally the echogenicity increases with age, and part of this is due to fat deposition or fibrosis, and it's usually more echogenic than the adjacent liver but might be isoechoic to it. Depending on what textbooks you read, the size of the pancreas is highly variable. In general, the head is slightly thicker than the body, which is slightly thicker than the tail, and equally the duct should be at maximum size in the head, slightly less in the body, and either invisible or very small in the tail. If all pancreases read the textbooks, they would all be shaped like a tadpole, like this pancreas, but they don't all, and they can come in dumbbell configurations or just unusual lumpy bumpy configurations. Equally, if you look in sagittal section, you can use the left lobe of the liver as an acoustic window, and here you see the aorta, the SMA and the SMV. This is part of the pancreatic head seen in sagittal section, and some of the tissue wraps around in between the SMA, SMV and the aorta to give you an echogenic focus here. Your technique transabdominally, it is vital that the patient be fasted. Everyone knows in the ultrasound world that bowel gas is the enemy. So you like to have your patients fasted, preferably overnight. You can use a variety of different transducers and a variety of different scan planes. And if you're unsuccessful with the patient just fasted, you can try a water bolus in the stomach as an acoustic window. And in countries where ultrasound contrast is available, you can give that. And that may be vitally important in differentiating between a hypovascular carcinoma and a hypervascular inflammatory mass. Also, surgeons do pancreatic transplants nowadays in the diabetic population. If you're going to evaluate a pancreatic transplant on ultrasound, it is vital that you know the surgical anatomy. You need to know where the surgeon placed the organ and what kind of anastomosis they made. There are two types. There's one that's called the systemic bladder type, in which the pancreatic venous drainage, which is via the splenic vein, is connected to this donor's iliac vein, and the exocrine function is directly attached to the bladder. This is technically easier for the surgeon, but is not physiologically very correct. The technically harder process is whereby the splenic vein drain from the transplant is connected to the recipient SMV, so it goes into the portal system as it does in the normal arrangement, and the pancreatic head exocrine function is connected to the recipient's GI tract, so that again the exocrine secretions go into the normal route rather than going into the bladder and being reabsorbed. Transducer selection. The curved 6 megahertz transducer is your workhorse in abdominal imaging, and as you can see in this picture, you can actually lay out the entire length of the pancreas with good transducer pressure. This is the spine, the aorta, this is the splenic vein coming along here. This is part of the SMA, and the SMV is actually obliterated by transducer pressure here. This is part of the splenic flexure of the colon, but it's being compressed so the air is not shadowing out the pancreatic tail. If you have a very slim patient, you can even bring out the linear transducers, and here you can see with a 9 megahertz linear transducer that you appreciate the marbleization of the normal pancreatic contour. What scan planes do we use? We start transverse in the epigastrium, and in that view you should see the neck, the body, and part of the head. Remember that the medial portion of the head is going to be partly obscured by gas in the duodenum. If you turn sagittal in the epigastrium, you can see the head and you can see the unsynaptic process tuck in behind the SMA and the SMV. An oblique left subcostal view will allow you to follow the tail out to the splenic hilum, and an oblique right subcostal view is essential to look at the gallbladder and biliary tree, because many processes that affect the gallbladder also affect the pancreas, such as stones, and if you have a pancreatic mass, you may inhibit biliary drainage. If you have limited views with the patient sitting or lying down fasted, you can then have the patient sit up. This shifts the diaphragm down somewhat and may reorient bowel gas and give you a better window. And you could also try the water bolus technique, in which you have the patient sip about 500 mils of still water, wait for approximately 10 minutes for any bubbles to settle, and then use the water-filled stomach as an acoustic window to the pancreas. After you have looked at the body and tail of the pancreas, you turn the patient right lateral decubitus, and the water will run into the duodenal loop, which then acts as an acoustic window to the pancreatic head. Here's some normal anatomy, transverse in the epigastrium, left lobe of liver. This is the body of the pancreas. This is going down into the head. This is the pancreatic duct, well seen where the beam is perpendicular. This is the pancreatic tail extending up into the left upper quadrant. Left renal vein is compressed between the aorta and the SMA as we apply transducer pressure to clear out all this anatomy. And here's the inferior vena cava and the spine. In the epigastrium, you turn longitudinal. Here's the liver. Patient's head is now at this end of the picture. Here's the transverse colon. The SMV is nicely elongated. Here's the aorta. You see the gastroduodenal artery and the common bile duct both in the pancreatic head, with that little lip of tissue from the unsynaptic process tucking in behind the vessels. Similarly here we have the SMA elongated in front of the aorta. The SMV is not so well seen in this image. This is pancreatic tissue. This is pancreatic tissue. Oblique left subcostal, as I showed you before, you can lay out the pancreatic tail very nicely. And oblique right subcostal, here is your common bile duct, paralleling the portal vein, gallbladder, no evidence of stones or biliary dilatation. Endoscopic ultrasound is, in my institution, performed by my GI colleagues. This is an example of the transducer within the stomach, and this shows this obvious inhomogeneous mass, which is accessible to FNA. This is another example where you can see the dilated common bile duct and the dilated main pancreatic duct coming down to a mass in the head of the pancreas. And this, again, is a typical appearance for an adenocarcinoma of the pancreas, causing biliary and pancreatic ductal dilatation. And you can see how easy it would be to get a needle in here for an endoscopic biopsy. So when you think about what you can see in terms of pathology in the pancreas, after anatomic variants, you essentially have pathologies that are either inflammatory or neoplastic. And of course, we have to think about the pancreatic transplant population in whom we are looking for complications of transplant. This is utilizing the extended field of view, or C-scape, and this is a newly placed pancreatic transplant. This is the associated renal transplant over here. There is echogenic fluid around the transplant, but the patient did very well initially, and I'll show you later pictures of his when we performed a biopsy to look for rejection. The different types of pancreatitis are listed here, and we'll discuss some of those in more detail, and we'll also review some of the findings of the various types of neoplasia. So in acute pancreatitis, we've all seen as radiologists the patient come in from the emergency room with right upper quadrant pain. You see some gallstones, the patient has an elevated amylase, and they go on to CT and have really quite marked inflammatory changes that were not that obvious on ultrasound. The findings can be extremely subtle, and the key to make the diagnosis is to actually look for ancillary signs of inflammation. So this is a patient with acute pancreatitis, and the pancreatic head, although the echogenicity is normal, it is slightly thickened. And if you look over here, there's fluid around the right kidney. There's quite marked gallbladder wall thickening. There were no gallstones and no sonographic Murphy's sign. Here's a list of all the features that you can look for signs of inflammation based on a study which was published in the Ultrasound Quarterly in 2005. This is a left pleural effusion and this is a right pleural effusion. And I'm going to show you more images of that same patient that I showed you earlier now to prove that you really can do this. Here's your mildly edematous, slightly thickened pancreatic head. Here is the pericholecystic edema and gallbladder wall thickening. I showed you fluid around the right kidney earlier. Here is fluid around the left kidney. And here again, right pleural effusion with atelectasis in the right lower lobe, left pleural effusion adjacent to the spleen. So all of these are indications of a diffuse inflammatory process in the abdomen. Complications of acute pancreatitis include necrosis, abscess, vascular complications. Later on, you may form a pseudocyst or develop chronic pancreatitis. And this is an example of chronic pancreatitis. This is the splenic vein which marks the dorsal border of the pancreas. So this is the dilated pancreatic duct which contains calculi. And these are the same calculi showing twinkle artifact on color Doppler. Pancreatic pseudocysts are commonest in the body of the tail, and you can see this nicely demonstrated in this graphic. They may be very circumscribed and smooth-walled, but they can, of course, be multilocular, and they contain internal echoes sometimes, particularly in the acute situation where they may be complicated by hemorrhage or infection. The utility of ultrasound in this circumstance is to be able to guide a needle into that fluid collection, because a pancreatic abscess is a surgical emergency, whereas isolated hemorrhage into a pseudocyst does not require a surgical procedure. And if pseudocysts become big enough, they can cause duct obstruction, which then increases the likelihood of more episodes of pancreatitis. Chronic pancreatitis eventually causes atrophy of the gland. The ducts will dilate, and that is a very common finding. And in fact, if you see calcifications within a dilated duct, it is virtually diagnostic of chronic pancreatitis. One thing to remember is that chronic pancreatitis does not have to involve the whole gland. It can actually be focal. And if so, it can be very difficult to differentiate focal pancreatitis from a focal mass such as pancreatic cancer. Elastography and contrast enhancement may help us with that, but oftentimes it comes down to needing a biopsy. Groove pancreatitis is a variant of pancreatitis that is relatively recently described, and it focally involves part of the pancreatic head tucked into the curve of the duodenal loop and is associated with cystic abnormalities in the duodenal wall. And this was a patient that came from the emergency room with right upper quadrant pain, look for gallstones. One of my previous fellows noticed the irregularity of the pancreatic head and suggested groove pancreatitis, which was confirmed on this CT. This is an important diagnosis to be aware of because these are frequently misdiagnosed as pancreatic carcinomas. And given the location in the pancreatic head, these patients may be set up for Whipple's surgery. And that is a huge operation that is not necessary for a benign process. So be aware of groove pancreatitis. There's another condition called autoimmune pancreatitis, which is also relatively new in terms of ultrasound features. And what you see with autoimmune pancreatitis is diffuse thickening of the pancreas with ill-defined anterior margins, and you cannot identify the pancreatic duct anywhere within this mass of pancreatic tissue. It's a systemic disease caused by deposition of IgG4 antibodies and is associated with biliary changes, so very often you will see biliary dilatation in association with this thick, inhomogeneous pancreas. In fact, if you look at the biliary system carefully in patients, there's a characteristic appearance called the trilaminar appearance, and you will see this striped appearance to the dilated common bile duct wall or to the gallbladder wall. And if you see this in association with the thick, ugly, edematous-looking pancreas like this, you can suggest the diagnosis of autoimmune pancreatitis, which can be verified with a simple blood test. Pancreatic masses. Primarily, you're worried about pancreatic neoplasms. There are many mimics, though, and this is where it becomes complicated because just the developmental abnormalities we spoke about, where the buds don't fuse in the conventional manner. If there's a pseudocyst that's complicated, if there's something in the duodenum, if there's a lipoma, if there's either focal fatty replacement of the pancreas or focal fatty sparing, you can appear to have a mass, and focal inflammation, focal pancreatitis, as opposed to diffuse. Different type of neoplasms are mentioned here, and intraductal papillary mucinous neoplasia is also an issue because you may just see a dilated pancreatic duct on ultrasound, and these are low-grade malignancies with the potential to develop an adenocarcinoma over time. Pancreatic cancer is an unfortunate cancer. It tends to be quite advanced at the time of diagnosis, so that 90% of patients are unresectable. The long-term survival is very poor, and many patients already have vascular encasement and lymphadenopathy and metastases at the time they present. Here's an example. A lady came in, she had been traveling on a cruise ship earlier in the year and had developed diarrhea, as had many of the passengers, but her diarrhea did not settle and she had precipitous weight loss. As part of her workup in the infectious diseases lab, she had liver function tests obtained which were abnormal, and she was sent for an ultrasound to evaluate primarily the gallbladder and liver. What we saw was this irregular, inhomogeneous mass with chunks of calcification that was occupying most of the pancreatic head, abutting the portal vein. And here's part of the pancreatic tail with what appears to be a normal duct, but over here you have this hypoechoic area that is different to the texture of the rest of the pancreas. We were very concerned for the possibility of a pancreatic carcinoma here. We looked around. This again is the mass in the pancreatic head. The common bile duct was not dilated because remember, this lady presented with abnormal liver function tests. She had some cystic masses in the abdomen, but she also had masses that had papillary excrescences. One of these was biopsied and it confirmed pancreatic adenocarcinoma as a primary. Here's the CT scan that shows this mass in the pancreatic head actually encircling the portal vein confluence. And here along the pancreatic tail you see the reason for that hypoechoic area. This in fact was an IPMN with subsequent development of an adenocarcinoma in the head. And here are correlative images from the MR and the PET-CT. Serous cyst adenomas are benign. They often present as a highly echogenic mass because there are multiple tiny cystic spaces which create multiple interfaces and look rather like the appearance we see in autosomal recessive polycystic kidneys in the fetus, where you don't resolve the cysts, you simply see the echogenicity from the interfaces. Mucinous cyst adenoma, on the other hand, has larger spaces and interstices, and here is an example of this, where you have this fairly benign-looking cystic lesion in the pancreatic tail. This is the splenic vein marking the dorsum of the pancreas, so this is pancreatic body and tail. And you note the small papillary excrescence in this mass, which turned out to be a mucinous cyst adenoma. Although these are malignant, they're generally low grade and they don't have as bad a prognosis as the conventional ductal adenocarcinoma. Islet cell tumors are either functional or non-functional. The functional ones, like insulinoma, present early because of their hormonal production, but they are small and hypervascular and can be very hard to see. Obviously, endoscopic ultrasound and contrast-enhanced ultrasound will be beneficial in looking for small lesions like this. The larger tumors are often necrotic with metastasis by the time they present, and they are easier to find. Other masses that affect the pancreas, metastatic disease is always a consideration. And I had never seen a pancreatic metastasis until just recently, and of all things, this mass in the tail of the pancreas here is a metastatic deposit from a carcinoid tumor of the cervix in a 26-year-old woman. So nothing is impossible. Lymphoma is the great pretender. Lymphoma can do anything, anywhere. It can cause diffuse peripancreatic infiltration, or so can acute pancreatitis. But you look for lymph nodes in the region, you look for systemic symptoms, and you check the laboratory findings. Focal or groove pancreatitis, remember we mentioned, is always localized in the pancreatic head adjacent to the duodenum, not to be mistaken for an adenocarcinoma, so that you can protect a patient from having an unnecessary pancreatic resection. This is an example of focal fatty sparing. This is a diffusely fat-replaced pancreas, and so the area that was relatively normal in echogenicity stood out from the background and looked like a mass. In the converse to this, you can get focal fat deposition in an otherwise normal echogenicity pancreas, and many of these things will need a biopsy to definitively exclude malignancy. Pitfalls in pancreatic ultrasound include body habitus, bowel gas, and the examiner's unwillingness to try. With endoscopic ultrasound, it's hard to be clear reading the literature because different descriptors are used, and there's a big move to standardize nomenclature in the literature so that different users can get together and pool their data. And even with intraoperative ultrasound, the surgeons may experience trouble by using too much manual pressure occluding vessels and by having near-field reverberation. This is an example where we thought, oh, there's a mass in the pancreatic body and tail here. Look at this hypoechoic thing. It persists. It's hypovascular. This must be a pancreatic cancer. Doesn't look like it's invading any vessels. This is potentially a great save. But when the lady went on to CT, this is a completely normal pancreas. And this is an example of the dumbbell configuration of the pancreas with a much thicker pancreatic tail than one normally expects to see. For the last few minutes of the talk, we're going to talk briefly about pancreatic transplant evaluation. This is just to remind you of the two different surgical techniques, and that you need to meet with your surgeon prior to performing the ultrasound so you know where the pancreas is in the patient's abdomen. You're looking for things like rejection, fluid collections, focal pancreatitis, leaks of fluid, and vascular problems. Here is an immediate post-operative study. There's some free fluid in the abdomen, which is not unusual post-op. Here are the iliac vessels, and you know that the vessels are going to be anastomosed to the iliac vessel in this type of pancreatic transplant. And here, these parallel lines are actually the pancreatic duct in the transplanted pancreas. Here's another example where this is the pancreatic transplant, and even with the use of power Doppler, we were unable to demonstrate much in the way of any flow, and spectral Doppler was very abnormal. And this was a pancreatic transplant with vascular thrombosis of the veins. Here's another pancreatic transplant, very conventional looking pancreatic head in the right lower quadrant. Single vessel seen nicely on color Doppler. Spectral Doppler shows very, very abnormal waveform with reversed end diastolic flow. And again, this was a venous thrombosis of a pancreatic transplant. Lastly, this is the chap that I showed you back at the beginning who had a pancreatic transplant surrounded by lots of echogenic fluid. He did well, went home, and he was back for a biopsy to look for rejection. This is the pancreatic head right beside the transplant kidney in the right lower quadrant. And as you can see, there are many small arterial branches all around this pancreatic head. That's the portal vein of the donor into the recipient's iliac vein. So a highly vascular structure. With ultrasound, we were able to line up with the short throw of the biopsy needle, look with color Doppler prior to taking the specimen, and see that each biopsy went through an area of the pancreas that would avoid those big surrounding vessels. So, in conclusion, I want to say, when you think about pancreas ultrasound, don't go, oh no! It is a retroperitoneal organ. It is often hidden behind fat and bowel, but with appropriate transducer selection and appropriate technique, you can see a lot of pathology and make a lot of diagnoses. Thank you.
Hello, I'm Dr. Oksana Baltarowicz, a radiologist from the Department of Radiology, Thomas Jefferson University Hospital, and from the Jefferson Ultrasound Research and Education Institute in Philadelphia. I'll speak to you today about sonography of the pancreas and spleen. First, I'd like to talk about the pancreas. I'd like to review the anatomy, some details, and highlight the vascular markers for the gland. Then we'll talk about some pathologic manifestations and the role of ultrasound. So why do ultrasound of the pancreas? Well, first of all, ultrasound is a screening modality for jaundice. So any patient with jaundice should first get an ultrasound. So that's a good place to start, and at least to look at the head of the pancreas. Now, although CT is much more accurate in pancreatic diagnosis, and also MRI now is a wonderful modality, and they provide more information for us, but we have to remember that not all patients can have a CT. For example, pregnant women, children, patients who have contrast allergies, who may not want to take the risk and undergo steroid prep, because a certain percentage of those patients break through with anaphylactic reactions. So in these cases, we should be prepared to do a full, proper evaluation of the pancreas. CT is not always available. Now, usually in the United States, there are CTs everywhere, even multiple CTs in a hospital, but in some of the countries outside the U.S., CT is not that available. Let's look at the pancreatic anatomy. The pancreas is a retroperitoneal structure. It lies posterior to the stomach. So the stomach with air in it would interfere with visualization of the pancreas, but also we can introduce water into the pancreas. So if we have to do a thorough evaluation of the pancreas, it's a good idea to have the patient drink some water and provide a sonic window for us. Now here we're going to peel away cut away the stomach, and right behind it is the pancreas. Notice how the head of the pancreas is hugged by the C-loop of the duodenum. This pancreas is very intimately related to a number of very important vessels. Here's celiac axis, splenic artery just above the body of the gland. Behind it is the superior mesenteric artery. Behind it is also the SMV and splenic vein forming the portal confluence. Notice the gastroduodenal artery that lies on the anterior surface of the head. Lots of very important anatomic markers, which we'll talk about in a few seconds. Here's a very classical, very well-known appearance of the pancreas on ultrasound. This is the splenic vein, and just in front of it is the pancreas. So we have the head of the pancreas, we have the neck, then the body, and here at least a portion of the tail. Then the tail wanders away towards the splenic hilum, so usually it's obscured by bowel gas. And here's a little piece of pancreas that hooks behind the splenoportal confluence and behind the splenic vein. That's the uncinate process of the pancreas. In Latin, uncus means hook, so this is a portion of the pancreas that hooks behind these vessels. This is a classical scan through the pancreas. However, this is very misleading because the head of the pancreas is 4 centimeters long. The body of the pancreas is about 2 centimeters in length in the sagittal plane. So we're only imaging a very thin section when we're hanging around this splenic vein. There are a number of vascular landmarks that we use to identify the pancreas and look for abnormalities. So I'd like to discuss the veins that are related to the pancreas, and that includes the splenic vein, superior mesenteric vein, the main portal vein, and the inferior vena cava. The splenic vein runs posterior to the body and tail of the gland. The superior mesenteric vein travels in a sagittal plane, and the two of them join together in a confluence, so this is a wider area where the main portal vein begins. The main portal vein crosses obliquely in front of the inferior vena cava, which is posterior. Notice here that the main portal vein is located at the superior surface of the pancreatic head, and the pancreatic head is rather long. Here's the uncinate process hooking behind the superior mesenteric vein. Now there's a number of arteries that are intimately related. There's the aorta, and off of it comes the superior mesenteric artery, which is right behind the splenic vein. Then we have the celiac axis. That's superior to the pancreas. It gives off the hepatic, the left gastric, and the splenic artery. This splenic artery travels along the superior border of the body and tail of the pancreas. Usually the pancreas goes no higher than the splenic artery. The gastroduodenal artery, which is not drawn here, would lie on the anterior surface of the head of the pancreas. So let's look at the splenic vein on ultrasound. Splenic vein lies posterior to the body and tail of the pancreas. It ends at the portal confluence where there's a little bit of a enlargement that resembles the shape of a cobra head. Some people have referred to it as the scallion, the little onion shape. And this is our marker for the body and tail. It's immediately in front. Here's another classical cut showing that portal splenic confluence a little better here with pancreas anterior to it. Now, the splenic vein is a useful anatomic structure because the pancreas being in front of it, we know that if masses are found anterior to the splenic vein, then they are of pancreatic origin. However, if there should be a mass located posterior to the splenic vein, then that's not a mass of pancreatic origin. That would be an adrenal mass or a retroperitoneal mass or a neurogenic type tumor related or a sarcoma of some sort, but not pancreas. The superior mesenteric vein courses parallel and just to the right of its partner, superior mesenteric artery. This vessel ends at the portal confluence where it joins the splenic vein. So it's the splenoportal confluence. This superior mesenteric vein is a marker for three parts of the pancreas. The head is lateral, the neck is anterior, and the uncinate process hooks posterior to the superior mesenteric vein. So we use that as a landmark. And here we have the head of the pancreas, the uncinate behind this portal confluence, and neck in front of the portal confluence. If we were a little lower, we would see it in front of the vein itself. Now, that was transverse. Now, when we look at the longitudinal sagittal scan, the superior mesenteric vein is a vein that looks kind of suspended in the middle of this abdominal cavity, and it ends in a little bulbous appearance, kind of resembling a cobra head. And that's the superior mesenteric vein, but on a longitudinal sagittal section. And this portion here that's bulbous is because of the splenoportal confluence. So the neck of the pancreas is anterior to this, and the uncinate process is posterior to the superior mesenteric vein. Now, when you look at an image like this, very often people see this characteristic kind of appearance of the vein, and they right away think that they're looking at the splenic vein. But be careful, because if it's a sagittal section, a longitudinal section, this can't be the splenic vein. This is the superior mesenteric vein ending at the portal confluence. This then is neck of pancreas, and the little echoes behind would be uncinate process. Very similar appearance on a transverse section of the body where we see the splenic vein. Now, we know we're transverse because we have the spine. There's a cross-section of aorta, cross-section of inferior vena cava. Here's a little superior mesenteric artery, splenic vein in front. Here we have a longitudinal appearance of a vessel and then spine behind. So here we're transverse. Here's our splenic vein. Here's longitudinal superior mesenteric vein. So we have to be careful not to mistake the superior mesenteric vein for the splenic vein. The longitudinal superior mesenteric vein is on a sagittal scan. The longitudinal splenic vein is on a transverse scan. And SMA, superior mesenteric artery, aorta, and spine are posterior to the splenic vein. Now, the main portal vein. The main portal vein crosses obliquely and anteriorly to the inferior vena cava. The pancreatic head extends just inferior to that point of crossover. So here we are on a sagittal section. This is the inferior vena cava. This round dark area is the main portal vein crossing in front of the IVC. That's our marker for the head of the pancreas. So all of this is head of pancreas that extends about 4 centimeters inferiorly, 4 centimeters in length. So this is our marker for the cranial aspect of the pancreatic head. Now the superior mesenteric artery. On a transverse scan, the superior mesenteric artery is cut crosswise, in cross-section, as a circle located anterior to the aorta. The superior mesenteric vein has a very characteristic echogenic triangle of mesenteric fat around it. That makes it easy for us to recognize. And in front of that then is splenic vein and then pancreas. Now, you may have a patient with a lot of bowel gas, but if you just visually spot that echogenic triangle with the hole in the middle, you know you are at the superior mesenteric artery. So that's going to be aorta in the back. The left renal vein crosses in between. The splenic vein is just anterior, and anterior to that is body of the pancreas. So we know that at least this part is part of the pancreatic body. Again, an echogenic triangle of fat on a transverse scan with a hole in the middle is SMA. In front of that is splenic vein. In front of that is pancreas. Notice here that the pancreas has a little hole in the back. That's the common bile duct passing through the head of the pancreas posteriorly, and a little hole anteriorly, and that's the gastroduodenal artery that lies on the anterior surface of the head. Now, if you ever see a picture like this, which is very confusing, and you use these landmarks to help you sort out where you are, you know you're transverse because here's the spine. This looks like aorta and inferior vena cava, and then you have all these masses, but you recognize an echogenic triangle of fat with a hole in the middle, so you know that's SMA. It's far and spaced far away from the aorta, and then you realize that you are staring at masses all over this region, the region of the pancreatic gland. On a sagittal scan, the superior mesenteric artery originates anteriorly off the aorta. The first branch off the aorta is the celiac trunk, and very close after it comes the superior mesenteric artery. Now, the celiac trunk is short. It points, I think of it as a long finger that points to the body of the pancreas. But the superior mesenteric artery curves and has a long course and parallels the abdominal aorta. It also has quite a narrow angle in between through which pass some important anatomic structures, which we will address later. That superior mesenteric artery has an echogenic kind of border around it because that's that mesenteric fat that surrounds it. In front of that is splenic vein, and in front of that then is body of the pancreatic gland. Now, this shallow acute angle of the superior mesenteric and aorta, there is a left renal vein that has to pass over the aorta. It comes right through this acute angle. So sometimes when the two arteries have too high of a pressure, they can pinch off the left renal vein. A little bit inferior would be uncinate process, and then the third part of the duodenum crosses over. But the important thing is the left renal vein. So if you're looking at this sagittal section of the body and you see the aorta, but you do not see a normal superior mesenteric artery paralleling the aorta, you see that you recognize the vessel, but the angle now is very wide, and then you notice that all this tissue is surrounding it, displacing the artery from the aorta, and this is all an invasive tumor of the pancreas, recognized by with invasion of the superior mesenteric artery due to that narrowing. Now, the celiac artery, I already mentioned that it's the first major trunk coming off the aorta. It's not very long. It looks like a long finger pointing to the body of the pancreas. Notice that we have the abdominal aorta, and it's paralleled in front by a thin hypoechoic stripe. That's the crus of the diaphragm, or a slip of the diaphragmatic muscle, which stops approximately at the takeoff of the celiac artery. And then comes the superior mesenteric artery. This patient shows the collapsed left renal vein passing between superior mesenteric artery and aorta. This celiac artery points to the body of the gland, behind which is the splenic vein. The splenic artery has a tortuous course, and it travels along the superior border of the pancreas. It's a marker for the cranial edge of the pancreas. It lies superior to the vein, which is directly behind the body of the gland. So it's a marker for the cranial aspect. Notice also that it has a very tortuous course, and it sort of weaves in and out and up and around the top part of the gland. We don't know why it tends to be tortuous, but even in young people it may be somewhat tortuous. Now, this is something to remember because there's a pitfall that can occur with this splenic artery. If you ever see a little cystic mass in the pancreas, the first thing you should think of, could this possibly be a piece of the artery that's weaving in and out? And you turn on the Doppler, and sure enough, this was just the splenic artery. Any cystic structure then in or around the pancreas should be interrogated with color Doppler at least. Now, the same thing holds for a little calcification. If you see a little calcification coming from the gland, and here's another example, little calcified rounded mass with shadowing. Here's another one, looks like a calcified structure in the body of the gland with shadowing. Turn on the color, because this could be that tortuous calcified splenic artery, and it often calcifies. So do not think that this is a calcified little mass in the spleen, in the pancreas. It's in the artery. So here's a summary of all these vascular markers for the pancreas. The splenic vein marks the posterior aspect of the body and tail of the gland. The superior mesenteric vein and the confluence are borders of the head, neck, and uncinate process. The splenic artery marks the cranial edge of the body and tail, and the main portal vein, not seen on this picture here, marks the cranial margin of the pancreatic head. So as you're scanning around and you see some unusual tissue, you wonder where you are, what's going on, you immediately refer to your landmarks. You say, okay, spine, aorta, IVC. You can recognize the SMA surrounded by an echogenic triangle of mesenteric fat. And now you know exactly where you are, and in front of that should be the splenic vein, which we can't find. Instead, there's some lumpy, lobulated solid tissue with small cystic spaces, and this turned out to be a diffuse pancreatic cancer involving the gland and already invading the splenic vein. Now, if you are asked to do an ultrasound of the pancreas itself, you should not only scan all of these margins, but all of these surrounding vessels, but you should also do sagittal sections of the pancreas. So I'd like to go over these. Let's look at a sagittal section through the head, through the neck, through the body, through the distal body or proximal tail, and through more of the distal body. Let's see what those sections look like. Here goes sagittal section through the head. Our markers are IVC with the crossing main portal vein. Just below is the 4 centimeter long pancreatic head. We move to the left, towards the left of the patient, and here we run into this vessel that has a blunted end, looks like a cobra head, but it's on a sagittal. So we know that's superior mesenteric vein, and in front would be pancreatic neck, and behind are uncinate process echoes. We move more to the left of the patient, and we pick up the aorta with SMA. In front is splenic vein. The celiac points to the body of the pancreas. We go more to the left, and we see two rounded structures, like two eyes looking at us. That's the splenic vein behind the body of the pancreas, which lies behind the antrum of the stomach. And the one that's more superior is the splenic artery, which rides along the superior part of the body and tail of the pancreas. And then as we progress a little more lateral, we can follow the echogenicity of the tail, and then we will lose it as it heads towards the hilum of the spleen. There will be too much surrounding bowel gas. So I want to bring you back, now that you know how to examine an entire pancreatic gland, I want to bring you back to this classical picture that on a daily basis is imaged by sonographers. Is this a normal pancreas? Well, we see aorta, SMA, IVC, part of the splenic vein. We see some echoes from the pancreas, uncinate, head, neck, body. Looks okay, a little heterogeneous maybe, but we don't see any unusual problem. That's about as much as you usually get on a standard view of the upper abdomen. You don't get the additional cuts, so you cannot say that the pancreas is normal. All you can really say is that portions visualized are normal, or portions visualized are grossly normal. The same patient, a few centimeters inferior, had a mass, a solid mass, when biopsied was pancreatic cancer. So this is a sagittal of that cancer. This is IVC. This is a main portal vein. Here's the pancreatic head, and hanging off the inferior part of the head is this solid pancreatic cancer. So we have to be careful. We do not want to mislead clinicians by saying there's a normal pancreas when we haven't examined the complete gland. Another little anatomic detail is the pancreatic duct. Now this is a small little tubular structure that runs down the very center of the gland, seen here as a thin tubular structure down the middle, surrounded by pancreatic echoes on both sides. There is no vessel that runs down the middle of the pancreas like this. So the only thing there would be the tube, pancreatic duct, which is not more than 2 millimeters in diameter. Here's another picture of this visible little duct here, surrounded by pancreatic echoes, and if you follow it, it will curve around and join the common bile duct and then onto the duodenum through the ampulla of Vater. Now, sometimes you look at the image of the pancreatic area and you see a dark stripe. Be careful, don't call this a pancreatic duct until you're sure that it's a duct. And what I mean by that is follow the course of this stripe. This does not assume the course of the pancreas. Even though it kind of faked you out at first, you'll notice there are no pancreatic echoes on the other side. So this is not the pancreatic duct. In fact, this is the posterior wall of the antrum of the stomach. Here's the anterior wall, and this is internal collapsed mucosa, and then filling with the gas. So just to call pancreatic duct dilatation, we want to see it directly inside the gland. And if you follow that posterior wall, you'll see that it blends and stays with the stomach. The common bile duct courses through the head of the pancreas. It should not be mistaken for a pseudocyst, especially when it's enlarged. But when it's enlarged, what we should do is track down the duct, take small sections inferiorly to make sure there's no stone or tumor down there. Here's the head of the pancreas, SMV, SMA, and lateral is the head. There's the distal duct with an obstructing calculus directly embedded in the distal duct. So we want to follow that, make sure we don't miss that. One other thing you should know about the pancreas is that it can have there can be two shades of echogenicity in the head. Sometimes you'll see that the most posterior part is a bit hypoechoic. Embryologically, the pancreas originated from fusion of the dorsal and ventral Anlage, so-called Anlage. Now, the reason it has different shades is some investigators tell us that there are different fat content within this mass, therefore different echogenicity. The important thing here is not to mistake this for a mass. Notice it has a fairly straight edge of demarcation. Here's another one, hypoechoic, more in the uncinate compared to the anterior part of the head. Sometimes it gets kind of prominent. We watch for the internal architecture, but if it gets too round and too dark, we have to think of a mass. Now, this one was a cancer in the head of the pancreas, and these were just areas of different fat infiltration. Let's look at some pancreatic pathology. We'll look at acute pancreatitis, chronic pancreatitis, some of the pancreatic tumors like cancers, and some others. Now, acute pancreatitis is usually a diffuse process, although it can be focal. It's a diffuse enlargement of the gland, and the gland becomes hypoechoic relative to the liver. In this case, it's not hard to recognize because the gland is swollen. But we have to be careful when, let's say it's a subacute situation, because sometimes the liver is fatty, which makes it more hyperechoic, which could make the pancreas look hypoechoic. So we have to watch this relationship and see which of the organs is abnormal. Is it the liver that's too hyperechoic, which makes this look hypo, or is this truly acute pancreatitis hypoechoic, and this is just a normal liver? On this sagittal image, the head is markedly enlarged. Here's the portal vein located inferiorly. Here's the bile duct heading into the posterior part of the head of the pancreas. Looks large and bulbous, and this was also involved with acute pancreatitis. Acute pancreatitis can be focal, and that can mimic carcinoma. That's why we do follow these patients in the next 3 or 4 weeks with a scan to make sure that all of this has resolved. This type of focal appearance is more likely to occur in the pancreatic head than it is in the tail. If it occurs in the tail, it's much more likely that that's going to be a carcinoma. There are complications of acute pancreatitis. If this is not treated and does not start to resolve, the process can worsen. It can turn into a phlegmon. Necrosis of the gland can ensue. It can turn into an abscess. It could bleed into itself. If it heals, a pseudocyst may form. It can obstruct the biliary tree. There's problems with veins. There's problems with arteries, and we'll see some of these. Here's a pancreas, SMA, splenic vein was in here, and the gland is edematous. But off to the side, we saw streakiness throughout the abdominal wall musculature and in the retroperitoneum. And this is what a phlegmon looks like, which is formed from edema and continuous leakage of these activated pancreatic enzymes in between these tissues. Now, pancreatitis can become infected. There will be leakages of fluid around the gland. Sometimes there's areas of irregularity, which could be tissue necrosis. If it's superinfected, if the patient gets fever, there could be abscess formation. Here there's some shadowing. When the acute pancreatitis becomes infected, this is a life-threatening complication from this. Now, what is the role of ultrasound in patients with acute pancreatitis? Well, it's not so much the imaging of the gland, it's all the other things. First of all, gallstones. patients who have gallstones can have recurrent bouts of acute pancreatitis. Now, usually people think of CT as the imaging modality for pancreatitis, but on CT, gallstones are poorly visualized. Only about 15% of gallstones are calcified, which means you can see them on CT. The other 85% of gallstones are not calcified, so they don't show up on CT. So ultrasound would be a great way to first investigate and see what's going on in the gallbladder. We can see biliary ductal dilatation by this swollen edematous gland. We can look for the complications that we just talked about. If there's a fluid collection, we can follow the fluid collection with ultrasound rather than keep repeating CTs. We can use it for aspiration of collections and a guidance for drainage. And sometimes we pick up unsuspected cases of pancreatitis. As the process continues and slowly begins to heal, a pseudocyst may form. Pseudocysts are cystic masses that form 90% of cystic masses of the pancreas. This fluid becomes encapsulated. It's a mass-like fluid collection. There's inside is tissue, edema, enzymes, blood, debris. All of this then incites an inflammatory response, and there's a thick inflammatory fibrous capsule that forms. Pseudocysts can range from small ones, 2 centimeters in diameter, to 20 centimeters in diameter. They can be multiple, as they were in this patient who had 1, 2, 3, 4 pseudocysts. They may occur in remote areas. Remember, the tail of the pancreas wedges its way into the splenic hilum, so the pancreatic enzymes can dissect into the hilum, can dissect into the spleen. You can have intrasplenic masses, collections. They can extend into the paracolic gutters. They can even extend into the mediastinum. Now, pseudocysts can have complications of their own. They can become superinfected. They can bleed into themselves. They can even rupture. They can have calcifications in the wall. And here we see several of these complications. Another complication of acute pancreatitis is thrombosis of adjacent veins. So intimately related is that splenic vein that it easily becomes thrombosed. Spiromesenteric vein can become thrombosed, and the thrombus can extend up into the portal vein, as it is in this case. Another complication happens when the enzymatic juices dissect into an arterial wall and then destroy part of the wall, and pseudoaneurysms are formed. So that can happen in any one of those intimately related arteries like splenic artery, gastroduodenal artery, superior-mesenteric artery, hepatic artery. So once again, any cystic structure in or around the pancreas should be interrogated with Doppler. Here was an innocent-looking little cyst, but when they turned on the color Doppler, it had a to and fro yin-yang type of flow, which is seen with a pseudoaneurysm. A pseudoaneurysm can occur in the splenic artery in the hilum. These enzymes dissect into the hilum and erode the spleen. And a similar appearance can also be caused by a pseudocyst. So pancreas can cause a large cystic mass in a spleen in 2 different ways. One is that it's a pseudocyst in the spleen, and the second way is that it's a large pseudoaneurysm of the splenic artery, for which color Doppler will be very useful. Always turn on Doppler with pancreatic cystic masses or splenic masses. Now, there's a chronic pancreatitis that can occur. Now, once the gland has undergone these insults, it can heal with fibrosis. Calcifications can be precipitated. Usually what we see is a smallish gland with increased echogenicity, and it's very heterogeneous, with punctate calcifications, sometimes coarse, causing shadowing. There's an irregular, dilated, beaded pancreatic duct. The pancreas echoes are on both sides of this arrangement, and fluid collections can also form. Now, this chronic pancreatitis sometimes is focal. Now, most of the time it's diffuse calcification, diffuse process, but sometimes it can be focal and can mimic a carcinoma. The giveaway is the areas of bright reflectors and shadowing, which is the calcium. So we can have scattered calcifications. That would be our clue. And sometimes we see small cysts in the pancreatic mass, the focal pancreatitis. This was chronic pancreatitis. These patients have to be followed. Sometimes a biopsy is done, but the calcium would be a very telltale sign, important telltale sign of chronic pancreatitis. Cancer of the pancreas. Now, cancer is hypoechoic. Cancer of the pancreas is dark. It's hypoechoic. There have been no cancers of the pancreas that have been hyperechoic. There have been no cancers of the pancreas that have been hyperechoic. So here's a hypoechoic mass in the head of the pancreas. Here's a hypoechoic mass in the body of the gland. 60% of the pancreatic cancers are in the head, 40% are in the body and tail region. Here's a patient with pancreas, and as we were imaging down the tail, we noticed a hypoechoic mass, lobulated irregular mass, extensive down the tail. Now, when we see such a mass, we immediately look for adjacent vessels because invasion of the vessels or encasement of the vessels is a common presentation. Here the splenic vein is barely visible because it's invaded, and here on a sagittal section the artery is present, but the vein is hardly discernible. We will check for biliary obstruction. Here's bile duct dilatation. At the end of the duct we see a hypoechoic solid mass. And we look for biliary dilatation inside the liver, for which we can do color Doppler to show that those are not vessels, that they are bile ducts that are not filling with color. A mass in the head of the pancreas will cause obstruction of the pancreatic duct. That means the duct is enlarged, and the duct shows up as a beaded type of tubular structure running down the middle of the gland. So here we have SMA, splenic vein, pancreatic duct down the middle of the gland, and a very abnormal mass in the head of the pancreas. And here's the cancer also on this slide. Now, after we've assessed the pancreas, it's very common for the pancreas to metastasize to the liver. So we're right there, we check the liver, here's a metastasis, a focal lesion, here's another patient. This changes everything. This is now stage 4 disease. You can easily take a needle, stick it in there, get tissue diagnosis, and have a diagnosis in 24 hours. You can see adjacent lymph nodes, you can see the tumor invading locally, lots of things to pick up with ultrasound. There are cystic neoplasms that occur in the pancreas, such as microcystic adenomas, cystadenomas, well known, macrocystic adenomas, including mucinous cystadenocarcinoma, cystadenoma, can occur. There are tumors called IPMNs, intraductal papillary mucinous neoplasms of the pancreas. There are larger multiseptated cystic masses that grow quite large in the tail. There are also a whole separate category of pancreatic masses that originate from the endocrine part of the gland. All the cancers that I've been talking about till now are originating from the exocrine part of the gland. The endocrine part of the gland have unusual presentations. These are these islet cell tumors, and they have different names based on what they secrete. So if a patient is having too much insulin and having episodes of hypoglycemia, then these are insulinomas. If they have high gastric secretion production, these could be gastrinomas. There are vipomas, there's glucagonomas, there's somatostatinomas. These are these tiny ones. They're often not even visualized. We're lucky here in this case to see a small little nodule. Usually they're small, very hard to find, but the endoscopic ultrasound that the gastroenterologist passes into the stomach and images from inside the stomach, that's really the most sensitive way to find these small tumors, which could be biopsied. It's not unusual for surgeons to call us into the operating room for us to come with our laparoscopic ultrasound to help them find the little mass which they can't see. So what happens is the surgeon has the abdomen and retroperitoneum and the gland exposed. We come to the operating room, glove up, dress up in sterile technique, cover the probe, and then run our probe over the surface of the gland after they put a little saline in, of course, and then we can sometimes pick up a very small tumor with our high-resolution laparoscopic probe. In some cases, we can't even find it. Sometimes the surgeon just does a blind kind of a resection. This is a very unusual disease of the pancreas, and that is lymphoma of the pancreas. Here's two cases for you to look at. They're just infiltrative, very large, not very characteristic masses. They're rare to be primary in the pancreas most of the time. There's other disease elsewhere. There will be enlarged lymph nodes, etc. So that's usually a very difficult diagnosis to make. Okay, now the spleen. The spleen is a small organ that sits in the left upper quadrant, very closely applied to the left hemidiaphragm. It almost looks like the echogenicity of the liver, except that it does not have the bright portal vein walls that are characteristic of a liver. The spleen has a different architecture. It's made of red pulp, white pulp, so it has basically a nice homogeneous texture with a few little vessels penetrating it that you can see near the hilar area. It's homogeneous, moderately echogenic. The spleen sometimes moves around. There is a phenomenon called the wandering spleen, also called floating spleen, ectopic spleen, ptotic spleen, aberrant spleen. The spleen is on a vascular stalk, and sometimes it can move around the abdomen from the left upper quadrant to the middle. This one landed in the pelvis. It looked like perhaps even an endometrioma in the pelvis. Here's the ovary. Here's the retroverted uterus. And this patient eventually twisted its vascular pedicle, and the spleen underwent torsion, and the diagnosis then was proven. What about splenomegaly? When is the spleen too large? Now, there's conflicting information in the literature. Some say over 14 centimeters long. Others say that you should just look at the way the spleen looks in relation to the kidney. Certainly, if the spleen is much longer and larger than the adjacent left kidney, that's splenomegaly. I personally like to use 13 centimeters. Anything beyond that would be splenomegaly. Others might use 14 or more. If I sometimes think the spleen is too long, but I'm not sure if it's really enlarged, I sometimes use more than 6 centimeter thickness as another indicator that that spleen is enlarged. Certainly if it has a mass effect on the kidney, that's another sign of enlargement. Around the spleen you will see small isoechoic nodules. These are quite common. They're usually small, less than 3 centimeters in diameter. They are accessory little spleens. They're developmental, You have their blood supply coming from the splenic artery. You can see them in up to 10% of patients. They're more common when the spleen is enlarged. They're usually solitary, but they may be multiple. But importantly, they should not be confused with lymphadenopathy and should not be confused with masses from adjacent organs like an exophytic renal mass. So you have to be aware of this. Now, there's another way that we can see little spleens in the body. Now, what I showed you just before was accessory spleens. There is such a thing as splenosis, these small little masses that are splenic tissue. But splenosis occurs only after spontaneous disruption of the spleen. And there's not spontaneous, but after splenic trauma or rupture. And then we have these little islands of splenic tissue that spontaneously transplant around the peritoneal cavity. They parasitize blood supply from the peritoneum. They can implant anywhere. They have a very characteristic appearance. They can even extend down into the pelvis. They can attach to peritoneum, omentum, mesenteric surfaces. In the pelvis, they simulate endometriosis, which happened in this patient. However, she had had a splenectomy after a motor vehicle accident, after her spleen was ruptured, and she had several of these little masses. These were removed. They were splenic tissue splenosis. They parasitize blood supply from adjacent areas. They're not fed by the splenic artery. There are masses that occur in the spleen. Here's a list of cystic masses that can occur. We'll show you a few of these. Here's a pure cyst that occurs in the spleen. The true cysts with the true lining are rare. Most of these are secondary to old trauma or hematoma or even a pseudocyst inside the spleen. They can be complicated by hemorrhage or infection, just like any cyst. Most of the time when there is a splenic laceration or hematoma, that is handled by CT, but in some patients, like in children or young adults that are stable, that do not need to have CT follow-up, for example, we can evaluate and follow the spleen. Look, here we have linear hypoechoic defects throughout the spleen, which is a laceration that was stable. Here's a patient who developed a spontaneous bleed on anticoagulants. Both were stable, did not require any surgery. We can see subcapsular hematomas, and there is sometimes difficulty in defining the extent of the subcapsular hematoma, because it can often look very much like the spleen itself. One thing that could be helpful is to do Doppler and watch where the vessels end, so we would know that's the end of the spleen, and all this heterogeneous material outside is perisplenic hematoma. Another thing that you should be aware of is that the left lobe of the liver can come around and hug the spleen. Now, it gives kind of a two-tone, double-shaded appearance to the spleen. The splenic tissue itself is homogeneous, and look for little portal vein walls inside this piece of liver that's coming way over to the left from the left lobe. This is easily mistaken for subcapsular hematoma. So if you see such a thing, such an appearance, think of liver adjacent to spleen rather than a hematoma. There can be a liver abscess. It looks like an abscess anywhere in the body, usually regular, thick-walled with internal debris. Especially think of bacterial endocarditis, secondary to embolism or septicemia in such patients like drug abusers or immunocompromised patients. Hydatid disease is an endemic disease in certain areas of the country, usually related to sheep raising areas. It sometimes bypasses the diagnostic list, but in endemic areas, this certainly is known. Here's two examples of multiseptated masses. Little small microabscesses can occur in the spleen just like in the liver, and these are usually due to fungal infection and have little small target lesions with a little echogenic nidus, which is the bullseye lesion of the microabscess. Intrasplenic pseudocysts can occur after trauma, which means that there was an organized hematoma after an occult rupture, or it can originate from the pancreas, a pseudocyst from dissection by the enzymes. Cystic masses around the spleen can be due to arterial problems, in this case a splenic artery aneurysm, which can form after atherosclerotic disease or from septic emboli, infection, or trauma. This has high morbidity and mortality and usually has to be treated when it's over 1.5 to 2 centimeters in diameter. They're somewhat rare. The pseudoaneurysm would be more common from pancreatitis or trauma, and in this case there are two of these. These happen to be intrasplenic pseudoaneurysms. More cystic lesions that occur in the spleen could be primary metastases from a primary tumor that is cystic, like an ovarian cystic mass. Sometimes there's a metastasis that undergoes cystic degeneration, maybe internal hemorrhage, necrosis, or infection, and that can cause this irregular, thickened, appearing mass, which would be suspected of being tumor or an abscess. When we talk about solid splenic masses, again, we have a list of things. The most common thing would be little granulomas. These are little calcified granulomas, echogenic spots and dots throughout the spleen. Tiny little shadows can be demonstrated coming from these, and these usually are due to granulomatous disease, exposure to histoplasmosis, in some areas tuberculosis, and think of sarcoidosis. Now, spots and dots in the spleen can also be caused by something called gamma-Gandhi bodies. This is known in MRI, but occasionally can be picked up on ultrasound. These are siderotic nodules, nodules of fibrous tissue that contain iron and calcium salts. That's why they're picked up on MRI. And these are actually little healed focal hemorrhages with necrosis. That's why they become hyperechoic. When you see these, you have to think of portal hypertension. Sickle cell anemia is probably the next most common cause. And then there's some other more unusual entities. However, seeing these spots and dots, you think of granulomas, you think of gamma-Gandhi bodies, you think of histoplasmosis, sickle cell, and disseminated pneumocystis can look just like that. Here's a patient with HIV. He has disseminated pneumocystis carinii, and here's his spleen in the left upper quadrant with left kidney, little spots all over the parenchyma. Here's the liver, also with echogenic numerous foci, and the right kidney. These patients, we used to see more of these in the past when patients were treated for HIV with pentamidine. So they would inhale the pentamidine to protect their lungs, but the disease would go then systemic and affect their parenchymal organs like liver, spleen, pancreas, and kidneys. We don't see as much of this because HIV is much better controlled, but in case you do spot this, you should think of HIV first. Infarcts are a classical wedge-shaped, peripherally located hypoechoic defect, which can be seen with septic emboli or just simply thrombosis of vessels. It's the most common focal lesion in the spleen. with septic emboli, we have to think of drug abusers. It occurs in patients with endocarditis, atrial fibrillation, and patients who actually get vessels thrombosed in the spleen. We have to think of sickle cell disease, pancreatitis, leukemia, and lymphoma. Hemangioma in the spleen looks just like hemangioma in the liver. They're rare in the spleen, but occasionally you'll see them. They're typical masses. They do have variable features. They're indistinguishable from any other etiology. So this can be a difficult diagnosis. MRI is usually helpful. And they may actually even require splenectomy to make the final diagnosis. The spleen size, however, is usually normal. Hamartomas can occur in the spleen. These are benign neoplasms. They're asymptomatic, often incidentally discovered at autopsy. Now, lymphoma, that's a common mass of the spleen. So if we see single or multiple hypoechoic solid masses throughout the spleen, we have to think of lymphoma. It could also be hyperechoic masses. We would look for additional lymphadenopathy and additional history. Now, metastases, that's another big category. So we've got like granulomas, hemangiomas, lymphoma, and metastases in the spleen. Rarely, these are seen, or at least they used to be rarely seen outside of autopsy, but now with all this imaging techniques, we do see masses, late manifestation of metastases in the spleen. Usually they arrive there by hematogenous spread. The important tumors are melanomas, breast, lung, and colon that like to do this. And the longer patients survive with better treatments, the more likely we are to see these manifestations of advanced disease. And finally, at the very end, there's one tumor that's kind of specific or special to the spleen, and that's the angiosarcoma. It's very rare. It's a primary malignant tumor, originates from epithelial cells. It's usually solitary. It's very heterogeneous and complex looking, and it's usually the last thing on your differential that the patient can present with. And one thing you should remember is that they can spontaneously rupture and could actually present with a hemoperitoneum and an acute abdomen coming from this complex mass in the spleen. So that's an overview for you of the pancreas and spleen by ultrasound. Thank you for your attention.
Hello, my name is William Middleton. I'm a professor of radiology at the Mallinckrodt Institute of Radiology at the Washington University in St. Louis. Today I'm going to present a lecture entitled Basic Aspects of Renal and Adrenal Ultrasound. Okay, so let's start with the normal characteristics of the kidney. Normal renal size centers at about 11 centimeters, plus or minus 2 centimeters, so the range is from about 9 to 13 centimeters. The echogenicity is compared to the liver on the right and the spleen on the left, and the right kidney should be equal or slightly less echogenic than the liver. The left kidney should be significantly less echogenic than the spleen. The renal parenchyma can be divided into the renal cortex and the pyramids are slightly less echogenic than the cortex, although you don't always see the pyramids. Notice on the image in the upper right-hand corner, that's a high-resolution view of a renal transplant, and you can see the location of the hypoechoic pyramids with respect to the slightly urine-distended calyces. The renal sinus is composed of fat and fibrous tissue, as well as the vessels and lymphatics, and it is hyperechoic and is centered in the center portion of the kidney. And then the outer margin of the kidney should be smooth. Now, the most common indication for renal sonography is in patients with acute renal failure to exclude hydronephrosis. Now, in the general population, the yield of finding hydronephrosis in this clinical situation is only about 1%. And unfortunately, false positives are relatively frequent. So even when patients don't have renal obstruction, mild hydronephrosis is seen. Now, the yield of sonography increases significantly if you only look at high-risk patients. And those are patients that are postoperative from abdominal surgery, have a history or physical examination findings consistent with a pelvic mass, have a history of kidney stones, etc. The diagnosis of hydronephrosis is made when there is anechoic fluid separating the renal sinus. In almost all situations, the renal collecting system will be displayed as several dilated infundibuli that are connecting to the renal pelvis centrally and connecting to renal calyces within the periphery of the kidney. And this should be seen on both transverse and on longitudinal planes. If you only see it on the longitudinal plane, but not on the transverse plane, it's probably not real. Hydronephrosis can be graded in several categories. Grade 0 is considered normal. Grade 1 is where the collecting system is just barely distended and barely abnormal, but the kidney is otherwise within normal limits. Grade 2 is a collecting system that's clearly abnormal, but the surrounding renal cortex is well preserved. Grade 3 is when the collecting system is clearly abnormal and dilated and the cortex is thinned. Now, hydronephrosis most of the time is due to obstruction, but that's not always the case. You can have a patient that has hydronephrosis, but the kidney is not obstructed. And unfortunately, the corollary is also true. You can have obstruction without having hydronephrosis. And there's a couple of ways to sort this out, or at least to help to sort this out. One is to check arterial blood flow by measuring resistive indices in the intrarenal arteries. If the resistive index is unilaterally elevated on the side of suspicion, then obstruction is likely. And the cutoff value for an elevated resistive index is 0.7, or asymmetry between the two sides of greater than 0.1. If the resistive indices are elevated bilaterally, that doesn't help you in looking at the suspected side of obstruction. And if the resistive indices are normal, that also doesn't help you in either excluding or making the diagnosis of obstruction. This is an example here that's being displayed where the grayscale image shows clear-cut hydronephrosis and dilatation of the proximal ureter. When you look at the resistive index of the questionable kidney, it's 0.76, and when compared to the contralateral kidney, which was 0.60. So clearly there's asymmetry in the resistive indices, and the resistive index on the right side is abnormal, and this was a kidney that was obstructed by a ureteral stone. Now, another way to get indirect evidence about the presence or absence of obstruction is to look at the flow of urine out of the ureters and into the bladder. If the ureteral jets are absent on one side, that means that side is likely obstructed. If there is a low-level continuous flow of urine out of the one side, then that also likely indicates obstruction. Now, the advantage that ureteral jets have over resistive index measurements is that they're affected immediately when obstruction occurs, and they resolve immediately when obstruction is relieved. The disadvantage is that you have to scan through the bladder for 5 minutes in order to make sure that the ureteral jets are clearly absent. And you also have to have a difference in the density of the urine that's exiting the ureter and the urine that's residing within the urinary bladder. So here's another example where you can see mild separation, very mild hydronephrosis in that longitudinal view of the kidney. When you look at the resistive indices, the right kidney had a resistive index of 0.71, the left had a RI of 0.57. So that would indicate that that kidney, although only showing mild hydronephrosis, probably is obstruction. When we looked at the urinary bladder, we saw that there was a detectable ureteral jet coming from the left ureteral orifice. Over a span of 5 minutes, we never saw a jet from the left, and that also suspects or makes you suspicious of obstruction. And very close analysis of that distal ureteral orifice showed a stone in that distal ureter. Now let's move on from obstruction and talk about kidney masses. The most common kidney mass is a simple cyst, the frequency of which increases with age, and by the time you reach 50 years, you have about a 50% chance of having a kidney cyst. Ultrasound is clearly the most accurate way of evaluating cystic lesions in the kidney, and it's especially useful when an indeterminate mass is seen on a CT or MR or a urogram where a cyst is highly suspected. The ultrasound criteria for diagnosing a simple cyst is the lumen should be anechoic, the back wall should be well defined, there should be posterior acoustic enhancement, and there should be no measurable wall, all of which are satisfied on the image displayed. Now, what can look like a cyst but not actually be a cyst? There's a number of things. Lymphoma is a solid tumor, but unfortunately it can look like a cyst because it's very homogeneous and generates few reflections. Fortunately, this doesn't happen very often, but this is an example of anechoic lymphoma. Calyceal diverticuli can mimic cysts. Arteriovenous fistulas can mimic cysts, and aneurysms and pseudoaneurysms can mimic cysts. This is a pseudoaneurysm that looks very much like a simple cyst, but on Doppler analysis, you can see that it has readily detectable internal blood flow. Now, what about cysts that aren't simple, in particular cysts that are hemorrhagic? Well, initially, when a cyst undergoes hemorrhage, it will have a solid appearance as shown here. Often will be heterogeneous, but will appear solid. Now, over time, that cyst and the clot within the cyst starts to lyse, and the cyst becomes more complex, evolving into a lesion that may be cystic with solid elements or cystic with thick septations. Now, eventually, the cyst will, a hemorrhagic cyst will completely liquefy and may have diffuse low-level echoes, as shown in this image, or may have a fluid cellular layer, as shown in this image. But if you wait long enough, and this may take a matter of several weeks or months, cysts will usually convert back to a simple appearance. Now, in general, we think about cysts as occurring in the cortex, but there is a subpopulation of cysts that occur in the peripelvic region. These are felt to be lymphatic in origin. They're usually solitary, but it's not uncommon for them to be multiple, as in this example. And they can be bilateral. When they become quite numerous, they can simulate hydro, as we see in these two examples. The difference between multiple peripelvic cysts and hydronephrosis is that with hydronephrosis, you can almost always see a distended pelvis extending continuously into an upper and lower pole infundibulum and many times into a mid-pole infundibulum. And with peripelvic cysts, you see separate cystic structures that do not communicate. Polycystic disease is a disease that affects the kidneys more than any other organ, although the liver is often affected. The pancreas is very rarely, but occasionally affected. And you can get cystic lesions in the vasculature of the CNS, in particular cerebral aneurysms. Up to 10% of patients that have end-stage renal disease in North America and Europe have this because of polycystic disease. Survival is approximately 10 years on average if it's untreated. By the time patients reach the age of 60, they will usually have renal failure. It's an autosomal dominant disease, but up to 50% of patients will not have affected family members, either because of variable expression of the gene or due to spontaneous mutation. So don't be surprised if you see this on a sonogram and there's no history of family disease. Type 1 polycystic disease is the most common, and it presents earlier and is more severe than type 2 and is easier to diagnose. The signs and symptoms of polycystic disease are listed there on the left. When you're trying to make the diagnosis in a patient at risk, i.e. a patient who has an affected family member, the criteria are below the age of 30, you have to see 2 cysts in one kidney or 1 cyst in each kidney. Between the age of 30 and 60 years, you have to see at least 2 cysts in each kidney. And over the age of 60, you need to see at least 4 cysts in each kidney. Now realize these criteria will only be applicable to patients who are at risk, patients who have affected family members. If you applied these criteria to the general population, you'd be diagnosing polycystic disease much too frequently. And these are some various examples of polycystic disease and various stages of severity. Because there are so many cysts in patients with polycystic disease, it is not uncommon to get crystalline deposits within the cysts. And when that happens, you'll see ring down artifacts such as this, it's also not uncommon to have cysts that have hemorrhage. So you'll see cysts that look solid and will ultimately go through the evolution that I described earlier. But polycystic disease does not have an increased risk of cancer, so these solid appearing lesions are almost always hemorrhagic cysts and not tumors. Now, polycystic disease is different from acquired cystic disease. Acquired cystic disease occurs in dialysis patients and generally occurs in a high percentage that have been dialyzed for over 3 years. The cysts are variably sized and they almost always occur in small echogenic kidneys. This upper right-hand image shows multiple cysts in a kidney that measures only 7.6 centimeters in size. Now, if the cysts become very numerous, then the kidney may actually become enlarged, as we see in this lower left-hand image. And in those situations, it can be difficult to distinguish this condition from polycystic kidneys. Now, unlike polycystic kidneys, acquired cystic disease does have an increased risk of tumors, and if you see a solid appearing mass like this, you have to be very concerned about a renal cell carcinoma, as was the case in this particular patient. Another complication that these patients get is retroperitoneal hemorrhage. Von Hippel-Lindau disease is another abnormality that presents with abnormalities in multiple different organ systems, but in the kidneys it produces multiple bilateral cysts and multiple bilateral tumors. The tumors may be solid, as is seen in this example. They may be complex, as is seen here, or they can be predominantly cystic with little solid nodules, as is seen in this intraoperative scan. Now, we've kind of alluded to renal cell cancer that occurs in particular conditions. Let's just talk about renal cell cancer by itself. It's the most common solid renal mass. It accounts for 90% of all renal malignancies. Risk factors include advanced age, smoking, and as we mentioned, von Hippel-Lindau disease and dialysis. It's most often detected incidentally nowadays, and traditionally it has been treated with radical nephrectomy, although nowadays there's a big increase in the number of laparoscopic procedures that are being done and the number of partial nephrectomies and ablative therapies that are being performed for renal cell cancer. Sonographically, 50% of renal cell cancers are hyperechoic to the cortex. About 10% are similar to renal sinus fat. In other words, they're markedly hyperechoic to the cortex, and this is particularly common in small renal cell cancers. 30% are isoechoic, 10% are hypoechoic, 5% are predominantly cystic, although many renal cell cancers have some cystic components, and then 10% contain calcification. And here's a collage of various renal cell cancers. A hyperechoic cancer here that looks very similar to an angiomyolipoma, and we'll discuss that in a minute. A hyperechoic lesion that's just slightly more echogenic than the renal cortex. An isoechoic lesion, a hypoechoic lesion, a complex cystic lesion, and then a lesion that contains some stippled internal calcification. Now, one unique thing that renal cell carcinoma does is it will invade the renal vein, as we see here. Now, renal vein tumor thrombus differs from bland thrombus in that it has tumor vascularity to it. And many times, although not always, you'll be able to detect that internal vascularity on color Doppler or power Doppler techniques, as we see here. Now, eventually that renal vein thrombus may extend into the inferior vena cava, as we see in this transverse view, and it may extend well into the cava and sometimes even above the diaphragm and into the heart, as we see here. Transitional cell carcinoma is much less common than renal cell carcinoma, but it is the most common urothelial cancer. The rest of urothelial-based cancers are squamous cells. 10% of transitional cell cancers are metachronous or synchronous, and it occurs much more frequently in the bladder than the renal pelvis, and more often in the renal pelvis than in the ureter. Now, ultrasound is not sensitive in detecting transitional cell carcinoma in the kidney, ureter, or renal pelvis, better in the bladder. When it is seen, it's often seen as a solid mass centered in the renal sinus, or as shown in this image, focal eccentric urothelial thickening, seen here in the upper pole of this kidney, or thickening of the renal pelvis, as seen in this transverse view. Now, metastases also occur in the kidneys, and in fact, in autopsy series, they're seen in up to 20% of patients dying from cancer. but most of the time they're small and they're not imageable. When they can be seen, they're often infiltrative, and they're frequently and almost always solid. They can be single, multiple, unilateral, or bilateral. So the appearance, unfortunately, overlaps with that of primary renal cell cancer. So in a patient that has an extrarenal cancer, when you see a renal mass, you have to consider metastases. And since metastases will not require nephrectomy, and renal cell cancer will require nephrectomy, biopsies are appropriate in this situation. These are examples of renal cell metastases, a small lesion with a hyperechoic halo on the left, and an isoechoic lesion that was seen really only on Doppler techniques as an area of decreased vascularity in the kidney. Lymphoma also affects the kidney, usually in the setting of widespread disease elsewhere in the body. Non-Hodgkin's disease is much more common in the kidney than Hodgkin's disease. It's very rarely symptomatic. On sonography, it typically appears as a solid, hypoechoic, multifocal bilateral process. Less often, it's unifocal and unilateral, or diffuse and infiltrative. As we mentioned earlier, it rarely is anechoic and can simulate a cyst. And one unique thing about lymphoma is that it can infiltrate the perinephric region, and in those situations, it also looks very hypoechoic and can simulate perinephric fluid. Again, since lymphoma does not require a nephrectomy, and it overlaps in its appearance with renal cell cancer, if you are faced with that differential diagnosis, it is appropriate to do a biopsy to distinguish those two. These are different examples of lymphoma. This is an enlarged kidney that is just slightly lumpy, bumpy, although it's hard to discern discrete lesions. This is a lesion with multiple hypoechoic masses. This is a lesion with a solitary unilateral isoechoic mass. And then here's another patient that has several lesions that are anechoic and look at least somewhat like renal cysts. And these are 4 different examples of perinephric infiltration of lymphoma that look very similar to perinephric fluid collections. So just keep that in mind when you're faced with that appearance. Angiomyolipoma is a benign renal tumor that's composed of vessels, muscle, and fat. It's the most common benign tumor. It tends to occur in middle-aged women and in patients with tuberous sclerosis. It has no malignant potential, so if the diagnosis can be made reliably, the patient does not have to have surgery unless the tumor gets to be big. And beyond 4 centimeters in diameter, these tumors tend to bleed, and sometimes they'll be removed just prophylactically to avoid bleeding complications. 80% of angiomyolipomas are homogeneous and very echogenic. 20 to 30% will attenuate the sound beam, and that's another thing that's unique to, or almost unique to, angiomyolipomas. Our approach to suspected angiomyolipomas is to do periodic ultrasound follow-up if they're less than 1 centimeter, and to do CT or MRI if they're larger. CT and MRI are pretty reliable in confirming the presence of fat in small or in larger angiomyolipomas. It's more difficult with the smaller lesions. And here's a typical angiomyolipoma. You can see a very echogenic solid mass in the cortex of the kidney. Now on this conventional view, we don't see any sound attenuation from that lesion, but when you look with a high resolution linear array, as shown on the right, you can see some attenuation of the sound deep to that lesion. Oncocytomas are another benign renal neoplasm that account for about 5% of all renal tumors. The appearance overlaps that with renal cell carcinoma, and as you can see on the 2 images on the right, those are very nonspecific solid renal masses that look for all the world like renal cell carcinomas, but when these were resected, they were found to be oncocytomas. Now occasionally you'll see a central scar on a contrast-enhanced CT or MRI, or if you do contrast ultrasound, you can see it on a contrast ultrasound as well. But in general, these lesions can't be distinguished from renal cell carcinoma, so they're treated surgically just like renal cells are. The last tumor that I'll discuss is a multilocular cystic nephroma. This also is a benign tumor that tends to occur in young boys and older women. They appear as masses with multiple variable-sized, non-communicating cystic elements, as shown on the 2 examples on the right. Unfortunately, the appearance of multilocular cystic nephroma overlaps with the appearance of cystic renal cell carcinoma and Wilms tumors. So these lesions are also treated surgically, just like renal cells, because we can't tell the difference. Now, there are a few things that are non-neoplastic that can appear mass-like on sonography, and one is pyelonephritis. Pyelonephritis typically, if it doesn't have a normal ultrasound appearance, will appear as renal enlargement with focal cortical changes. Now, these are often wedge-shaped, not always. They can be either hyperechoic or hypoechoic, and unlike other organs where inflammatory lesions are hypervascular, in the kidney, infection causes decreased vascularity. Urothelial thickening can also be a sign of pyelonephritis, but occasionally you'll get focal masses, as we see in the two images on the right, that will look for all the world like a renal neoplasm, but will turn out to be inflammatory in nature. And those often have to be correlated clinically and sometimes need to be biopsied to prove that they truly are inflammatory. Renal abscesses are another inflammatory condition that can simulate the appearance of a cystic renal cell carcinoma. They, like renal cell carcinoma, can appear as complex cystic masses, and to make the diagnosis you really need to correlate with the clinical history and again aspirate the lesion and see what you get for further evaluation. So just in summary, renal masses often have characteristic ultrasound features, but like all modalities, there's a fair amount of overlap in the ultrasound appearance of both benign and malignant and non-neoplastic renal masses. So ultrasound should be viewed as complementary to CT and MR when evaluating renal masses, and it's especially valuable in evaluating cystic lesions. Now, I also need to discuss renal stones. We no longer do ultrasound as often for evaluating patients with suspected stones, but you can see stones with sonography, and you should become familiar with the appearance. They really appear similar regardless of the type of stone. Whether or not you see them depends on how large they are. And stones that are 5 millimeters or smaller get progressively harder to see. On the other hand, stones that are 5 millimeters or larger are seen fairly reliably. And they all appear as hyperechoic lesions, most of the time with an associated shadow, and oftentimes with a twinkle artifact. So this is your hyperechoic lesion with a shadow. This is a large staghorn calculus that appears hyperechoic with shadowing. And here's a twinkle artifact on color Doppler seen from a very small stone that was difficult to detect with grayscale. Now, realize that renal stones are more difficult to detect than gallstones. Gallstones, ultrasound is fantastic. Renal stones, ultrasound is much more limited. That's the reason that we do non-contrast CT to identify renal stones nowadays. Now, another type of calcification in the kidney is medullary nephrocalcinosis. This occurs most frequently in patients with hyperparathyroidism, renal tubular acidosis, and medullary sponge disease. This causes increased echogenicity to the renal pyramids, as you see in the first two images below. And it tends to start in the periphery of the pyramids and then progress into the central aspects of the pyramids. As the calcification becomes more progressive, you'll start to see shadowing associated with these hyperechoic pyramids, as you see on the third image. Now, ultrasound is very sensitive in detecting medullary nephrocalcinosis, which is a little strange given that it's got limitations in detecting renal stones. But medullary nephrocalcinosis is seen very easily with sonography, probably as well or perhaps even a little bit better than seen on CT. Okay, now I want to shift gears a little bit and talk about renal Doppler, and first talk about renal arterial Doppler, specifically renal arterial Doppler for the detection of renal artery stenosis. There's a variety of criteria that have been established. These are the ones that I rely on most heavily. One is on color Doppler imaging, detection of focal flow abnormalities that include focal aliasing of the Doppler signal and focal vibration of the perivascular tissues around the stenotic site. Measurement of the waveform velocities is also very helpful, and the cutoff value for renal artery stenosis is a peak systolic velocity in the main renal artery greater than 200 centimeters per second, or an elevation of the ratio between the renal artery and the aorta, the renal to aortic ratio, or RAR, greater than 3.5. And here's some examples. In the upper left is an example of focal aliasing, where you see this abrupt color conversion in the proximal left renal artery. Upper right, you see this focal tissue vibration manifests as extravascular colored dots, equally distributed between red and blue in the areas around the right renal artery. The lower left is a patient with elevated peak systolic velocity of 327 centimeters per second, secondary to stenosis. And in the lower right is a patient that has a borderline elevated peak systolic velocity in the proximal right renal artery of 213 centimeters per second. But when you compare that to the velocity in the aorta, you see that the renal to aortic ratio is slightly greater than 5, meaning that this is very likely to be a significant renal artery stenosis. Now, there are limitations in renal arterial Doppler, and these include poor visibility of the artery secondary to a variety of causes, but most frequently obesity, bowel gas, and shortness of breath. Sometimes the Doppler angle is very limited, and you can't measure velocities at a Doppler angle greater than 60 degrees. Extensive arterial calcification can cause enough shadowing that you just can't evaluate certain segments of the renal artery. Cardiac arrhythmias can affect your Doppler waveform. Fibromuscular dysplasia and distal atherosclerotic lesions are more difficult to detect because they're not in the proximal renal artery. Accessory renal arteries are common and difficult to detect with sonography. Even in the best patients, examination times are relatively lengthy, and it's important to remember that even at the best that we can do, we don't detect stenoses less than 60% diameter narrowing. We don't even try to. We're really focusing on detecting stenoses that are significant, and those are the ones that are greater than 60 to 70% narrowing. So how do we get around some of these limitations in looking at the main renal arteries? Well, one is to look at the intrarenal arteries. Significant stenosis in the proximal main renal artery will cause parvus tardus effects in the distal renal arteries, in the arteries within the kidney themselves. And parvus tardus refers to decreased systolic amplitude and slowed systolic acceleration. And there's a variety of ways that we can identify parvus tardus effects. The schematic that's showing in the upper right-hand corner shows a normal renal arterial Doppler with a very rapid systolic upstroke and a sharp early systolic peak. With proximal stenosis, the distal waveforms start to look like this. You lose that early systolic peak, and the early systolic acceleration starts to decrease. And then with progressive stenosis, the systolic peak gets progressively blunted, the acceleration diminishes, and that early systolic peak gets very rounded. So what do we use to quantify this? Well, in addition to looking for loss of that early sharp systolic peak, we can quantify it by measuring the early systolic acceleration. And that's done by looking at the upslope of early systole. Now, in the image in the upper right-hand corner from the left kidney, you can see that the slope, which is the early systolic acceleration, is 92 centimeters per second squared. That's extremely low compared to the right kidney, where it's 1,806 centimeters per second squared, which is much faster. Now, you don't really need to measure the slope in this case, because you can just look at the waveforms and see how different the systolic acceleration is in the left kidney compared to the right kidney. But in borderline cases, measurement of that early systolic acceleration can be handy. Now, what are the limitations of intrarenal arterial analysis? Well, many people, including myself, feel that it's less sensitive to borderline stenosis than main renal artery analysis. It does not distinguish occlusion with collaterals from a high-grade stenosis. It doesn't localize the stenosis to proximal, mid, or distal renal artery. And in fact, you can get changes if the stenosis is in the aorta or in the aortic valve. Sometimes the cursor location for measuring the early systolic acceleration is questionable, and all of it is dependent on having compliant vessels, which is not always the case, especially in elderly patients with significant intrarenal atherosclerosis. Okay, now let's change gears and talk about renal vein thrombosis. This is something else that we sometimes try to detect with renal Doppler. Realize that this requires a combination of both grayscale findings and Doppler findings. You can miss it on grayscale if you just rely on that. You can miss it on color Doppler if you just rely on that. Now in the right renal vein, we have a fairly high sensitivity because it's a short vessel and you've got that nice big liver to scan through. The left renal vein sensitivity is lower because the vein is longer, there's more of it to evaluate, and you don't have as good an acoustic window. It's important to realize that with even total renal vein thrombosis, it still is not uncommon to have venous flow in the hilum of the kidney, so you can't just take views of the kidney, see venous flow in the kidney, and exclude the diagnosis. You really need to see the entire renal vein to get a full examination. And also realize that arterial flow into the kidney is usually not affected or only minimally affected in native kidneys that have renal vein thrombosis. Now on the other hand, in renal transplants, the arterial flow is affected to a much larger degree, and you get that to and fro pattern. So here's an example where you can see renal vein thrombosis in the left renal vein of the native left kidney, both on grayscale and Doppler. And this image on the right is an example of a renal transplant with renal vein thrombosis where you can see that to and fro waveform pattern within the supplying renal artery. We use Doppler to diagnose pseudoaneurysms. Those occur secondary to trauma from biopsies, trauma from penetrating trauma from gunshot wounds or knife wounds, and occasionally from infection. They occur most commonly in renal transplants because renal transplants get biopsied more frequently than native kidneys. They can be a source of hematuria. As we mentioned earlier, they can appear as simple cysts, as we see here, but they'll have internal blood flow, as you see on the Doppler image. The to and fro pattern in the neck of a pseudoaneurysm that you commonly see in pseudoaneurysm in the groin is much more difficult to diagnose in renal pseudoaneurysms, but occasionally you can see it, as we see here. And remember that they can coexist with arteriovenous fistulas. Which brings us to arteriovenous fistulas. The etiology is similar to pseudoaneurysm. They typically are self-limiting, but they can cause persistent hematuria. Now, generally, there's no grayscale findings for AV fistulas, but on Doppler analysis, you'll see a prominent artery with high velocity and a low resistive index. So on this image obtained in diastole, you see one vessel heading into the lower pole and no vessels anyplace else. That's because there was some underlying renal parenchymal disease in this transplant kidney. In systole, you continue to see that one prominent artery heading to the lower pole. Now you see another artery heading to the mid-pole here, but look at the difference in color saturation. You can tell that that artery that's heading to the lower pole has a lot more blood flow in it, and that's confirmed when you do Doppler analysis to the artery that's supplying the fistula, gangbusters arterial flow and a lot of diastolic flow compared to the artery going to the rest of the renal cortex, which has much less flow. Now, in addition to differences in the arterial flow, you can see arterialization and disordered flow in the draining vein, and typically you'll see fairly extensive and dramatic tissue vibration around the area of the fistula. Well, that does it for the kidneys. I want to just briefly review the adrenal gland. We often ignore the adrenal gland when we're doing sonography of the abdomen, and that's probably appropriate because ultrasound is certainly not a mainline test for looking at the adrenal glands. The normal adrenal glands are difficult to evaluate, easier on the right side than the left side, but even on the right side it can be tough. These are some examples of normal adrenals on the right side. Typically you'll see them as just little linear hypoechoic bands of tissue between the liver and the crus of the diaphragm near the vena cava, and occasionally if you're lucky you'll see the Y-shaped appearance of the adrenal gland. Now, adrenal masses are also more difficult to detect than on CT, but in the right adrenal, masses, if you pay attention, can be seen with fair sensitivity. Much more difficult on the left side. Unfortunately, the sonographic appearance of masses is usually very nonspecific, and you have to rely on a combination of detection of mass on sonography and clinical history. Clinical history can be very helpful. But many times you need to get follow-up laboratory values and often will need to further evaluate these patients with CT or MRI. So just a few adrenal lesions that you can see with sonography. One is the adrenal cyst. Simple adrenal cysts are very uncommon, but they do get encountered occasionally. And you see this one here in the liver, which is a low attenuation lesion. Looks a lot like a cyst, could potentially be a low attenuation adrenal adenoma, but on sonography it clearly has appearance of a cyst. So those are usually pretty easy to diagnose. Adrenal adenomas, on the other hand, are very common tumors. They're usually non-functional. They're usually small. 3 centimeters is a reasonable number to remember. And they typically are solid and homogeneous. And these are 3 different examples of adrenal adenomas that have been seen on sonography. And they all have a fairly typical, although nonspecific appearance. Adrenal metastases are also relatively common. It's the 4th most common organ that develops metastatic disease. And on ultrasound, again, the appearance is nonspecific, but they're usually larger than adenomas, and they're often heterogeneous in appearance, as we see in this transverse and longitudinal view of a patient with metastasis from lung cancer. Adrenal pheochromocytomas are the 10% tumor. That's because 10% are malignant, 10% are extraadrenal, 10% are bilateral, and 10% occur in patients with multiple endocrine neoplasia syndromes. They typically present with hypertension, headaches, tachycardia, anxiety, palpitations. They can be seen with sonography, but again, they have a nonspecific appearance. They're usually solid, usually large, heterogeneous, and hypervascular, as we see in this example of a left adrenal adenoma in the left para-aortic region. Myelolipomas are a benign tumor that's usually asymptomatic. They contain hematopoietic elements and fatty elements. They're variable in size, but they usually contain some hyperechoic component because of the fatty elements within the lesion. And that's what we're seeing on these 2 examples of a patient with a relatively typical myelolipoma. So when you encounter a lesion like this, a CT scan or an MRI should be obtained to confirm the presence of fat. And then the final adrenal lesion is the adrenal cortical carcinoma. These are rare. They usually occur in the elderly. They're usually large, and they usually present with symptoms of some sort. 10% will be hyperfunctioning, and usually that produces Cushing syndrome. On imaging, they often will have necrotic areas, will have hemorrhagic areas, and calcification is not uncommon. And like renal cell cancers, they can invade the adrenal vein and then go on into the inferior vena cava. Here's an example of a large mass that has invaded the inferior vena cava, consistent with an adrenal cortical carcinoma. So that concludes this whirlwind tour of the kidneys and the adrenal glands. Please recognize that this is a very basic introductory review of the topic. If you really want to start doing renal and adrenal sonography and do it well, I'd advise you to go and review some chapters that are specifically focused on these 2 areas. Thank you very much.